A very good morning to everyone present here. Welcome to the second day of the 7th Walter E. Dandy India Neurosurgical Educational Course. We'll be opening with a session on pediatric neurosurgery. Can I please invite Professor Dattaria Mazumdar to give a presentation on tilo-velo-tonsillar approach to midline posterior fossa tumors? Thank you, sir.
Good morning, and thank you, Dr. Ghosh and Dr. Pandey and the Dandy team for giving us an opportunity to share our experience, and most of them meet and greet. So I'm the opening batsman. So can we have the presentation? So I'm going to talk on telovelar approach to a posterior fossa tumor, and the commonest tumor that we see in the posterior fossa, as you know, are pilocytic astrocytomas, medulloblastomas, ependymomas, have their own characteristics and behavior. And medulloblastoma is the single most tumor which has a good correlation with survival as regards surgical excision and adjuvant therapy, as you know, craniospinal irradiation. So what present? Okay. So my time is not ticking, so I can. No, it's okay. Some issues. No, yeah. Yeah, I know. And because of the online. Recorded talks is better.
Segments.
Morning, doctor, while you're waiting.
Yeah. Oh, Sandeep. Good morning, Sandeep. How are you?
Fine, thank you.
Yeah, thank you. Thank you. So let me keep going now. And so I just describe a telovelar approach for a large medulloblastoma. And this is the index presentation that we had done. So way back when we had a last series, so I thought that what was our experience before or around the microscopes when they came, and after what the advances in microscopic surgery, anesthesia, post-op care, how it has made an impact. And as you know, posterior fossa surgery, and at least in KEM, it was that the residents used to get a lot of medulloblastomas. We had about 50 to 60 medulloblastomas per year at that time. And the residency training started slowly with medulloblastomas, obviously under supervision. So I had this thought that after 2000 and before 2000, what was the difference? Before 2000, we used to have a lot of issues of, patients being taken up. We used to take the patients in emergency also. So a lot of patients, we used to have a lot of morbidity and, patients suddenly dying early morning and all those stuff, which we have this. So then what happened after 2000? So as you proceed in your experience, you definitely get better. But then there are certain parameters I thought that which make a difference. So one was microscope, another was anesthesia. And third was we do surgeries in sitting position, although sitting position is not favored everywhere. But I think it's a very good position if you have a good setup with good anesthesia facilities, your anesthetist is in tune with you, and you know exactly what to do. Then if somebody is comfortable with sitting position, I have no problems that somebody wants to learn or continue sitting position. It is quite good. But yes, prone position, semi-sitting and all, whatever is, I'm not dogmatic about that. But I found out certain difference that after our surgical techniques with the microscope and the neuroanesthesia in tune became better, and we know how to resect, how much to resect, and shorten the surgical time, it definitely made a difference in our outcome. So the requirement for shunt, the morbidity became less, how to handle the cerebellum, retractor, less retractor, no retractor, and the technique of your suction, controlled suction, and its proximity to the brainstem, to the vessels, pica vessels, the tonsillar branch, all that thing. Sometimes we used to get away with that with the pica. No, sometimes you used to get injured, a revel, the tumor is engulfed. But then sometimes it was devastating. Patient used to land up with brainstem ischemia, brainstem. So maybe that was the predominant vessel which was supplying the brainstem. But certainly we then decided that, found out that avoiding any injury to the vessel, avoiding any injury to the critical neurostructures around is the best way. And at the same time, remove the tumor. And medulloblastomas certainly are, some soft, suckable tumors. So sometimes, it's a good learning experience. So this was our experience. And obviously, these are the salient features why I took medulloblastoma, because of its distinct phenotype, and it is different from the rest of the tumors because it has got a good prognosis if you treat the patient properly, and the patients live long with craniospinal irradiation being the most important factor in the entire this thing. Another thing was that if you want to give benefit of this adjuvant treatment to the patient should be in a better condition to undergo this therapy. So that is also onus on us. That if we try to go and do an extended resection or give morbidity, then these patients do not reach the radiotherapy adjuvant therapies center, and then the thing is lost. So that also is bears on the mind. So the surgical considerations which we took into consideration was all this. So I think position of surgery I've talked about, hydrocephalus, the tumor characteristics, and molecular typing. Now that has made a lot of impact on the medulloblastoma surgery, as you know, the SHH, the WINT, and the group 3 and the group 4. And usually we receive this kind of tumors. So the tumors were very large, more than 4 centimeters, patient coming with blindness, secondary optic atrophy. And obviously, because of all this tumor and the hydrocephalus, patients do have cognitive and intellectual impairment, which may persist in the postoperative period also. So I'm not going to go in detail. Everybody knows this. So you know the WINT has the best prognosis. And if you see on the right side, WINT tumors being the best prognosis arise from the lateral recess. And there is the problem where you can do an extended surgery and damage the critical neurovascular structure. So if we do a radical excision and leave some part of the tumor, that adjuvant therapy takes care. So the surgery should not be a total. You should not you should aim for a total resection. But if you cannot, then it is safer to leave the tumor behind. In contrast, SHS, they are hemispheric. So you have to remove the tumor completely. It can be removed because you have surrounding cerebellum only to take care. Group 3 and group 4, the tumors are large, midline. Sometimes they enhance, sometimes they don't enhance. Even whatever you do to these tumors, ultimately, because of the molecular characteristics of these tumors do not do well in the long run. So we have to concentrate on WINT tumors. Now there are medulloblastoma subtyped into another 12 categories. So I'm not going to go into the detail. So if you can see here, the WINT tumor is on the first left. And you can see on the right, so I've just labeled WINT, SHH, group 3 and group 4. So radiogenomics also plays a very important role in understanding the biology of these tumors, and it has an impact on the excision, the strategy also of the tumors. And this is how we did the nomogram coupled with Tata Memorial Hospital. We studied the molecular characteristics and the radiology of the tumor and came to this conclusion that we can tailor our surgery according to the characteristics of the tumor. So our goal of surgery is cytoreduction, tissue diagnosis, and re-establishing the CSF pathways. As I told, we hardly do shunts, and the goal is safe maximal resection of the tumor. The TLOC, normally we use the inferior vermian approach. So sometimes superior vermis is, as you saw, we cannot tamper with the superior vermis. Inferior vermis, okay, we go along and but the incidence of cerebral mutism is very high. So this telovelar approach is absolutely a very novel approach. It has to be understood and it has to be practiced. And the tumor is the large tumors create a natural corridor for you to enter into the telovelar space. So telochoroidea and inferior medullary velum, they form the lower half of the fourth ventricle. And as you know, you retract the lower vermis up and you enter into the telovelar area and the fourth ventricle. So as I just know, you need to understand the tumor. The tumors are usually, if they are soft suckable, they are hyperintense on T2. If they are little bit firm, they are hypointense on T2. We have to do the spinal screening and everything. So straight away, I will go to we use adjuncts can be used for preservation of the neurovascular structures, facial nerve monitoring, lower cranial nerves, BERA, SSCP, and everything. So I will straight away go to the videos. In very infants also we can use sitting position. This is what we have this chair as the child as in few months, 6 months also we can use this chair and put the patient in sitting position. And I would go straight away to the video because we have less time. So if you see this corridor, there is no retractor, patient is in sitting position, and you can rip or dissect the arachnoid, and you can see the tonsils, and you create a midline approach, which is absolutely in the midline. So you don't have to, because the tumor creates a downward pressure, the thing may not be evident. So you have to find the space. And you can see either you can use retractors or so we use this suction. We use a controlled suction or a dissector in the right hand and the bayonet forceps in the left hand. You require very, very few instruments, very minimal coagulation, almost no coagulation. And you can see you can just create a space. And if you see the direction of the suction that I use is always up towards the aqueduct. We never use it down straight or inferiorly, because that will tend to injure the brainstem or the vessels. So the suction direction is always up, and you can see that slowly, without any use of any retractor, going in. And I'm finding the tumor. You can see the tumor just once you create a corridor and you retract the tonsils, you see the inferior medullary velum, you see the telochoroidea, but here the tumor mass displaces around. So once you are you enter the tumor, quickly you can, as you see here, you can quickly sort of decompress the tumor. First is internal decompression and reduce the pressure. And if the tumor is soft suckable, which it is usually, then you can create more space. You can see that, and quickly, the best thing is to get the CSF down, so I sometimes use a small retractor just to keep it in space. And you can see that the entire tumor can come out. As you see, the vermis is pushed up. So you can see that I go on the superior pole of the tumor, never inferior. And whenever I see this thing, I try to see the aqueduct as early as possible. And then come from, is there a way I can fast forward this? I can fast forward this. There's no bar here. Oh, okay. Okay. If you see, the whole tumor then comes out from the superior. You see, I have not gone to the inferior pole of the tumor. So this is a different, whatever is the standard procedure for neuroblastoma surgery. If you see, I'm doing exactly the opposite. People will go from down, see the inferior cerebral peduncles go up from this thing. So if you can see that the tumor is out from there, and usually you can do a craniotomy or you can do this thing. So suddenly when I see the aqueduct, I usually, because the hydrocephalus is there, air can get sucked in. So the moment I open the aqueduct, I just put a piece of small gel foam there. Gel foam swells up, blocks the aqueduct, prevents the air from going inside. Not use nitrous. So that prevents the decreases the pneumocephalus to a significant extent. And you can see here pneumoventricle can happen in spite of this. You can see that the sliver of tumor has remained on the brainstem. This I won't try to remove because that would create morbidity. You can see that nowadays you can use endoscope also in that. So you can maneuver the endoscope and see the obex, see the foramen of Magendie, see the foramen of Luschka, choroid plexus, and you can get 0 degree, 30 degrees, 70 degrees view as well. And you can have to see the telovelar junction, which is the attachment of the tela choroidea to the inferior margin of the inferior medullary velum. And you can have a 360 degrees view of the just from the telovelar junction. You can see the entire cerebral peduncle, superior, middle, inferior, choroid plexus, and you can remove the tumor as well. So you can, as an adjunct also, you can see whether endoscopic assisted or exoscope assisted surgery will also enhance your telovelar approach. So I think telovelar approach is definitely useful. You do not encountering any structure. The tumor also helps you to keep the structures away. But where you are near the tumor in vessel or a tumor brainstem interface or the tumor peduncular interface, you have to be very careful. In medulloblastomas, you can certainly leave certain amount of tumor which is infiltrated, but by and large, your mutism goes down significantly. And the other advantages are also there because cerebral mutism can be very devastating. It can sometimes residual 5 to 10% patients have got this arthria lifelong. So you cannot take cerebral mutism lightly. So telovelar approach is directly related to the reducing the incidence of cerebral mutism compared with other approaches. Thank you. Any questions, or I will?
We have, sir, we have a panel discussion at the end. Thank you. Quick announcement before the next talk goes. Participants for the anastomosis workshop, Dr. Navajit Mani, Dr. S. Aditya Shivaram, Dr. Akshay Patidar, Dr. M. Sri Patas, Dr. Vikatoli Samuel Sorhi, Dr. Soumya Ranjan Das, Dr. R. Ganesh Kumar, Dr. Abhigyan Burkotoki, Dr. C. Jayaprakash, Dr. Nikunj Vardani are requested to go attend the workshop in the other room. Moving on, I'd like to mention that the next talk will be a recorded lecture by Professor Deepak Gupta on Chiari decompression indications and techniques.
Good morning. At the outset, I want to thank Dr. Siddharth Ghosh and his team for inviting me for this 7th Walter Andy educational course. Due to unprecedented causes and my personal illness, I'm not here with you. So that's why I'm sending you my recorded lecture. Well, in the next few minutes, I'll be sharing about my experience on Chiari decompression, indications, and techniques. I'm sure of all the various neurosurgical illnesses that we treat routinely, Chiari is malformation or the deformation so-called is one such problem wherein there are many unanswered questions. Well, majority of the neurosurgeons, they do agree upon one point that most of the asymptomatic Chiari, they can be observed. In fact, over 60% of this carry are incidental in finding, and up to 90% can be managed by conservative treatment. Now, in the management, there are two important groups. One are the decompressors, those who believe in decompression of the foramen magnum, along with some augmented procedures. And second is the group who believe in fixing the craniocervical junction. In the next few minutes, I'll be primarily talking about the decompressors. Now, the question comes who, when, and how to operate. Well, the answer is very simple. The patients who are having symptomatic carry with pointed tonsils or descending tonsils for more than 5 millimeters below the foramen magnum, or with medullary kink. In fact, the position of the obex below the foramen magnum is taken as one sensitive parameter in large group of patients in the recent publications. So these patients, they 100% of these cases, they merit surgery. And of course, the headache is very classical. This is more of an occipital headache and less of a frontal, and it is classically precipitated by the valsalva or the cupping menopause. However, in children and neonates, they can be very atypical presentations. They can present with irritability, excessive crying, nighttime waking up, oropharyngeal symptoms, and gait unsteadiness, and sometimes they can have some spinal deformities. The asymptomatic patients, but with significant syringomelia, 80% of these cases, they do merit surgery. If I am to ask when should we operate carry, well, I don't have any answer because there is no literature. But I personally believe early surgery prevents neurological deficits. Then we are often left with thinking how to operate this patient. Now, the carry 1 malformation or the deformation group, the classical approach recommended is foramen magnum decompression with some dural procedures, which I'll be talking in the next few slides. The carry 2 malformation patients, there is hardly any debate. The selection criteria are very discrete, and one goes for wide decompression plus duroplasty in such cases. As I said about these incidentally discovered carry malformations, 90% of these cases can be conservatively managed, and one needs to refer to these patients to the neurology colleague for the detailed evaluation, for evaluation of the entire spine, the senior flow study. And in case everything is normal, then of course they need to be on periodic surveillance with the MRI as per the patient clinical findings. Those with the small syrinx or with the medium or large syrinx, again, they need the evaluation, further evaluation, and they need neurosurgical consultation for possible decompressive surgery. Now, as I said about these surgical options, the decompressors, you have foramen magnum decompression. Classically, we do 3 by 3 centimeter wide foramen magnum decompression in the adults, and some people do 2.5 by 2.5 centimeter. In fact, the sideways, it has to be wide oblique, but not the superior inferior. So that's a basic which is there in all options. Along with that, in pediatric cases, without any syrinx, one can do standalone bony foramen magnum decompression. Many of the surgeons, they also talk about doing durotomies or the dural scorings, wherein only the outer layer of the dura or the outer of the dura is incised, leaving the arachnoid as intact. And the other group of people recommend doing a foramen magnum decompression with duroplasty. And then the more extensive can be doing this procedure with tonsillar coagulation and arachnoid debridement with obex plugging and duroplasty procedures. And of course, we have in the last decade, we have so-called fixers, those who believe more in doing C1, C2 fixations, and sometimes occipital-cervical fusions in this group of patients for various indications. To talk about the secondary carry patients, especially seen in the children with the craniosynostosis or those with the raised pressure, again, you have to address the primary pathology. I'll be touching upon it in the last few slides. Now, the conservative decompressors, I think the Italian group, and even the Shlomi Constantini, they firmly believe in this. In this, you do classical C1 and C2 laminectomy, and then you do a series of 6 oblique dural scorings in the outer layer of the dura with a diamond knife, and leaving the arachnoid intact. And in fact, they had very decent outcomes in their patients. However, the patients with the rapidly developing deficits with a Cobe angle of more than 35 degrees or tonsils below C2 or acquired query, this is something which is not recommended. Then there are radical decompressors who believe in the concept that there are some arachnoid wells. In fact, many of us have observed when we do a duotomy and open up, there's sometimes the fibrous band at the craniocervical junction, and sometimes these arachnoid veils which are plugging the opening to the opex and obstructing the CSF flow. And so the intradural exploration is recommended by them. Now, in patients of KRE1 with syrinx, there have been a large number of publications, especially in the pediatric age group, wherein they said there is no need to open the dura because the hypothesis is you don't see those arachnoid veils, which I just talked about so frequently. Adhesions are not so commonly seen, and syrinx pathogenesis is primarily due to the piston effect. So they just talk about doing either a bony decompression or with or without dural scorings. Now, the extended decompressors, they believe in that the carry is more of an arachnoid pathology. And again, when you do a kind of a with dural procedure, we have a low recurrence rate and favorable long-term outcomes. In fact, in this seminal publication, which was published in 2012 in Neurosurgery, with more than 25 years follow-up in 371 patients, they noted that duroplasty was done in almost 67% of the cases. And in fact, they found that the tissue glue does not decrease the CSF leak in their patients. But the dural procedures were recommended in large group of patients in their series. Now, again, to talk about the tonsillar resection of the syringe, it's quite controversial because the people who believe in doing tonsillar resection, they believe that it's more of a chronic compression, and most of the time, tonsils are atrophic and cloudy. And some people, they reserve it only for severe syrinx cases. In fact, way back in 1997, there was this publication which was first talked about the technique of tonsillar coagulation, which is basically kind of, we don't do any extra arachnoidal or intra-arachnoidal excision. It's purely subial coagulation and by using suction and adhesions to decompress the tonsils. And then we can also do the subial hitching of the tonsils to the overlying dura. Sometimes you can have your own share of problems. This was a young girl, a 16-year-old girl who came from Northeast with history of 2-year history of headache, which was reflected to medical treatment. And she had pointed low-lying tonsils. There was no low-lying withered core, and she had a carry type 1. No hydrocephalus was noted in her. And so we decided, because she to do a foramen magnum decompression with duroplasty. I noted the tonsils to be quite big than the preoperative radiology. So I went ahead and did the bilateral tonsillar subial coagulation and hitching. She broke up without any deficits. However, the post-operative MRI which we got it done showed incidental infarcts in the left cerebellum. She was asymptomatic though, and the follow-up at 6 months revealed the resolution and no findings. So if this kind of things can happen, maybe because some vasospasm or some stretching injury of the pica branches. Now, if you talk about the literature comparing the children versus the adults, I would say that the literature is more in favor of doing standalone foramen magnum decompression with durotomy procedures in children, and it is favoring more of decompression with duroplasty with tonsillar coagulation in the adult population. Now, there are some patients who have this C1, C2 joint normal, but carry malformation. And now, especially from India, Professor Atul Goyal and his team, they recommended very strongly that one needs to do a C1, C2 fixation because they believe that the tonsils are more of a air bags, and they believe that there is a difference between the demonstrated versus presumed instability. However, I believe that there are ethical issues in fixing C1, C2 junction in patients with normal C1, C2 joints. And in my practice, I always believe that one needs to do a dynamic studies to see for any instability and offer this intervention only to the group of patients where instability can be documented in the imaging study. In fact, this was a beautiful study carried out by the PGI Chandigarh group, wherein they compared the outcome in patients with C1, C2 normal joints with carry. There was no difference in the long-term outcome in those patients. And in this seminal paper, which came up with the SGPGI group also, they recommended that in patients with a normal C1, C2 joint with pure carry, one needs to offer just the posterior neuroplasty and augmentation procedures. And really, there is no benefit of doing a C1, C2 fusions. However, if patients have got crâniovertebral junction anomalies in the form of ADs or basilar invagination, one can offer C1, C2 fusions or occipital cervical fusion as per the need based. And sometimes people have also recommended anterior decompression with anterior C1, C2 stabilization to restore the entered ventral compression of the CSF hydrodynamics, and it has resulted in the improvement in the symptoms. So if you have a patient of carry with a raised pressure, I think one needs to take a stepwise approach. If there is a hydrocephalus, you need to do a CSF diversion. And sometimes these group of patients, they have got features of raised pressure. And if there is a causative factor like craniosynostosis, one can do a PCA, posterior calvar augmentation procedures, or ATV in this group of patients. However, if the ICP is normal and there is a strong suspicion, then and there's a carry, then only FMD alone suffices. So if you have a patient of carry with hydrocephalus, which one first and how? I think you should always treat the symptomatic side first. If the hydrocephalus is more symptomatic, treat the hydrocephalus first. And also there's a less risk of pseudomeningocele postoperatively if you treat the hydrocephalus first. I think the best way to treat hydrocephalus, I think endoscopic third ventriculostomy is the treatment of choice in majority of these cases, and it should be offered as a first treatment option in patients. There is some controversy, and people have been talking about the association of carry and tethered cord. I believe it's more of an association and less of a causation, though there have been mixed literature available on both the things. And so I, in my routine practice, usually do not detether spines, the low-lying tethered cords, unless and until there is a strong evidence of tethered cord in the patients with coexistent low-lying tonsils. There are some failures. Sometimes you have got failures, and you may have to do redo. In such cases, of course, people have talked about doing procedures like tonsillectomies, which was not done earlier in case. And sometimes the anterior decompression has also been recommended to improve the outcomes in this failure group. Very recently, we have this treatment guidelines, especially in the children with the carry type 1. And if you see it very carefully, in asymptomatic children with incidentally discovered isolated carry 1 and no syrinx, surgery is not indicated. If you have asymptomatic children with incidentally discovered CM1, carry 1 with syringomyelia, surgery is indicated. Syringe size is more than 5 to 8 millimeter. And thus, if there is a smaller syringe and it is increasing in size, of course, it needs surgery. The most important thing to be noted is that when you are recommending just a standalone bony decompression, you need to take the family into confidence because there is a definite risk of reoperation in this group of patients. And if the parents are willing to take that risk, one can offer standalone foramen magnum decompression. Otherwise, in children with syringomyelia, bony decompression with duroplasty is always preferable. And similarly, we had got adult guidelines also. However, most of the evidence is leveled class 2 and class 3 in posterior decompression with or without duroplasty and tonsillar resection. This is my very small series of 47 cases. And in the last 29 cases, I had one cephalic immunocompression. This was a very interesting case of a child who had CSF leak, and my resident injected this local anesthesia, and child had an arrest while the switching was going on. And it is to be noted for the young resident that this xylocaine, it contains a preservative called methyl paraben, which can cause an anaphylactic reaction. The child was actually immediately intubated, revived, and extubated within 2 hours subsequently, and then discharged the next day. So how you do it? The patient surgery is done classically in the prone position, in the military truck position. The shoulders are pulled down. and you make a wide 3 by 3 centimeter bony opening with taking of the foramen magnum in. And C1 laminectomy is done in all cases, and sometimes with tonsils are lying below the C2, one should be liberal with the C2 laminectomy. Then you make a Y-shaped opening in the dura, and sometimes in the children, the sinuses are very prominent, and you may have to use those Liga clips to take care of the hemostasis part of the sinuses. Yeah, as you can see, the dura is gently opened in this patient, and now here I think we are doing this tonsillar resection, and now the tonsils are being. I do tonsillar resection and subfile leaching in large group of my patients, especially the ones at the sales. So this was a very old child who had multiple shunt failure procedures. In fact, he had aqueductal stenosis and carry, which was actually missed by the primary surgeon, and the shunts were recurrently infected. So what we did was we took out the entire shunt assembly, and initially we got endoscopic third ventriculostomy, which actually got blocked. And subsequently, we went ahead and did the foramen magnum decompression with duraplasty in this child, and the child actually improved. As you can see, with the diamond burr, the 3 by 3 centimeter foramen magnum limb is initially removed, and there's some bands and some kind of a tissue at the craniospherical junction which is gently peeled off. And as you can see, there is some bleeding when you open the dura, especially in the post-meningitic cases. And one can use this Liga clips liberally to control the hemostasis. And you can see there were a lot of additions at the craniocervical, at the foramen magnum just below the tonsils and the both ventricular floor at the outlet, and they were gently opened up by the sharp dissection, and bilateral pica were identified. And subsequently in this patient, we did use the artificial dura. In fact, I am very comfortable using artificial dura in my patients without any risk of any CSS. As you can see, there is a marked improvement in the hydrocephalus and the fourth ventricle outlet obstruction which was there prior to the surgery. And sometimes this was a child with a growing skull fracture who had a carry which was missed. There's a small posterior fossa and oblique sitting up tentorial picture, and in this child also improved. And the surgery for the growing skull fracture was done subsequently after addressing the carry component. So one needs to take a stepwise approach, and it is usually decided by whether the child is or the adult is symptomatic or asymptomatic, presence or absence of stings, presence or absence of raised pressure, hydrocephalus, or associated secondary causes, the common being craniosynostosis or hydrocephalus in the children and the adults respectively, and presence or absence of CVJ anomalies. We have got various surgical options: ETV, VP shunt, pony decompression with or without dural procedures, as I discussed earlier. And of course, posterior cerebral augmentations in children with a craniosynostosis is a beautiful option. And you should do CVJ fixation in select cases. If you talk about the outcome, the headache improves in almost 88% of the cases after surgery. The improvement in the syrinx within 6 months is seen in 75% of the cases. The deficits, in case they are present early, they improve in more than 40% of the cases. I think overall, approximately more than 70% of the cases improve after these surgeries. I think it's more of a vexato question kind of a picture to talk about decompression in carry malformations. But my personal suggestion or take will be to do a foramen magnum decompression with duraplasty, which has got low reoperation rate and more clinical improvement as compared to which outweigh the CSF complication rate. Though there in the literature there is no class 1 or class 2 evidence to it, but majority of the surgeons, including me, they believe that this is the procedure which is the standard treatment of choice. And in the adults with the large tonsils, I do go ahead with the tonsillar shrinkage in my patients. Bovine or the collagen matrix sutureless technique for the dura makes the donor side mobility related issues less and lesser, and with very decent results in the and quick surgery. C1, C2 fixation or the occipital fixation in absence of C1, C2 instability is highly debated. And my personal take is I usually do not do it in case I am not able to demonstrate any C1, C2 instability. There's no indication of prescribing collars for the patients who carry one malformations alone. In children with the craniosynostosis, one can do PCA without foramen diagram decompression with good results. One needs to have a very low threshold. And I think if you have got only one chance with no waiting list and admission waiting list, and there's some nose to follow-up issues, you should give the best in the first shot and practice what gives you best results in your hands. Thank you.
Before we proceed, I'd like to request the following participants for the stereotaxy radiosurgery workshop on taking place on the first floor to go attend. Dr. Hedsha, Dr. Puranjay Pratap Singh, Dr. Aaron Jose Fernandez, Dr. Ashish Thakur, Dr. Jesse Jaswant, Dr. Poonam Mohanty, Dr. Adrian, Dr. Dheeraj I'm sorry, I can't pronounce the name, Dr. Abhijit Acharya, Dr. Mani Maran. Thank you. Next up, we have a recorded lecture of Professor Sandip Chatterjee on surgery of lipomyelocele and thyroid cord. Thank you.
Good morning. I'd like to thank Professor Siddhartha Ghosh for this opportunity, and I'd like to apologize for my physical absence today. My talk is on spinal lipomas, how I do it. And here's a nice dorsal lipoma to start with an MRI showing a very nice stalk, a good separation between the lipoma and the cord. How do we get about it? What about the incision? Well, you have a choice of a number of incisions. This is caudal, this is cranial, that's the anal canal. And in our opinion, it is best to make a U-shaped incision, because if you make a U-shaped incision and you make a large U-shaped incision, then you stay well away from the anal canal. The other issue is when you make this incision, and this is very important, that you keep a lot of subcutaneous fat there. This is going to be a buffer against any CSF leak should it occur. And there, so there is the lipoma itself, and there is the fat pad. And this is very important to distinguish between the two. And of course, the first step is to work around the lipoma, as you can see, working from cranial to caudal on one side, caudal to cranial on the other side. And of course, it is very, very, very useful to find out the gap, the gap, mind the gap, they say in the stations and in London. And mind the gap is what you have to do. Find the gap, mind the gap. And that is the whole story of the lipoma, as you can see. The whole idea is to expose the lipoma all around, both proximal and distal. And we find this groove dissector a very useful tool when you're doing this dissection. An extremely useful tool because it allows you to work around the lipoma, as you can see. Ensures that you do not remove any important tissue. There's the cord below the lipoma. There's the lipoma. And of course, we're trying to work right around it, both proximally and distally. And of course, once you've worked around it completely, you can make it smaller and smaller and smaller. And of course, we always use MEPs. This is essential. And throughout the procedure, We're using MEPs to check to ensure that we are not going and deviating. And of course, we use SSEPs as well. So the next step after you've gone right round is called neurulation. And neurulation fundamentally means you remove the fat, like so. This is the point where we're always checking MEPs as we remove the fat, making sure we're not causing any injury below. And the most important thing is, at the end of the procedure, you should be able to get the pia to pia apposition. Note the important pia to pia. So all you see is pia, a little bit of fat. Everybody asks, should we remove every single bit of lipoma? And the answer is no. In our opinion, if you remove enough lipoma so that you can get a neurulation and a pia to pia apposition like so, and you can see the conus here. This is the conus, and this is the whole pia. And the little bit of fat that's inside can be hidden by doing this pia to pia apposition. This is very important, and this is probably the most important step. So that at the end of that, you can see a beautiful pia to pia apposition without any fat. And that's quite important. And we like to see it so that we can now do the next step, which is to push in a dorsal lipoma. You can actually push the rest, the reconstructed conus into the canal. So the last bit of fibrous stands that are holding you back can be separated. And then there's the neurulated new stalk, a new conus, and you can push that back into the spinal canal. So just to get everything together, summarized, let's have a look at the short composite video again. Exposure, working round the cord, very important to work around the cord. Again, you see, the groove dissector is something that we find very valuable. You see, that's very important. That's the interface, beautiful white line between the fat and the cord. And of course, at the end of that procedure, so you see, you've got just the filum terminale there. How do you know it's the filum terminale? Well, it's broad, it's accompanied by a blood vessel, it's white, and it's the only structure that goes dorsally. So in fact, you can, at the end of that, just chop it off like so. And there's the lipoma, that's the conus. You can see how neurulation is done so that there is hardly any fat visible and there is hardly any residual lipoma left. So just to show you again, there is another option, and that is after you have done, again, you see, I demonstrate to you how complete removal of the lipomatous portion is possible. And how little of the lipoma is left behind. So there's the last bit of fat we've removed. Then simulation can proceed. You can see there's hardly any lipomal tissue left. Those little fat globules are those that will be covered. And you can, if you want, stimulate to check. This is a bipolar stimulator, which is stimulating to check whether that is getting stimulated. That's the phylum terminale before we chop it off. And of course, today we really hardly ever stimulate because it's very clear which one is the phylum terminale. So in summary, a U-shaped incision, preserve the subcutaneous fat, work around the lipoma, cranial to caudal on one side, then caudal to cranial on the other. Neurolite, make sure you get a good pia-to-pia position without any fat. Then place the conus in the canal, cut the phylum terminale with or without stimulating, and then, of course, close. So these are the simple steps in repair of a lipoma. Thank you very much.
Thank you for joining us online, sir. Before we proceed, I request all those speakers who are present here today to kindly stick to their allotted time, so we are on schedule. Next up, can I please invite Professor Dandabani to give a talk on endoscopic strategies for large spinal intradural tumors.
Sir Pandey sir for this wonderful dandy course. So many residents and young faculty and all of us get benefited and by learning from each other. So it is a wonderful experience. So thank you. Yesterday, Professor Goyal sir told that don't talk about technology, but highlight the philosophy and the technique. So though the talk is at kind of titled endoscopy. Though the title of the topic is endoscopy for large spinal intradural tumors, it is actually, I want to focus on the minimally invasive aspect of yeah, don't touch it. Just by mistake, it was switched off. It's not coming. Yeah. So most of the time we see large complex tumors such as this. So whether endoscopy or minimally invasive spine surgery is relevant in these tumors, I would like to show in this presentation. When we published this in 2018, this was the first paper in world literature to show that minimally invasive surgery is highly effective even for giant tumors in the CV junction. And also, we coined a technique of sliding delivery technique for a long schwannomas in the dorsolumbar spine, where the length of the dural incision need not be as similar to the length of the tumor. It can be even shorter. The way we deliver a baby out of a cesarean section, we don't give incision as per the height of the baby, but as per the width of the baby. So, and I would like to show certain videos, and we have comprehensively explained our philosophy in this chapter of endoscopic neurosurgery, edited by Professor Yadav sir. And this is the video which I would like to start with, how endoscopy is a good adjunct. Again, the philosophy is doing surgery with least collateral damage by preserving the tension band and by doing minimal bony exposure. As you can see, this is a schwannoma in the dorsolumbar junction T10, and this schwannoma is mainly posterior. The key is not to damage the ligaments and the tension band. And as you see that we given a slightly paramedian incision, and we go along the spinous process and we retract the muscles laterally, and we use minimally invasive retractors, and endoscope was held by the assistant, and we do a fenestration at the level of the tumor as shown in the postoperative CT scan in the insert. And this fenestration should be of appropriate size as per the tumor. Dural exposure can be limited depending upon what pathology we are dealing with. But because this is more lateral, the fenestration is more lateral, and we give a paramedian incision. And the key is to get into the correct plane of the tumor. Schwannomas are extra-arachnoidal tumors. So once we get into the correct arachnoid plane, then we can gently roll the tumor and see whether any nerve root is attached. We use nerve stimulator to identify which are having any significant motor function, and which we try to separate all the rootlets, but things which are the roots which are non-eloquent, which are densely stuck, we can choose to coagulate and cut. The advantage of endoscopy is you can see behind the tumor. Sometimes when we do with 0-degree visualization, whatever is behind the tumor is hidden. But here the tumor is just rolled onto the operative cavity extradurally, and then with the endoscope, we identify the attachments to the rootlets, and by rotating the angle of the endoscope, we see any residual lobule, especially in multilobulated tumors, if it is there. And then dural closure is done. Recently, we have started using with Liger clips applied in a very oblong fashion so as not to constrict the dura. But we don't do this for cervical and dorsal spine, but dorsolumbar junction, we have noted that this is quite effective, and postoperatively, we don't see any stricture of the dura. This is the postoperative. This is there in neurosurgical focus. And this is another case of an anterior meningioma. As you can see, the spinal cord is flattened and pushed posteriorly. Here we need to determine, we have to go by a far lateral approach. Wherever you find a corridor, here is where we find the corridor. So, sorry. This is the paramedian incision, and we give a incision in such a way that we are in the coronal plane exactly over the center of the tumor, and then we retract the muscles laterally. In the deeper position, the muscles are incised horizontally, but not in the superficial plane, only in the deeper portion, so that we have to go as lateral as possible, so that we have to go for a far lateral approach. And lateral drilling of the facet joints is done with a fenestration of the lamina. Only one facet, because it is opened up, no need for fixation. And we identify the root, and at the axilla of the root, we have noted by localization that the tumor is there. We give a very far lateral incision and we coagulate the dural base. We devascularize the tumor attachment from all around, and then we get into the extra-arachnoidal plane. Again, these meningiomas are also extra-arachnoidal. So when we get into the extra-arachnoidal plane and we leave the dura overlying the cord, so that we will not inadvertently handle the cord. And in the extra-arachnoidal plane, gently the tumor is rolled into the lateral gutter. We have already created the lateral gutter by drilling the facet joint in that area. So there is a space in the lateral area. Medially there is, and posteriorly there is spinal cord. So we gently curate out the tumor, roll the tumor into the lateral gutter, and we excise the dural tail, because this was a meningioma. And most of the surgery in this case was done using an exoscope, and then angled endoscope is inserted to see whether we have left any dural tail. And all around we are seeing, and we can see the arachnoid overlying the spinal cord on the lateral aspect. So we can rotate the angle of the endoscope both cranially, caudally, as well as medially. We have to preserve the intact arachnoid. Arachnoid preservation is very vital, and as long as you are remaining extra-arachnoidal, these tumors which are smooth, there is no way we can injure any vessel of the supplying the spinal cord. But in multilobulated tumors, this you have to be extremely careful. But in smooth tumors which have a uniform shape, we can remain in the arachnoid plane and then preserve most of the vasculature and intact arachnoid. And then closure, because it is a far lateral incision, we didn't close the dura. And so basically we can classify the minimally invasive approaches into intermuscular and paraspinous access depending upon the location. Anterior tumors, we do intermuscular access from a posterolateral trajectory. Posterior tumors, we do paraspinous access. And different like which are the ports to use in which type of tumors, this has been highlighted in the Spine Journal publication, which I have already shown. And we have removed in that, when we had published, we had 4 large tumors in the CV junction, and the largest tumor in the dorsolumbar junction was around 6.8 centimeter. So the precise localization is the key. We have to take extreme caution so that our localization is precise, and we have to use optimal access retractor system. We can use any illumination and visualization system, it doesn't matter. And we do an appropriate drilling, tailored bone removal, and understanding the plane of the lesion is the key. And when we do localization, surface localization is useless, because with the same surface localization, you can go in any angle kind of trajectory. So only when you are opening the lamina fenestration, that time localization has to be done. We have different good retractor systems available. We can either do fenestration or do interlaminar approach. Posterior meningiomas and lateral schwannomas are extra-arachnoidal. Others will have intra-arachnoidal violation also. So it can be microendoscopic or true endoscopic or exoscopic. Each have their own advantages. This was a case of a giant C2 schwannoma. This is a case in which we have analyzed the position of the vertebral artery, and we go interlaminar without any bone removal. Most of these tumors, they are in the extra-arachnoidal or even extradural plane. So from a posterolateral trajectory, we use expandable retractors, and then we exactly stay around the tumor, and we start doing internal decompression. This is a very vascular tumor. So the only way to stop bleeding is, as long as you are within the tumor plane, the faster you decompress the tumor, the bleeding will stop. There is no need for coagulation. And at the end, as you see, the bleeding has stopped. This was an extra-arachnoidal tumor, but still there was doubt whether any medial lobule is remaining or not. We removed the capsule, which was predominantly extradural and then extra-arachnoidal, and we opened up and see whether any intra-arachnoidal extension is there. Then we closed it. And this is another case of giant C2-3 schwannoma, which is multilobulated. Here, the advantage of endoscope is phenomenal, because here the vertebral artery is in the depth, and in multilobulated tumor, you can do phased removal by repositioning the retractor. And as you see at the end of the surgery, we see the vertebral artery, and there was dural defect in this. With the angled endoscope, we were seeing the we can see the cervicomedullary junction, and the tumor here also, because we have a good soft tissue, the kind of dural closure is not needed. But in dorsal areas like this, we have to have dural closure. We use sliding delivery technique. We try to make a knot and then slide it, and then we try to close it. We try to close watertight as far as possible. And whenever, even this can be done for hemangioblastomas, this minimally invasive technique, for all locations, whether recurrent cases also, dumbbell-shaped schwannomas, and anterolateral meningiomas, we can do an appropriate trajectory. And these are some of the, like even in a case of double meningiomas, recurrent cases. So most of the types of tumors, this minimally invasive surgery is possible, and the results have been very good. And so I would say that we have to go for an appropriate retractor system and a tailored bone removal and remaining within the arachnoid plane. These are the keys for this surgery. Thank you.
Thank you, sir. Can I please invite Dr. Bernard T. Lingdo to deliver a talk on microsurgical approach to spinal intramedullary tumors? Thank you.
Good morning, everybody. I would I would like to thank Dr. Ghosh and Dr. Pandey for this opportunity to present here in this educational program. I'm Dr. Bernard. I practiced in Shillong, and Shillong's neurosurgery is not very old. It's just around 19 years old. I'm the pioneer of neurosurgery in this state, and that time we had a population of maybe around 9 lakhs or so. Now it's swelled up to around 12 lakhs in the city, but the whole state is around 32 lakhs. So being the only neurosurgeon at that time, it was quite difficult to start. My alma mater is SGPGI. That's where I trained. And then now I'm working in Supercare Hospital in the city of Shillong. So I would like to talk about spinal intramedullary tumor, particularly the ependymomas. And we all know that the spinal intramedullary tumors form almost 3 to 2, 3 to 2, the intradural versus extradural. They're around 5 to 10% of the CNS tumors. The Astrocytomas are more common in children, whereas the ependymoma is more in the adults, but it's present in both places. And almost half of the CNS ependymomas are spinal. We have a cervical predominance in the ependymomas. Sorry. Yeah. So cervical is predominant, and many of them you might find in the final terminal and the chorda equina areas. So they are rarely malignant. Most of these intradural tumors are benign, and the goal for treating intramedullary tumors is try to remove as much as possible, safeguarding the neurological outcome of the patient. Most of them present to us as weakness, spasticity, disbalance, wasting, loss of sensation, paresthesias. And most of the symptoms actually precede, the occurrence of the tumor actually precedes the occurrence of the symptoms. So the challenges is that we have to try and get them as early as possible. The challenges for us also in a place like Shillong is that we have less manpower regarding surgical outcomes and things for managing tumors like this. For example, neuromonitoring and all that, we will not have in our place. So I think for the young neurosurgeons who are going to go out to other places, to new places, coming from institutes, where whatever you've heard here yesterday and today are mainly from institutes and from big hospitals where most facilities are available, but in the smaller places where you have to come, it's totally the skill and the training that you receive in your institutes and the regular workshops that you go to, that you'll be able to understand how to come and approach tumors and work in a small place with minimum infrastructure that you will have. So I'll be trying to talk about two cases in this talk, and here's the cervical spine. As we know that the ependymomas are more predominant in the cervical spine, I'll demonstrate the cervical spine ependymoma. You can see it clearly that the ependymomas might be either small segment or large segment or holochord, depending on the extent. So here we have a ependymoma, which is a small segment ependymoma in the cervical spine. And on the post contrast, you could have a look that it is over there. It is 2.5, so most probably it is a small segment schwannoma. Second case is a myxopapillary ependymoma. Now we must be very careful of myxopapillary because I've seen many people making a mess of it, even though they see that everything, because a little bit of the ependymoma might enter the conus in the intramedullary in the conus area. So this is the post contrast scan. You'll see it's a long segment. Now, the surgical management under the cover of antibiotics and SERT, our main goal is to have complete excision with maximum preservation of the neurological function. Now, intraoperative monitoring in my hospital, we never use, but wherever it's available, it should be used. And I think in the years to come, it might be mandatory that everybody should have intraoperative monitoring for doing any type of spinal tumors. So you could use, as Dr. Sandeep had already mentioned, you can use MEPs or the D-wave monitoring. And most of the intramedullary tumors are now managed by, they are checked by the D-wave monitoring. So surgical management is the position. We have to see that the patient is positioned well so that there is minimum pressure on the abdomen, keep it as lax as possible. And then you plan your laminectomy through which you have to go through and enter the tumor and the dura. So try to do a wide laminectomy. And then I'll take you through it since it's more of a the young guys are here. So I'll take you through the steps. We all know we've seen videos. I'll just take you through an illustration of how you go about. So as soon as you open up the dura, you would see and try to identify the place where you'll have a swelling of the cord, the dura covering. You can feel the swelling. Be gentle. See for the nerve roots that are exiting from the dura. So because that's going to give you when you enter the cord inside, it will give you an orientation as to how to go into the midline of the tumor. So dural opening is normally done either caudally or cranially. As when you give a little incision on the dura, you can open it up, and then you finally expose the cord. So when you expose the cord, you will see the blood vessels running over the cord, and you will know exactly as to where the tumor might be located by the more blood vessels in the area of the cord. Now, since you've already opened up the tumor, the dura, and you've identified the rootlets coming out from both sides, you'll know exactly where the midline would be, where you can give your incision on the cord. So normally incision is given straight on the cord. Try to go right down to the tumor so that you can see the tumor. And then as you start dissecting the tumor, you can either go up and down, extending the incision on the cord to go up and down, and then you expose the tumor. Now, some people administer giving pile sutures to retract the cord. You can see we have given dural sutures to expose, but some give pile stitches to separate the cord so that you get better exposure. My practice, I've illustrated with the pile sutures, but I don't use pile sutures because I feel that too much extra retraction might cause cord damage since I don't have any neuromonitoring with me. So we have to be very careful as much as possible not to cause any damage to the cord. So then you come to the upper pole and the lower pole, try to see the cystic spaces, and then these ependymomas normally have a good cleavage between the normal cord as well as the tumor. So try to identify superiorly as well as inferiorly, and then start dissecting of the tumor. Minimum coagulation as much as possible. Try to dissect all around the tumor, coagulate the tumor so that it reduces in size, and then go forward. So this is basically what we are trying to demonstrate slowly how to remove the tumor. Normally people prefer it caudally, cranially, but it doesn't matter which way you go as long as you're able to get into the plane and remove the tumor. Short video of the whole procedure so that you can understand, but I will just, sorry. So just what we had seen on the illustrations, it's exactly what we are doing. So we peel and go. So you can see that the dural vessel, the cord vessels on top will actually give you an idea where the tumor is. Next. Just to hurry up. So we do that. You can see the vessels, then you can cut open, take out the tumor, cut the small vessels that are there, minimum coagulation as much as possible. I don't have the full video here, but just to tell you and demonstrate, you can further cut down, take biopsy, go get the dissection up and down, low pole, go down. And then the following video I didn't get, but just to show you the post-op, you can see the post-op that you have a complete removal of the tumor. Yeah, this is the post-contrast scan. It'll tell you that you have removed the whole tumor and you've tried to preserve as much neural structure as possible. And this is the first 10-day follow-up, and then that is the 1-month follow-up. You can see initially he came to us in a wheelchair, very spastic, but he improved slowly. And in 1 month, he's quite independent on his own. The next set is the myxopapillary ependymoma. Now, here, when you open up the dura, like as it was previously shown, you'll tend to get like a chewing gum on hair appearance, when you open this area, or atta in your hair. It's very sticky. All the the phylum is stuck to the tumor, and then you might have a little portion that is going into the conus on top. So while dissection, one should not, because I've seen people just trying to decompress and then it becomes a mess and it just gets bloody over there. And we know that ependymoma, it's not very vascular. If you are able to separate, dissect slowly, you can come out with the whole tumor slowly. So the idea is to separate each and every phylum, get to the main bulk of the tumor, debulk it, and then come up to the conus slowly. And then when you're at the conus, maybe you just cut the conus a little bit and take out the intramedullary portion from there, and you'll be able to see the whole phylum that is present over there. So this was the post-op scan, and you can see that we have removed each and every portion, even the intramedullary portion of the tumor, the post-contrast scan that is over there. So surgical occurrence, you can see this boy, he came to us, he had slowly started getting retention, but then suddenly after removing, his catheter was removed out. This is around a month's follow-up. He's able to do every action without any problems. So in conclusion, our main goal is to have a complete cure, try to remove the whole tumor. Early diagnosis and complete excision is the way we have to remove, because once you remove all ependymomas or intramedullary tumors, you can totally cure the patient, and most of them are low grade, so you do not need to give any adjuvant treatment or anything. Now, in the coming days, everybody would have to use intraoperative neuromonitoring. So we are trying to get that into our hospital soon. And our main problem is getting the technicians here. Everybody is, we have very few manpower in our place here. And the neurosurgical, we have to try and get as much neurosurgical preservation in the post-op. Thank you very much for your attention.
Thank you, sir. Thank you for being on time. Now we're moving on to the panel discussion part of the session. May I please invite Professor Dattatreya Mazumdar, Professor Dandabani, Professor Bernard T. Lingdo to have a panel discussion, and may I request Professor Ashok Pillai to moderate.
Pointer.
We also have Professor Sandip Chatterjee, who'll be joining us from online. Professor Chatterjee, are we audible?
Yes,
thank
indeed. Thank you.
Thank you.
Yes, indeed, you are.
Thank you to all the speakers for wonderful talks. It was very fascinating and incredibly good artwork also. So we'll open the session for questions to any of the speakers. Is there anybody, any of the trainees, sir?
My questions and comments are for Dr. Bernard. Thank you for inviting us to your beautiful city, and thank you for your artwork as well.
Amazing artwork.
Amazing. My questions are, first, why are you so keen to say that you need intra monitoring? Because to my simple mind, we are treating patients who cannot afford that. Even at hospitals in Mumbai, where we have this facility, even at the cheapest rate, it costs 40,000. My patients don't pay more than 15,000 for the entire care. So we have to find a simpler way. And one comment is that bipolar coagulation should be at its minimum. It's the first thing. I saw you using the bipolar coagulation on the posterior surface of the cord. I happen to have a large series myself at KEM as well as Nair. The important thing is to open into spaces where there is no vessel. So that's the first thing, and then get to the tumor. And you can make multiple such small openings. I've tried to publish it. It hasn't been, let's say, allowed because I don't use intra monitoring. But I found results like yours, where patients can walk on day 10, day 3, day 5. I don't even use steroids. I have not used methylprednisolone for a long time. I'm really worried about infection in the setup. So I use small myelotomies. I call them micromyelotomies, but they're about maybe a couple of millimeters. I don't even cut on the posterior surface. I take a 21 number needle with a 2 cc syringe. I make a small nick on the pia arachnoid in the midline, very much as how you've described. And then I take the microbayonet forceps and I just splay open. The posterior columns don't handle thermal trauma like the cautery, don't handle the retraction, which people used to use pile sutures, but they allow dissection in the longitudinal plane. Because if we jump, we do all our activity, there's a lot of stretch, but in the longitudinal plane. And in fact, to prevent that, we have these dentate ligaments on the side. So there is a lot of protection by nature. And all we have to do is follow nature. Don't destroy those vessels on the posterior surface of the cord. Open up these spaces. I'll try and put a YouTube video, but I'm waiting for my article to be published, and it's not happening, but I'll keep trying. I have maybe 80, 90 cases of ependymomas and astrocytomas. I'd like your comments. Thank you.
Thank you, sir, for your comments. But I think intraoperative monitoring may be as a case of litigation in the years to come that we might have to use intraoperative monitoring. We are the older generation, but I think the newer generation with more modern hospitals and everything, and plus the litigation aspect, that's why I was saying that intraoperative monitoring might be important and might be mandatory later on in life. The rest which you have given us, me as comments, I take those as good comments. And with time, slowly, my cautery has come down a lot. I do the dissection myself. I don't use pile sutures anymore. So these are things that I like to preserve the cord structures when I go.
So we have one question from Dr. Pandey. Before that, I'd just like to add one point about the intraoperative monitoring, having developed it over 10 to 15 years at our center.
And I would like to also make a comment about intraoperative.
I agree with you that it is going to be required. And as a person who's transitioned through that over 15, 20 years, I think that the important thing is it gives you the confidence to keep going. That's the main thing. It's not really just only for its documentation will be important, but I hope we don't reach a level where we're using documentation for legal purpose. It's mainly to give the surgeon who's already, it doesn't substitute for proper technique. It helps you continue to go and then perhaps do a better resection. So Dr. Pandey.
For the young neurosurgeons, intraoperative monitoring is a technique. It's a part of the technique. And I work with the Trust Hospital. We do operate on poor patients at VHS, and it is free. The paying patients pay for it. At Apollo, it is used. It is mandatory, not for litigation. For the results to improve. Yeah. You will have to do it. There is no way.
It will
and
change
because we don't use it we don't operate without it now. I am quite sure that it is mandatory, and it is good to develop facilities all over. Congratulations, Dr. Bernard.
So we
May I make a small comment on this?
Yes, please go ahead, Doctor.
As president of the Intraoperative Neuromonitoring Society of India, I thought I should make a comment. And we've written an article called The Seat Belt Effect, which is that people always say, I've driven a car for the last 30 years without a seat belt. Why do I need a seat belt now? And I think that's the same attitude we have towards intraoperative neuromonitoring. The seatbelt does offer you that extra protection, that extra insurance, and of course, stops you paying the fine at the police. But most importantly, we have published ourselves 50 cases of intraoperative neuromonitoring used intramedullary tumors compared with the last 50 cases when we didn't use intraoperative neuromonitoring. And to our surprise, we found that our resection was much more complete when we used intraoperative neuromonitoring. The duration of time was about 10 minutes. And it certainly gave the surgeon much more confidence in the approach. By the way, since you talk about medical legal issues, and since I am unfortunately the president of the Indian Society, there are 2 cases already in the National Commission for people who have not used intraoperative neuromonitoring while doing surgery, and that's reached now the National Commission. and we have to appear as expert witness for both of them. So it's not that it's not happening in this country. It is happening, and it will continue to happen. So you need to protect your patient with intraoperative neuromonitoring, but you also need to protect yourself. And finally, Bernard, you talked about complete removal of a myxopapillary ependymoma as the cure. The new WHO classification, unfortunately, puts the myxopapillary ependymoma as grade 2, which suggests that you should have adjuvant therapy given, even if you've done a total removal.
Thank you, sir.
All right. Thank you everyone for making this an interactive session.
Can I ask a question to Deepak, please?
All
Is he
right.
available online?
No? Professor Deepak is not available right now.
I was just going to make a small comment, which you might find, the juniors might find useful. You notice the somewhat empirical way that some patients just have a bony decompression and some patients have a duroplasty. Well, in our experience, what we tend to do is, but in children particularly, we do a bony decompression. Then we take an intraoperative ultrasound and use the intraoperative ultrasound to see if CSF is draining from the supratentorial place, from above the foramen magnum to below the foramen magnum. And it's very easy to work out with a simple intraoperative ultrasound probe. If we find that the CSF circulation has been established, we do not do a duroplasty. If we find the CSF circulation has not been established, then we do a duroplasty. So sorry, this is from a not so younger trainee, but this is an algorithm that we found very useful and avoids a lot of unnecessary duroplasties.
Right. Thank you, sir. Can we conclude the session now? Right. That concludes the topic of pediatric neurosurgery. Now we'll be moving on to the session of epilepsy.
So the session on epilepsy will be moderated by Professor Ellen Tripathi. I now call upon Professor Abhida Shah and Professor Sukhdeep Jawar to deliver a talk on the anatomy of medial temporal lobe. A kind reminder to all the speakers to adhere to the allotted time. Over to you.
Yeah, thank you. Now we are shifting our focus from pediatric to the epilepsy surgery, and the most important part of epilepsy surgery is to study the anatomy of this temporal lobe. Can you put on the 3D, please? So now he's doing the setup. While he's doing the setup, if you see this temporal lobe, it's a very hidden part of this cerebrum, and it's a large lobe, and it has a lot very hidden surfaces. Actually, if you see it clearly, the topic is the medial temporal lobe, which we call mesial temporal lobe. So it is not a one lobe. Actually, there are two lobes: temporal lobe and the limbic lobe. So we will be studying, having a look at the dissection of this part. So we are waiting for the 3D to come. So now, beautiful. Now you can see how beautifully this 3D is coming. So we can see the basal surface with all the cranial nerves here, right from the olfactory nerve. Then we have optic, third nerve, fourth nerve, of course, is not visible here. But you can see there is a large part of mesial temporal lobe, which is hidden and very close to the brain stem. So all this folding and, this configuration of this lobes and everything, it has all part of the evolution of the human brain, how the this telencephalon has evolved and led to infolding of this old cerebrum, which we call archae or paleocerebellum. So this is the part here. Can I have a pointer? So now you can see here, this is the temporal lobe part here, parahippocampal gyrus here. This is the basal surface, and this is the peduncle here. And how this uncus is related, you can see this tentorial impression on the uncus here. So now we have removed the brainstem, and you can see how this whole is the temporal lobe. So temporal lobe is a large part of the cerebrum. So this is the parahippocampal gyrus. This is the occipitotemporal or fascicular gyrus. This is the inferior temporal gyrus here. So all these gyruses, and they are very important when you are dealing with the pathologies in this area. So parahippocampal gyrus, if you see clearly, is going like very close to the brainstem, related to ambient cistern, caudal cistern, and then it is bending forward in a hook shape. That hook area is your uncus here. This is the parahippocampal. So if you see, if you imagine, you know this to understand the limbic lobe anatomy is one of the most challenging part for a you can say from your textbook or for 2D images. But if you go to anatomy and see this 3D anatomy, you will understand this is a very complex area. If you understand this anatomy, you will understand the most of the anatomy of the brain. So if you it has very many connection to other lobes. So if you imagine the temporal horn and you see the hippocampus there, you see the amygdala if you go from lateral aspect. And their ventral impression, if you see, this is the amygdala here, and this is the hippocampus here. So parahippocampal is parahippocampal. So it is this is the cortical side of the hippocampus here. So if you remove this, now you can see here we have cut some part of the hippocampus here, and then you see this area. These are the if you see clearly, there are a lot of gyri here. From anatomical point of view, there are 4 or 5 uncinate ambience, and you can see semilunar gyrus. There are 4 or 5 gyrus here. But from surgical point of view, we consider this uncus as a single entity with the amygdala at its superior aspect. We'll see that in the other images. So coming to the, of course, we should also understand that this area is not only the neural, there are a lot of vascular structures, lot of very important arteries. We have the posterior cerebral, we have the anterior choroidal, posterior choroidal, then this choroidal branch is going to the temporal horn and supply the temporal area, supplying the hippocampus here. So vascular anatomy is also very critical. They have small perforator. If you injure a small perforator, patient can land up with some problems. So while doing these surgeries, these are critical issues. So this is yesterday I think Abhida showed you from the lateral aspect how this is anatomy of the insula. Now we have just kept the insula here and showed the medial side of the hemisphere. And here we have cut open the this from the lateral side, we have cut the temporal lobe. And now you can see the temporal horn, this bulging structure is your hippocampus. Now that the structure I told you from the inferior aspect. So on the other aspect of this is the parahippocampal gyrus. And if you see the roof of the temporal horn, and there is this area anteriorly and on the roof where uncus is there. So that is your area of the amygdala. So sometimes it is amygdala is a small, almond shaped structure. So it occupies this area. So these are all, this is all primitive, this thing. Olfactory system is the most primitive, and this is the, bridge between neocortex and the olfactory, this thing. So this is now you see the mid-sagittal section. So here you can see most of the structure. This is the third ventricle. This is the impression of the massa intermedia here. And this is the septum pellucidum. You have the corpus callosum. And all around the corpus callosum, we have wrapped around the cingulate gyrus. So cingulate gyrus is a very large white fiber bundle, which is connecting almost all of this medial surface of the brain and connecting it to the limbic lobe. So this is a connection between limbic lobe and the cortical areas. So it is going all the way like this. Then then this is the isthmus. Then it continues as the parahippocampal gyrus, which will show to the other side. So now we will try to do some dissection of this. So if you see this image, this is a 2D image. So these, if you imagine this in your center, you have a thalamus and hypothalamus, and then there are multiple C-shaped or semilunar structures which are wrapped around, and this is how all this limbic lobe and paralimbic lobe system is. You have the hippocampus here, we have the amygdala, mammillary body, hypothalamus, and then we have the number. This, if you see, there's a cingulate gyrus, large connection between these structures. Then we have the linea stria here. Then we have the other structure. Of course, these are more of anatomical, but this is the stria medullaris thalami. Then we have, we'll skip for this now. So just if you see, this is the medial thalamus here. This is the thalamus here. This is a hypothalamus. So hypothalamus is a very small area. It's just 4 gram of the brain, and it has a it's the main survival part of the cerebrum. So it controls our emotions. It controls the temperature, circadian rhythm. So there is all the hormones are controlled by hypothalamus, and hypothalamus has a lot of connection with the limbic lobe. So this is now we have done the fiber dissection on the medial aspect, corpus callosum. You can see we have the caudate head. You can see this is the thalamus here, hypothalamus, mammillary body is visible. So as you keep on dissecting, of course, this is a cut section from the below. This is just showing the relation of the corticospinal tract. This is the amygdala here, and the temporal lobe has been cut just to show the relationship. So now we have removed some part of the corpus callosum. Now you can see the lateral ventricle, and you can see the fornix going like this. The fornix again is a very prominent bundle here. So now you can see, now we have removed the cortex from inferior aspect also. This is the parahippocampal gyrus, then going the isthmus, then continuing as the cingulum all around the corpus callosum. This is the mammillary bodies here. And of course, this is the midbrain. So if you now you see we have removed some part of the caudate head also. Now you can see some fibers of the thalamic radiation, and corona radiata will be of course on the other side. So these are the thalamic radiation fiber going to the thalamus here. So coming closely now, we will try to dissect here in the thalamus how to see mammillothalamic tract, how it is going to the anterior thalamus, then again going to the cingulum. And then we have to see how, this anatomy of the hippocampus also. So this is all stepwise dissection, which I am showing, which we have done over the years of the this limbic lobe, the Pepys circuit, and all these things. Now you can see the column of the fornix here. You can see, appreciate now. The structure which is just in front is the anterior commissure. This column is going here, body. There's a crura here. Then it goes as the fimbria of the fornix. So fornix is wrapping all around the thalamus. So choroid fissure is you have to remember, choroid fissure is a very important fissure. It is when you are operating in intraventricular or any approaches to the thalamus, choroid fissure is your guide. So anything lateral to the choroid fissure is your fornix, you are safe. Anything medial is your thalamus. So it is all around the thalamus. We have the 3 parts of the fornix, which is the column of the fornix here. And this is again the body, this is a crura, this is the fimbria. So this is just the close-up view. Now you can see how this column is going into the mammillary body here. Then we have a small tract emerging from the mammillary body, which is going upward. So as you keep on dissecting, so we removed here some part of the thalamus. So some of them, they can give you a little strain because of the 3D things. So now you can see there, so you see these tracts are there. When you have to dissect, you properly prepare the specimen, and you have to be very careful while you are doing this sort of dissection. If you damage this whole thing, this whole specimen get damaged. So now you can see some impression here. So now beautifully, now this you can see how this tract is going, mammillothalamic tract, and it is going to the anterior thalamic nucleus. So just to show this, now you can see this the mammillothalamic tract. So now we have removed the whole thing just to show, to give a impression of the Pepys circuit of emotion. So here it is the hippocampus here. You can start from here, hippocampus, then fimbria. There's a crura body, then going to column, mammillary body, mammillothalamic. Then thalamic radiation go from here to the cingulum again, and coming back as the parahippocampal gyrus and completing the circuit. So here now again, once you go to the deeper part of this dissection, you will see all the thalamus connecting to almost all of the cerebrum. So thalamus, as it is a relay center of the body, all the sensory information from the body, it comes to the thalamus except for olfaction and of course visual. Then part of that goes to all the cerebrum. So now you have removed that Pepys circuit, hippocampus is out. Now you will see the deeper part of this dissection. You will see a lot of white fibers going to all parts of the brain. And as you keep on doing now, you can see have a better look here. And this is the anterior thalamic radiation. This is the posterior, which is a major part going to the occipital and parietal lobe. And this is, of course, the Mayer's loop. It's also inferior part of the thalamic radiation. So Mayer's loop going all the way. So we are seeing from the medial side. Of course, this dissection can also be done from the lateral aspect. But then it gives you a 3D overview of all how these white fibers are oriented. So this is again the same picture showing different angles. So now you can see whole of the thalamus getting fibers from to the all of the rest of the cerebrum. This picture we have seen. This is just to top from the top. If you see, this is the hippocampus. Then we have this choroid plexus attached to the choroid fissure. Again, choroid fissure, as I told you, is a very useful landmark when you are doing these surgeries. Anything here is the thalamus here, and this is the fimbria, and then going the column as the mammillothalamic tract. This is a different dissection. So of course, now, with all this fiber dissection and all the latest technology, you have seen these images. So with the fiber tracking, we can have all the tracts, how they are interacting with each other, how they are interacting with pathologies, whether they are getting displaced or they are getting involved in. So if you know the anatomy and if you have done some dissection, this is really helpful. And this fiber thing is very useful also for your hand-eye coordination also when you do the dissection in lab. Because nowadays we have seen a lot of young neurosurgeons, they are coming, and some of them, they don't get that much opportunity to go to operation theater daily and do some surgeries. Of course, that is the best experience if you can get. Even if you are not getting that experience, I suggest you find a lab somewhere near you, or you find a place where you can do this hand-eye coordination things. So it is all in the muscle memory. So this, I think Abhida has shown yesterday. This is here the visual pathway. So, and of course, lateral aspect we have already seen. So with this, I think I finished my talk. And this is the hippocampus on both sides. Thank you.
Thank you, sir. Now I'd like to invite Professor Manjri Tripathi to give us a talk on the pre-surgical evolution of drug-resistant epilepsy. Over to you.
I think it's pre-surgical evaluation of drug-resistant epilepsy. The evolution would be a very boring topic for all the residents over here. I would at the outset like to thank the organizers, Dr. Pandey, Dr. Tripathi, and others, the local team, for their kind hospitality. The reason I guess this talk has been kept is that clearly it should be understood by a neurosurgeon who's starting out in the field of doing epilepsy surgery as to who are the candidates and who are safe to operate without producing any additional harm, because the outcome here is seizures. And of course, there are non-seizure outcomes. It's not a measurable grand tumor, which is there in the skull base, or an aneurysm that we are out to do. But of all the interventions in neurology and neurosurgery, epilepsy has the least number needed to treat. So the epilepsy surgeon has most gratifying outcomes and also pleases the patients because you just need to treat 1.5 patient to make one seizure free. Anyone in the hall know the number needed to treat for Disprin or Ecosprin to prevent a stroke? You need to treat 76 patients to make one prevention of stroke with aspirin. So that's the power of epilepsy surgery. It can change the trajectory for your patients. I bring greetings from my center, which has been established. It has not only a clinical arm with the epilepsy monitoring unit of 8 beds, but it also has a magnetoencephalography facility, which is almost free to the patients of our country. It also has a basic sciences lab, which is named after Professor P.N. Tandon, who was the inspiration behind this center. And of course, it also has the epilepsy surgery facility, which has discovered newer techniques for surgery. Now, why is the screen not showing up there? I think people, I'm sorry, I didn't notice it. So that's just to show the arms of our facility. We've operated roughly around 4,500 cases, started in 1996. We have 328 papers to our credit. Now, it's very important that the surgeon know that you're not operating a patient who has a wrong diagnosis. The wrong diagnosis commonest to feature is psychogenic seizures. So it's the job of the neurologist in the team to rule out psychogenic seizures in patients who have true epilepsy. And it's not uncommon that 15% of your patient will have a combination of true and psychogenic seizures. So before you get them into surgery, you have to tackle the psychogenic seizures. It's also very important that the surgeon doesn't implant 11 or 12 or 15 electrodes when the patient has generalized epilepsy and has been wrongly given drugs which are used for focal epilepsy. So very often there's a fishing expedition of stereo EEG electrodes for a generalized epilepsy wrongly treated as focal epilepsy. Of course, we should be sure that the patient is taking the medicine and is not doing so in an inadequate dose. All this is the job of the neurologist in the team to lay out. The surgeon, before even operating the patient, should make sure at least this criteria is met. That is, the patient has failed to have his seizures controlled despite taking 2 anti-seizure medicines. The duration is immaterial. Previously, they used to say it's a rule of 2, that is 2 years you have to have taken 2 medicines and still had 2 or more seizures occurring. But that's not so. You can have 2 drugs which have failed, irrespective of the interval between the seizures and the duration of the seizures. So that's drug-resistant epilepsy. Just make sure you have drug-resistant epilepsy. Approximately out of 100 patients, 30 patients will have drug-resistant epilepsy. And the greatest clue that this patient of yours is a good candidate for surgery is the fact that you would find an imaging abnormality in your MRI. So those who are starting out with an epilepsy program, surgery program, it would be wise to choose or select patients who have a substrate positive MRI. So it's very important for that. And of course, then the other criteria should be met. So finding a structural abnormality is something which is very important. Also important is the fact that since they have drug-resistant epilepsy, please make it a habit to look at the seizures, whether it's in the home videos or situational CCTV cameras that your patient brings, because that can give you a clue as to how fast you should do the surgery for a patient. So if it's a focal seizure with intact awareness, you're not going to, put him on super fast express for surgery. You can wait. Whereas if it's a generalized seizure where the patient is falling again and again, it risks injuries, it risks death. There you would have to fast track them into surgery. It's also important to take a history from your patients to make sure these seizures are focal. They could be focal motor, they could be focal with impaired awareness, they could be focal with intact awareness, which is just the aura, or they could be focal with bilateral tonic-clonic seizures. And it's good to know where the seizures are. Are they disabling? Are they non-disabling? Grossly disabling seizures are those that prevents the patient from age-appropriate activity, whether it's going to school or going for a job or whatever, or getting married, and is causing falls, injuries, dislocations, is causing intellectual decline gradually. So these are disabling seizures, whereas non-disabling seizures would be seizures where it hasn't impacted these usual parameters of age-appropriate activities. It's also important to have a screening tool to shortlist your patients, and that would indicate that they are truly drug resistant, have an imaging abnormality, and have impacted comorbidities of epilepsy. A tool for questioning auras, the kind of auras, unless sometimes when you ask the patient, do you come to know about the seizure? They say no. But when you give them specific clues, do you have a sense of vertigo? Do you have piloerection in one side of the body? Do you have a sense of smell or bitter taste? Then they come out with these auras. The reason being is many a times patients are shy of reporting these auras. Then, of course, the neurologist gets them into the epilepsy monitoring unit, which is where the drugs are tapered. Now, when we taper the drugs which produce adverse effects first and which can be given IV in case of a status. It is not uncommon for epilepsy monitoring units to now be situated in neurosurgical wards, as many in our country. It's important to understand that the neurologist must give you the clinical, that is the symptomatogenic zone, must give you the surgeon, the interictal network or the irritative network, the radiologist in your team must give you the lesion, and the neuropsychologist in your team should tell you the deficit. That is very important that we establish all this. And of course, the semiology, which is confirmed as the habitual seizures by the video EG. So all this workup has to be on the plate before it is served to the surgeon. And the surgeon has a right to demand for all these investigations. Most of these investigations can be done in a Tier 1 center doing epilepsy surgery. However, there are certain conditions in which you require advanced investigations like PET, MRI fusion, ictal and interictal SPECT fusion, SysCom, and anamagnetoencephalography. And these would come to a Tier 2 center, which would then need some cases to go into a stereo EEG or invasive evaluation. Hence, it's very important to have a team. And believe me, the team is constantly meeting once a week to discuss the cases and decide which one can be taken up for clean surgery and which one of them need to go for diet management or for alternative managements and rehab. The essence is to find out the network, which the neurologist should be able to do, and then find out the lesion, which is, causing this network to fire, and remove this network, which is resective surgery. And in case the surgeon is not able to remove this network, then do a disconnective surgery. And if is not able to do either of the first two, do a neuromodulative surgery, which can be very expensive in our settings. Hence, this is the protocol we follow, which is published in the Annals of Indian Academy of Neurology, where a Tier 1 center can clearly do clearly defined lesions like mesial temporal sclerosis, DNETs, gangliogliomas, and type 2 dysplasias, provided they are not over the eloquent cortex, with standard investigations like MRI epilepsy protocol and video EEG and neuropsychology examinations. However, wherever you have multiple lesions like TS, wherever you have large lesions which require disconnections, multilobar resections, and you have subtle dysplasias which are type 1, you would need additional investigations like ictal SPECT and PET, and hence they should go to a Tier 2 center or center where this is available. It is also important that when you are having a reasonable hypothesis of the ictal onset based on all the investigations which you have done, and you are fairly sure it's a focus, you go ahead with the intracranial EEG with an established hypothesis and not being a fishing expedition. And when you find that you are not able to do anything because the onsets are too diffuse and bilateral, as we see in many of our bilateral hypoxic encephalopathies, we can do palliative procedures like callosotomies or neuromodulation. Hence, as per the International League Against Epilepsy guidelines, H is the highly recommended. And H would be, that is, you do a MEG or a high density EEG, BISA source localization, PET and ictal SPECT in patients who have negative MRI or have subtle findings in the MRI, which would be in FCD type 1. So you have to do all those investigations in those. And wherever you wish to establish function, whether the function be motor speech or motor function or visual function, it's very important to preserve that function, and you would require more snapshots, and hence all the highly recommended investigations of MEG, ictal SPECT, PET should be done there along with mapping. Pediatric patients have large lesions and diffuse EEG onsets. This is not a contraindication to surgery, and the neurologist should be able to convince the surgeon to do so. Now, I'll spend some time on the epilepsy protocol MRI because this is the most important workhorse for a refractory epilepsy. Previously, it was thought you could do it anyway, but now you have clear guidelines by the ILE. The harness protocol is a protocol which should have all these 4 categories, which would be a high resolution 3D T1 weighted image, 1 into 1 into 1 millimeter. It's not 3 into 3 into 3 or 5 into 5 into 5. It has to be 1 millimeter voxel. high resolution 3D flare, high in plane resolution. I think my time is up. So this cannot be done away with. And along with this, you have to have ASL. So if you have all this, you could pick up subtle lesions in the frontal lobes, and you could convert a negative MRI into a positive MRI. There are certain areas which are overlooked. Many MRI systems, they have artifacts in these areas. You should also look for encephalocele where you're getting temporal lobe onsets, but your MRI is negative. Go in for the coronal T2 images, which will pick up your encephalocele, which are an important cause of MRI negative epilepsy. Hence, it's very important that a good neuroradiologist be in your team. Along with this, the ASL can act as the poor man's pet. As you can see here, ASL clearly picks up the type 1 dysplasia in the temporal lobe. It picks up the dysplasia in the frontal lobe. The ASL shows hypometabolism, which is confirmed by PET MRI fusion. So you can use ASL extensively. This is an ictal ASL in a patient with Rasmussen's encephalitis. Syscom, or Syscos, where you can see the onsets with the cross-cerebellar diascasis also are very useful. So also is the fact that these can be now done with MEG analysis, which can help us shortlist cases for SEG implants. A neuropsychologist in temporal lobe should be able to tell you if you're removing the right temporal lobe, the verbal memory is intact. And if you're removing the left temporal lobe, the visual memory is intact. A functional MRI is another thing which can be done. We have paradigms generated for Hindi-speaking population. And this helps us localize. The word generation has shifted to the left hemisphere, so the surgeon feels safer. The syntax generation has also shifted to the right hemisphere. The comprehension has completely shifted to the right hemisphere in this patient. Hence, the surgeon can go ahead with a safe surgery into the left temporal lobe. Along with tractography, the surgeon can also determine with functional MRI. As you can see here, functional MRI shows shifting, and the tractography shows absence of tracts in that particular area. And the approach can be right through the language cortex or the Wernicke's area. It's important to understand that in complex cases, if you have a concordance of all investigations, the long-term outcomes of 8 years and above can be as good as in any other country in the world, with 75% 8-year outcome for temporal lobe and 60% for extratemporal. The ictal specs have to be injected within 30 seconds of the seizure onset. So do not believe a ictal spect where the dye was injected after 10 minutes. That's not an ictal spect. Always go into whether it was truly ictal and look at it. Its sensitivity is as good as 100%. The MRI, the sensitivity is 80%. The MEG is very good for deep-seated lesions, including an ictal MEG. Stereo EG should be employed with a clear hypothesis. It can be done with the ROSA. If you don't have the ROSA, you can use a stereotaxic frame. What we use in AIMS is the French protocol because we had them come over for some workshops, 2 workshops at AIMS. So there are standard implantation guidelines. It's a easy thing to do provided you know where the onsets are. Stimulation and ablation. This is something which we do in our patients nowadays. We stimulate and we also ablate the ictal onsets. And if the seizures come down after the ablation, as they do in 20 to 30% of patients, in one of them, our patient is completely seizure-free following an ablation where the MRI was completely normal. I'm not talking about a lesional ablation. So it proves your hypothesis. Multimodal fusion is something which the surgeon can ask for. Standard softwares are available. And intraoperative electrocardiography is something we can do. It's not possible to cover each case scenario, but I would recommend that the residents note this website, which is available. All the case scenarios of temporal lobe surgery, extratemporal lobe surgery are available on this website. It's a 2-hour workshop done by the International League Against Epilepsy for each case scenario. With this, I'd like to conclude my talk, and if there are any questions, I'd be glad to take them.
Thank you, ma'am. I would now like to call upon Professor Ashok Pillai to deliver a talk on the surgery of MTS.
Thank you. While they're connecting, I'd like to thank Dr. Ghosh and Dr. Pandey, my friends, and the local organizing committee for this wonderful hospitality and opportunity to contribute to the training. I hope it is useful for all of those here who are interested, upcoming neurosurgeons for the next generation. And I know that also there are many other surgeons who are well experienced in this field. So this is more how to do for those who are interested in learning this, or at least how I do. And it's a surgical talk. So though this is in the epilepsy surgery session, and it's primarily meant for epilepsy, I'll be talking about the technique for anterior temporal lobectomy, just to get a lead on the time. I also feel that this surgery, once one is confident with the temporal lobe anatomy, from as we've seen from the anatomy lecture which started off the session, then it helps you a lot for tumor surgery also, and I think outcomes are better with the same technique applied there. And my previous fellows, Dr. Gopal and Dr. Nateshan, who are both now epilepsy surgeons, have helped me a lot for preparing this talk once upon a time. So temporal lobectomy for epilepsy. To quote one of the fathers of epilepsy surgery, Dr. Jerome Engel, it's one of the most underutilized surgeries of the century. That was said by him in the previous century, because it has excellent outcomes. As Dr. Manjari has just explained, it's one of the most gratifying things in neurosurgery, perhaps. Which is the... And so I like to teach my fellows, it's just like the lumbar discectomy of epilepsy surgery. If you're going to do epilepsy surgery, you have to learn this one well. But having said that, it's to my I'm quite sad to see that there's declining talent in this in Western countries, especially in North America, because and I was recently there operating, and I noticed that most people coming out actually don't know how to do a very good temporal lobectomy anymore, because it's slowly being replaced by ablative methods. And I have some opinions about that from direct experience just as well. But I'm happy to say that here we still have the chance to learn this well, because it will be, hopefully it will be there to stay. And there are many different techniques which many people may be using. Which goes all the way up to selective amygdalohippocambectomy, which I will stay away from that now, partly just to teach the general temporal lobectomy. But also, I feel in the next 10 to 20 years, if we're really going selective, it's going to be in selective thermal ablation. So you will, for the benefit plus the reducing the invasiveness, we're probably better off going with stereotactic thermal ablation for once you want to get selective. Now, the flap that I use is a myocutaneous flap. This was taught to me by my mentor, and is one of the best things. It causes the least amount of cosmetic deterioration over time if you don't separate the temporalis from the scalp in the traditional Yasser-Gill interfacial dissection. Actually, you just go straight through and go subperiosteally, and that gives a good mechanical support for the muscle and good mechanical and vascular support for the muscle, and probably virtually no cosmetic defect in terms of temporalis atrophy over time. So it's very important. This is the position I use. Now, let's start the dissection. So let's go through the surgeon's anatomy, seeing it from the top, T1, T2, T3. So cut number 1, this is how I usually enter through T2 and T3, and there's a traditional way of measuring how many centimeters off from the temporal pole. We can go over that if anybody's interested. And then this starts there, and then it also extends over T1 towards the planum temporal. And to see in the coronal view here, you see it's coming through T1 to T3. And then cut 2 is going to get you into the ventricle. So that's the moment of truth in a temporal lobectomy, is to see the ventricle. So let's go over the microsurgical. And I'm afraid that the resolution is not so great there, but I hope this is helpful. Here we're going through. So here you see the Sylvian fissure for the trainees here. This is a T1. So I start on T2 and we go along the cell side. This is quite standard dissection. Okay. Now you follow that inferiorly towards the base, so that you're confident you can count from the base and from the Sylvian fissure. And then you're going to go medially from there and hit the collateral sulcus. Collateral sulcus is going to be your landmark to curve upward. And then above the collateral sulcus is going to be your collateral elements, which will more confidently get you into the ventricle, which you see here. Once you open the ventricle, a gush of CSF is very rewarding. And that from there on, you're seeing the hippocampus and your work is much easier. So this is one of the most important steps. There are some pitfalls in that. If you don't go from the base and you go from the top, you can skive right above the ventricle, enter the insula and the posterior posterior limb of the internal capsule. Okay, so this is then widened. Okay, so for trainees, so think about it like this. The first stage is a temporal, anterolateral temporal neocortical resection. The next is then the hippocampal formation, and then the third is the amygdala. This can be done in reverse phases also. I know each each surgeon who's been doing this for a long time develops their own technique. It can be done with amygdala first also. Okay, so then you have now cut 3, which I do is along the planum polare. And from T1, we follow this, and you're heading medially. And then once you finish that cut superficially along the planum polare, then we again connect it back centrally into the ventricle. Okay. And then finally, you have just the last cut is just to connect these lateral ones and medial ones with a connection in between. Okay, and finally you're swinging this thing out, which is the temporal anterolateral temporal neocortex here, and you see the shining hippocampus in the center there. And this is the cut 4, cut 3 and cut 4. Okay, so let's come back to this. How am I doing for time? Okay, so we're extending from the center of the temporal horn of the ventricle, extending that into these lateral neocortical cuts. Here you can see the Sylvian fissure right here, and you're coming along that. And this is quite standard for many of the surgeons here who are already doing this. So just to go over the basics. Okay, there you can see the shining hippocampus. And then this is the stem of the temporal pole, and we're connecting that in. And take it a little bit forward now. Okay, then you have a last cut along the base. And then finally, this is released from cut 4, and then the whole thing comes out. So the ATL specimen is removed. Fine. Okay, now we'll go back. Now the next thing is we want to understand the mesial temporal anatomy. This was discussed earlier in the anatomy discussion. Important thing is to understand it like this. You have the hippocampal formation. Underneath that sits the parahippocampal gyrus. You have the entorhinal cortex, and then above the head, you have the amygdala. Sitting above that is a little leaflet of cortex called the piriform cortex. These are very important in seizure generation. So let's look at it from a bird's eye view. So this is my technique of how we started. You go to about the choroidal fissure here, and you have the hippocampal sulcus. Okay, and then we want to start about this point here. Open up the hippocampal sulcus, develop that, and then cut off the head in a subpile dissection. Okay, let's cut unfolding the hip, and then I unfold the hippocampal head, open it up like a book. Here we're opening up the hippocampal sulcus, because this is full of perforator vessels coming off of the PCOM artery, and if we do not do a careful subpile or release of that, then it can lead to the worst dreaded complications of vascular injury directly from the PCOM. And then there's a final disconnection of the tail here. So going to the video. So one of the most important things is the retractor placement. Now, I know some surgeons who just take out the amygdala to avoid this. I like to use the amygdala as a padding for the retractor. Okay, and then you see, and the important thing is to open up the choroidal fissure. Okay, and then open it up like a book. This is the subpile disconnection of the head. Now we're opening it up like a book here. This is, and then you can see the vessels of the hippocampal sulcus, and these have to be stripped. It has to be undressed one vessel by vessel, or just by peeling the pia down. This is a very important but rewarding step, because once this is free, then it just starts shelling out. Okay, you can see this is the pia of the hippocampal sulcus, and this is the parahippocampal gyrus down here. This is a suction tip which is made for that. And then we'll release it from subpially underneath the parahippocampal gyrus, move it along. Now, and then the lateral disconnection. So if we come here, now we basically just need to follow the groove of the hippocampus within the ventricle, laterally disconnect that, and then take it down to the medial surface of the collateral sulcus. And then you do the final snipping of the tail at the end. Okay, so this is just following that groove along to separate the. Now, if we go on the other side of the collateral sulcus, then we tend to increase the optic radiation injury and then field deficits. Okay, finally it's shelled out subpially, and then the posterior tip can just be snipped once it's loose, and then it comes out. So it needs to be really nicely released subpially. And then I still carry it on posteriorly until there's a transverse sulcus that takes off one of the first branches off the PCA, go over that so that you have a very good posterior extent of the parahippocampal gyrus resection, as that's been traditionally shown to be related to the chance of seizure freedom. So I still clear out the posterior parahippocampal gyrus along the turn around the posterior brainstem, the tectum. Okay, so in the interest of time, we'll speed along here. Okay, next is the last stage is then to take out the piriform cortex and the amygdala, which is the only thing remaining here. And that's why I follow the planum. You get a nice subpial dissection off of the planum here. Now, when I was recently in the US, I found a lot of surgeons are very nervous about this, the piriform cortex. But if you get the proper plane in the subpial plane, the whole, as you'll see now, the whole amygdala, piriform cortex comes down as a unit with some uncus attached to it. You're seeing the uncal recess here with the third nerve and all your vessels, and it comes off as one piece. So essentially right here, we're cutting the piriform cortex and the base of the amygdala. And I think completeness of resection here definitely leads to superior outcomes in the surgery. Okay, so that's the microsurgical technique. Outcomes are still quite good. Our outcomes are around 80 to 90%. I was involved in some discussions with this, with surgeons from North America about this. They have a hard time believing 90% seizure freedom in temporal lobe epilepsy. We have a hard time not believing or accepting anything less than 90% in concordant temporal lobe epilepsy. So I think surgical technique has a lot to do with it. And I think this is partly what is driving a lot of the minimally invasive techniques of thermal ablation also. Now, complications. Complications are it's one of the most rewarding surgeries, but if complications happen, it can be one of the most dreadful surgeries. And the worst is hemiplegia related to vascular injury or improper retractor placement. Okay, vascular injury being the worst. I have had hydrocephalus, and unfortunately, we've had actually one mortality, which is not really acceptable. It was related to the APOS and then unfortunate sequence of events in a slightly less fit individual. But so recently I was actually a fellow in the US working under Dr. Gross, who was one of the pioneers in the selective laser ablation. So I actually learned it and I was doing it. It's an intraoperative MRI-based procedure where you insert a laser probe, the lit probe, in a certain trajectory. And I'll show you the video. And it's generally in a posterior to anterior trajectory along the axis of the hippocampus, just above the hippocampal sulcus, and there are some basic techniques that are used to ensure that you can produce the maximum radius of thermal ablation. But that being said, you will read a lot. I present this only especially for the upcoming generation, because you will see this a lot more. In many countries, a good temporal lobectomy is unfortunately becoming a dying art. And I think I did come back with the impression that there are certain subsets of patients, for example, the high-risk patients, patients perhaps older than 45 years, who might benefit from thermal ablation as their operative risk goes up. But you should be aware of this procedure because you're going to see a lot more literature about this, and outcomes are coming out. We have adapted our own stereotactic RF thermal ablation lesion for epilepsy. I have used it very sparingly in temporal lobe epilepsy with actually good outcomes. This is an individual who was an engineer and who had he was already affected. His neuropsychological profile was affected, but in MRI normal hippocampal volumetry MRI in a high functioning individual, we had done a stereo EEG to see if we can further localize, and it was still mesiotemporal, and we offered him the ablation, and he's actually done quite well long term. So there are cases where a selective approach is good, and we feel that we probably, especially in the background, have his ongoing depression, maybe the neuropsychological improvement, which is a lot of what is promoting the technique of thermal ablation. In this particular individual, I still feel it probably was of benefit. But in the broader perspective, I think temporal lobe epilepsy is still going to be a significant component of epilepsy surgery, and our traditional temporal lobectomies are probably still giving the best outcome, especially in light of the possibility and the opportunity for drug freedom. At present, we offer, and I just recently did offer this, is stereotactic thermal lesioning for what I term high risk TLE. Our complication rate seems to be higher in patients over 45 years. I have even had hydrocephalus there for an unexplained reason, and so that is an option. But you will and radio frequency versus laser technology is basically a difference in the energy source and the company-driven industry sponsorship, to be quite honest. I think if you get good lesion volumes placed in the right locations, both have good promising things. There are trials which are going on right now looking at this, but not doing a head-to-head comparison yet, to my knowledge. So I think we need to have a lot of equipoise in taking decision on which technique to use, especially as the younger generation comes up. I think it is still important to learn very good microsurgical technique for the temporal lobe for both epilepsy and tumors, because without a doubt, it still does give superior outcomes in the long term. Thank you.
Thank you, sir. I now invite Professor Sarat Chandra to give us a talk about the evolution of hemispherotomy in epilepsy.
7.
So let me start my lecture. So good morning to everybody. Apologies. So I'll transfer my other lecture also. Ye wala. So at the outset, my greatest gratitude to Professor Ghosh, Dr. Anil Pandey, for having taken steps and pains to arrange this Congress. I know it's not very easy to do things like this. Right. So in the next 12 minutes, I'll be speaking about my journey of 20 years to show you one of the maximally invasive procedures which is possible in a brain surgery, which is disconnecting or removing half of the hemisphere. And what is the most minimally invasive strategies you could devise in order to achieve this? Oh, so ये क्या बाकी slides आए नहीं? क्या बाकी slides में कुछ आया नहीं? Okay, तो ये क्या new slides introduce कर दिया? So no disclosures. Now this was the first hemispherotomy which we did back in the year 2002. And this child had come with status epilepticus. We had to operate, I think late in the evening we started. I had to go through some articles and books and then go ahead and do the surgery for the first time. The child had complete cessation of seizures, was completely seizure free. And then we published soon afterwards the first series of hemispherotomy from India. And I have been working on this to see, I always felt that when you do such a surgery, we are doing it in kids who are just 4 years or 5 years of age, 6 or 7 years of age, and then you are doing a huge craniotomy. So I always felt that it's a very maximally invasive surgery and not at all compatible for kids. And that's where I started working upon my innovation on minimally invasive strategies, which I would be describing in the next few minutes. And I would really appreciate Professor Goyal in this, that whenever you try to do something new, it is very, very difficult. Not only for the fact that you have to actually see it for the first time, but also because of the fact that you have to take ethical clearances, you have to get all the processes in place. It takes so much of hard work. And then, of course, not to forget the criticism and rivalry which you could have. Sometimes, of course, that's healthy. And you always have this perennial question coming out from people once you present, saying that it's so easy, nothing so great about it, I could have done it. So innovation is not easy. So what people see is only the front. What people don't see are the hardships behind. Whenever you try to do something innovation, it could be simplest of the things. But when you want to do innovation, the road is always difficult. So I learned I was doing hemispherotomies before I went for my postdoc fellow under Dr. Mathon. And I learned the UCLA para-insular technique from him. And I used to do these cases. I have done about 7 or 8 cases. Still, I did it in a case of hemimegalencephaly. So where when I cauterized the veins at this and took out the central portion, this patient developed a large venous infarct, had to undergo a decompressive craniotomy, was on ventilator for almost 1 month, 2 months, discharged in not so good condition. He lived, but he was discharged in not a very good condition, following which I gave up the lateral techniques. I started doing the vertical technique because it was a totally avascular technique, and that's Dr. Mathon who had come to our home. And then this slide was given to me by Dr. Radhakrishnan, which shows the first hemispherectomy which was done in India by Dr. Jacob. And unfortunately, the patient died after 10 days because of meningitis. So then I went over to vertical hemispherotomies. There's a child where I did a vertical hemispherotomy. You can see 5 years afterwards, the weakness completely improved. And this journey is my trust with epilepsy surgery for 25 years for 4,500 cases. And just to show what goes into developing any kind of innovation, especially in some difficult areas where others have not broadened. So where did we start? We started with a hypothesis by none other than father of medicine, Aristotle, who said that you cannot create an empty space within the brain because nature abhors vacuum. And finally, in 1888, a German scientist, Friedrich Goltz, he performed hemispherectomy on a dog and it survived. It was weak on one side, which rapidly improved as it does on animals. And then it started feeding, started wagging its tail. And for the first time, he showed that this animal was actually living on half a brain. That was, I think, amazing. And then Dandy as he was, father of this society. Dandy, as he went and performed the surgery in 5 patients with glioblastoma multiforme. And one of them survived without radiotherapy for 3.5 years. And again, he went to show that these people actually lived with their personalities intact. And then we evolved. We came across the era of conventional hemispherectomies from 1950s to 60, where Mackenzie did the first hemispherectomy in 1938. And then Crenau from South Africa, where we had the World Congress last year, started doing piecemeal hemispherectomy, published 8 cases. And finally, it was people like French, Obrador, and Rasmussen who developed en-bloc hemispherotomies. We continued to evolve. So Oppenheimer, for the first time, described hemosiderosis. He showed that a significant percentage of patients, which could be from 16 to 33%, develop progressive cognitive deficits and have 100% fatality. On autopsy have shown cerebral hemosiderosis. So following this, people started devising techniques like Adams, plugging the foramen Monro and stripping the dura so as to create the large extradural space, or Iglenzi and Busey creating the hemidecortication techniques. And then finally, Rasmussen was a person who developed functional hemispherotomy in 1974. And this is not exactly the kind of functional hemispherotomy we do today. So you can see he has done a temporal lobectomy, he removed the central core, but definitely showed that he could leave at least 60% of the brain behind in the cranial cavity so as to achieve equivalent outcomes that of anatomical hemispherectomy. And he underwent tremendous criticism for this because there were people who said, unless you physically remove the hemisphere, the patient is not going to be seizure free. And when I was going through literature, I was surprised to see so many letters of editors of criticisms against Rasmussen. And then, of course, Delalande developed the vertical technique, which I followed once I had some complications with the lateral technique. And we know that the lateral techniques has been described by Willem Muir and also our own colleague from CMC Vellore. Now we have to understand that hemispherotomy is not a heterogeneous technique for heterogeneous pathologies. It could be for something as straightforward as post-infarct, where it could have very good outcomes, to something to intermediate outcomes for pathologists like Rasmussen, to again, it could be a very difficult surgery for hemispheric non-atrophic pathologies like hemispheric cortical dysplasia or hemimegalencephaly, which I think is the most complex of all. Now, in this largest study of hemispherotomy around the globe, in which we also participated, we showed that overall outcome is 64%, being best for post-infarct, which is 80%, and being least for hemimegalencephaly, which is 60%. But again, these patients go on having several seizures a day, so surgery is the only option for them. And for the first time, it also showed that a vertical technique definitely has a better outcome than the lateral technique. And then came this study, which we published. It has more than 1,000 citations right now, where we clearly showed that in kids, not only there is a 10-fold better improvement when you do surgery as compared to medical treatment, but also for the first time we showed that these kids, if they're not operated early, they are going to lose their cognitive faculties. So if you get a child of 4 years or 3 years having epilepsy, which is drug resistant, needs an hemispherotomy, you need to do it as soon as possible. You cannot say that I'm going to wait till the child is 9 or 10 years old, by which time the brain would be fried. So when we started thinking of the minimally invasive techniques, initially it sounded as difficult as trying to pass camel through an eye of a needle. So we started with the vertical techniques. Then I shifted to an interhemispheric technique. And finally, we reduced the size of the craniotomy just to 3 or 4 centimeters in size in order to do the endoscopic technique. And I'll run the video very fast at 4x speed. So you can see that we have a frontal trajectory, and that reduces the foot plate of hemispheric disconnection by almost 40%. So we do a 3 into 4 centimeters craniotomy, and under the endoscope guidance, we go interhemispheric. You're not seeing the ring around because it's under high magnification. Go into the interhemispheric area, open the arachnoid, split both the A2s, start cutting the corpus callosum from the genitidal splenium. The splenium has to be cut completely, and then take the endoscope forward till you visualize genu and the A2s curving around it. And then you start doing the anterior disconnection, which is anterior to the caudate head. which passes in the coronal direction. And then you start the middle disconnection, which is lateral to the caudate head and thalamus, which joins down to the temporal horn. And once you expose the temporal horn, resect the amygdala and the anterior temporal head. And finally, you end up with a posterior disconnection, which you disconnect the temporal efferents, which are coming and curving around the atrium. So we presented this for the first time at Gothenburg 2014, and then published a number of papers. We started initially for atrophic cases. That's the kind of cases. There's a pre-op and there's a post-op. Progressed to non-atrophic. So that's a case which I operated in Malaysia, having about 200 seizures a day. And that's a hemispheric cortical dysplasia. And you can see it's a very beautiful disconnection using endoscope. And the caveats is we described endoscopic and new techniques like endoscopic assisted corpus callosotomy combined with anterior hippocampal and posterior commissurotomy for Lennox-Gastaut for the first time in the literature. And we showed that whenever we divide the commissures, we are able to reduce the drop attacks by 100%. And then, of course, more papers and acceptability, it went into textbooks. And finally, it went into the Bible, which is by Professor Jerome Engel. And you can find chapter 219 written by us on hemispherotomy as well as multilobar disconnections. Now, we also described the value of leaving the residual temporal stem. Now, this was not described by anybody earlier in the literature. We showed by cadaveric studies that you have a temporal stem which is anterior to the amygdala. So that has never been dealt in the literature. And if the patient continues to have seizures following a hemispherotomy, and if the temporal stem is still present, you can go ahead and take out this portion of temporal stem, and the patient is going to be seizure free. And by doing this, we were able to enhance our outcomes from 80 to 90%. And we published, one of my fellows published this paper in JNS. So we showed that endoscopic hemispherotomy is safe, effective, minimally invasive, could be done for all spectrum of pathologies. And by addressing temporal stem, we increased the outcomes from 80 to 90%. And the repeat surgery is simple. But the question is, do we need to evolve further? Obviously, I always felt the need to evolve further because it requires a very steep learning curve. And I always believed that if something is difficult, it's probably not right, because the best of inventions were easy to use for majority of us. And that is why we decided to evolve. And I started thinking about this idea since almost 2017. And this was a workshop which we conducted in Banaras, in which John Stern, who is one of the primary editors, he was there. And I asked him, so we were having this chart in a center at Varanasi. And I asked him, I'm thinking of a bloodless surgery for hemispherotomy. Do you think it's possible? And John, by this time, I'd heard about he knew about my endoscopic techniques. He said, I don't know how you would do it. Maybe perhaps you have to use a smaller endoscope, which goes to show that you can never innovate unless you move out of the box. So then we devised, for the first time in the literature, the robotic thermocognitive hemispherotomy. We've done about 32 cases now. We published it. And this is a totally ultra minimally invasive surgery. We got the idea when doing the hypothalamic hematomas. And particularly when I was dealing with this giant hematoma, I thought I could do hemispheric disconnection if I go more laterally. So the idea was born because we had a robotic machine, we had a generator, and we were able to calculate the trajectories that the hemispheric disconnection footplate is just 1/5 of it. So all the trajectories are exactly same as endoscopic approach. You have an anterior disconnection, you have a middle disconnection, you have trajectories for temporal stem and amygdala disconnection. Corpus callosotomy is dealt with 4 oblique trajectories. And then we created the X technique where through a single hole, we are able to create diverging trajectories which can take care of the entire thing. And I'll quickly run the video. Of course, it shows the standard use of robotic using a drill we use it right through the skin. So no skin incision. We go right through the skin. That's the dura being coagulated. And then finally, we introduce the electrode. Now this electrode, unlike just a single lesion, has got multiple pen markings. So we calculated it in such a way so that we are able to produce a linear thermocoagulative lesions. Of course, it takes a long time. Initially, it used to take us as much as 8 to 9 hours or 10 hours. But with the X technique, we've been able to cut down the time by almost 30%. So within 4 to 6 hours, we are able to finish hemispherotomy. So I'm almost done. This is the last slide. So the most important thing I wanted to show here is there's absolutely no blood loss. Now we are injecting glue, and for sake of modesty, we said less than 5 ml in the blood paper, but it's absolutely bloodless. So few examples. So you can see this beautiful disconnection here. 30 to 40 seizures. Another example, right frontal FCD, hemispheric FCD. And then few more example, post-meningitic and Rasmussen's here. Now this patient, we had to do ROCH 2 times, following which, this flap was left behind with. This is because of differentiation atrophy. And every time we would put an electrode, this would be shifted because of the being in a cavity. So third time we had to do an endoscopic surgery, and following, we just disconnected this. Following this, the patient was seizure free. So we've done ROCH till now in 32 cases. It's the standard procedure for us for all spectrum of pathologies. Very minor complications, and the recovery is amazing. By next day itself, the patient starts opening eyes, absolutely no fever. Of course, in non-atrophic pathologies, we do have edema. That's why we cover them with mannitol and steroids, do a repeat scan on 5th day. Best part is no blood loss, single sutures, absolutely no fevers. So I will not deal upon the SWOT due to lack of time, but I will definitely say that it definitely seems to be a promising technique, most minimally invasive technique for the most maximally invasive pathologies. You could leave a skip areas, but with X technique, we are avoiding the skip areas. For me professionally, it's a big satisfaction because we moved from a hole in the brain to a line in the brain. So we have evolved, but with all humility, we should say that we are still here because this is the time we are learning just to grapple with our tools. And so we should not thump our chests and say that we have reached the pinnacle. I think we are still very much in the stage of evolution. And I'd like to thank every one of the people in our team. So this is our research faculty for without whom this quantum of work would not be possible. And we have fellowship programs for those of you who are interested. It's an entrance based. I would say we have the busiest functional division in the world. We do 3 to 4 cases a week, both DBS as well as epilepsy. And it's not very competitive. If you study well, you'll get through it. Definitely, it's going to give you a very good expertise in 2 years. So thank you very much once again for this opportunity.
Thank you, sir. I request the speakers, Professor Ashok Pillai, Professor Sarat Chandra, and Professor Manjri Tripathi to take part in the panel discussion, an interactive session moderated by Professor Ellen Tripathi.
It's good to read.
Good. What can I say about this session? It's really dumbfounding. Sharat, your contribution to the epilepsy surgery. And of course, you are backed by nobody other than Manjri, and you are a formidable, fast epilepsy couple of the world, maybe. And your innovations are absolutely, I'm flabbergasted, and we must give him a round of applause to him, to Manjri, and all his team in All India Institute for a very, very innovative, exemplary, and massive number of work in epilepsy for the deserving children and adults. With this, it's customary to ask questions to all the presenters. So I can ask Sarat while he's here before he leaves this thing. So which cases you found the most difficult to treat surgically, especially when Manjri told you must cure this patient?
So this is a perennial problem. It always goes on. So our epilepsy surgery meetings, we have massive fights. So we says, why can't we do this? Why do you do this? So why have you done this? But I think the most important part is you learn and you move ahead. So nowadays, every case, most of the cases we get are really difficult and challenging cases. We no more get, I don't know, Ashok, how is it with you? But for us, the mesial temporal sclerosis has literally dried up. We are getting, most of the cases we are getting are MRI negative, substrate negative. It has to go into an SCG mode. Then we are getting very difficult hemispherotomies. We got a patient of hemispherotomy who had a pulmonary venous anomaly last week. So while we were doing ROCH, patient had a cardiac arrest on the table, given CPR. But now the patient has recovered. Now he's seizure free. Fortunately, I may think it's not a credit to us, but what we are saying is there are a lot of challenging cases, and I think it's a learning curve. And we are learning a lot. We are really learning a lot because the cases which we tackle today, we never thought we could tackle them 5 years back or 10 years back.
It's fantastic achievement. And with this, I'll ask, sorry, Sarath, for a very short time. We should be very brief. So I can't ask you questions because I don't know much about epilepsy surgery, but I have a lot to learn from you. Thank you very much. May you take your seat, please. Thank you. And to Dr. Ashok Pillai, please. So we just heard from one of the masters of epilepsy surgery that MTS and the medial temporal lobe. It's the same, isn't it? Like you rightly said, this is a microdiscectomy for epilepsy surgery. But with the advent of new techniques and less invasive or apparently less invasive procedures, like you yourself mentioned about laser, your experience with laser and RF. So what is your, what is your impression? What is going to happen in the next 10 years? Please.
Thank you for asking that. It's one of the most important questions, I think. To answer Sharat's question, we're seeing less and less MTS, but I don't think it's going to go away like that. We still have a good amount. We're happy when we get it because it's the easier one. And the challenges are as the MRI becomes more and more normal, which we're getting a lot more and more. And then we're going into uncharted territory there. But coming back to techniques, I think the next 10 to 15 years will definitely show more, definitely less invasiveness, because even in my own experience, as I showed you, I have one unfortunate mortality from a temporal lobectomy, which I can never forget. And it actually didn't have anything to do with the surgery. The surgery was quite normal and quite clean. But so it's a question of segregating patients into higher risk, I think. That's what it is for me right now. Because having said that, having seen the outcomes and been involved in some of the writings, I don't think the outcomes with thermal ablation in the temporal lobe is going to be as good as the microsurgical thing. And you're dealing with relatively younger patients, and we should still give them the chance for higher. For me, the difference between a reported incidence of 65 to 75% seizure freedom versus ours of 90%, that's significant. And that only translates down into the chance of drug freedom also. And in temporal lobe epilepsy, and I've had this discussion with many other people in the field, it's unfortunately a dying art. And that will still give better outcomes, I feel. There's very little doubt about that. And even the trial which is going on, and there's a large industry sponsorship component to it also. I was just having a discussion about how many trajectories it takes to do a good laser. If you were to ablate what I remove, it will take 3 trajectories, and then it's not really So in the standard and in we use RF, we use thermal ablation more when our chance of a seizure-free outcome, it goes down, which is generally more MRI negative neocortical foci. So our chance has come down, and therefore doing a craniotomy and doing a resection, the risks go up. And that's where we use it a lot more. And we're finding pretty good results with it there. And but now I'm starting to extend that to temporal lobe also in cases which I characterize as high risk. But I think there should be a balance, and I don't think it should. I think you have to do what works the best.
I think we fairly put the point.
Yeah, I think you have to do what works the best, and going from something that has a better outcome to something that's new, exciting, but has a worse outcome is a step backwards.
So thank you also. That's wonderful. A lot of contribution to MTS surgery from his team. My next question is before. Yeah, please. Yeah.
My feeling is temporal lobectomy, to say that it's going to change very quickly may not be correct. It is the foundational surgery for epilepsy. And if you're finding the cases shrink, it is not because of absence of cases. It is because the referral pool is getting exhausted. Not even a tenth of the patients gets referred for epilepsy surgery. Those who require epilepsy, we calculate it as something like less than 5% of patients who really require epilepsy surgery. Yeah, ultimately we'll get you. Entire India will be doing something like, around 700, 800. We calculate approximately 700, 800 per year. So that means the pool is less than 1/10. So that's why you find a paucity of temporal lobectomy. And if you say epilepsy surgery is still a viable procedure mainly because of the MTS. The outcomes of MTS are so good. Hemispherotomy are comparatively rare cases. I will say the best outcome is for hemispherotomy. If you select a case properly, you will get more than 90% outcome. Following that is MTS. And MTS pool is much, much larger. And if you start off with other cases, extratemporal, your program may fail. For a program to evolve, you first have to stand on the bedrock of temporal lobectomy. And the surgeon conceptually evolves from the temporal lobectomy, from temporal lobectomy into the other multilobar sections, into focal resections in the hemisphere.
Thank you. I think this discussion is, of course, very interesting and a lot of positive points from it. But because of lack of time, we have to move on to the next session. Just before I finish up this session, wind up this session, I'll ask Professor Manjari Tripathi. See here? I'm sorry. So a silly question from a general physician, maybe. If somebody had a fit, you know how a fit is taken by physicians and referred to neurologists or accidental neurosurgeons. And patient has been on anti-convulsant treatment for no good reason. And if I see the MRI is negative, and there isn't any pointed towards, but your questionnaire point is very important to really consider whether it was an epilepsy or a fit or not. Especially if it happens again and again. How do you deal with it clinically
This
with
is
your
a
expertise?
This is a single seizure or repeated?
Repeated attacks of could be a false seizure, pseudo seizure.
Okay. So basically, there are some questions we ask in the clinic. If there are repeated seizures, do they occur in sleep when the person is in deep sleep? Do they occur when the patient is alone, not surrounded by his relatives or friends? Do they occur with urinary incontinence in any of them, with tongue bite, with injuries, with not so prolonged episodes, brief? Even the biggest generalized seizure will last for not more than 2 minutes. So if the episode is occurring for 15 minutes, half an hour every time, and the patient is bang normal after the episode, it's more likely to be pseudo if there are no injuries, no tongue bite, none of them in deep sleep, and bizarre movements. Each seizure is different from the other. So once it's his head nodding, the other time it's the hand moving. So, and of course, there will be sympathy given by others. So pseudo seizures will always occur in the presence of his friends or empathizers than when the patient is alone. So these are few questions we ask. And if it is true, then we tell them that next episode, please bring a home video. In the home video, we observe that the eyes are closed during the event. Very often they're crying. So crying during an event is an emotional expression of sadness with closed eyes, with bizarre movements, with prolonged episodes would confirm your diagnosis of psychogenic seizures.
Thank you. There's a lot to clinical assessment then at the end of a SPECT or PET or everything that you have within
I've seen a patient undergo a VNS for pseudo seizures. So that's why I keep telling.
Thank you very much.
Surgeons must know.
Thank you. So, Sukhdeep, I just have to congratulate you and Abida and your team for the lovely 3D work and fiber dissection work. Do you have any comments? Have you got any good, residents, students to follow it up? Because we need to look at, succession. Not yet.
I think for this, limbic lobe is very, special for us. This was the first dissection which I did in my cadaver dissection, which Professor Goyal told us, you go to the lab and, do these dissection. Only then you can see this epilepsy surgery. So I think it is important from residents also, from the teachers also, that they encourage their students to go to the lab and study anatomy, because most of the residents, they are busy in their day-to-day work. So once they are guided in that direction, of course, they will learn. So limbic lobe is really special for this thing. Thank you.
Thank you, sir. Let's now have a quick break and we'll be back at 12:05.
I'll begin, sir. Right. Now we're moving forward with the session on endoscopy. Before we begin, once again, I'd like to request all the speakers to adhere to their allotted time. Can I please invite Dr. Narendra Kumar to deliver a talk on endonasal surgical anatomy?
So, fine. Good morning to everyone present here. I'm Dr. Narendra Kumar from Chennai. I'm a ENT and skull-based surgeon. So, my sincere thanks to Professor Ghosh for giving me this great opportunity to give me a talk on this. I'll be talking about endoscopic endonasal anatomy, especially completely an endoscopic anatomy. So, the Google map, we all know that we are using from the airport to this hotel. Everyone will be using it. But this can be considerably like a navigation in our surgical environment. A navigation can also guide you to where we are exactly. But sometimes if you are trusting on this tool, you may end up at like this. So we have to know about our own surgical anatomy. That's very important. We can't able to relay or to completely accept with the tools. So we have to know perfectly the each and everything of the anatomy here. Most of the neurosurgeons, you will be go with the axial view, but we, the ENT and endoscopic cell-based surgery, mostly we consider about the on working with the coronal views. So before going into the endoscopic anatomy, a glimpse of the nasal cavity, I'll be explaining you. This is nothing but a septal cartilage here, and this is perpendicular for bone of ethmoid, and here is a vomer. The flap over this will be taken for as a Haddad flap. So this area is very important for us, and these are the three turbinates. So superior, middle, and inferior. So the main blood supply to the nasal cavity is a sphenopalatine artery, which is artery of epistaxis also called as. And with this is very important in rising the Haddad flap. It's based on this artery, nasoseptal branch. And you can see the olfactory bulb coming from the cribriform area. This is more important for skull-based surgeons to know that anything we are working superiorly can injure it, and so the patient may have loss of smell also. So we are going to work inside the room. So the pathway has to be very much preserved. So as a skull-based surgeon, we have to know that the pathway is nothing but the nose. So nose has its own function like olfaction, breathing, air condition, ventilation. The main thing is vocal resonance. So anything disturbing on this way, the veranda, can affect the further the function of the nose too. So there are three stages in understanding the anatomy. The first one is a nasal stage. The second one will be the sphenoid stage, and the third one will be the cellular stage. The first one is in coming to the nasal stage. This right nasal cavity, you are seeing inferior turbinate. As I said, inferior turbinate will be the first structure. When you enter into the nose, you will be seeing the inferior turbinate. The lateral to it or and the medial to it is nasal septum. You have to go in between it. You should not touch both the thing. So you have to go in between it. So before starting the surgery, so you have to decongest the nose nicely so that you can have a wide area of surgical field. So going it towards in between, you will reach the choana. Choana is nothing but a nasopharynx. If you reach the choana, you will be seeing the eustachian tube here. From the choana at the roof, if you go 1.2 to 1.5 centimeter above, you will be seeing a sphenoethmoidal recess. Nothing but the recess just in going in front of the sphenoid ostium. You'll be seeing it little above the roof of the nasopharynx. See, this is a roof of the nasopharynx. If you go little above, you will be seeing the sphenoid ostium, which is a field of interest for the skull-based surgeon. So inside that, you will be seeing a glimpse of a sella. We will be seeing in the next sessions. So this is the first stage. So this is a small video. I'll be showing the nasal septum here. All the way I'm going in between the septum and the inferior turbinate. This is a nasopharynx, and what I'm touching is a torus tubularis, the roof of the nasopharynx. This is the inferior meatus. So this is a middle turbinate. If you go medial to the middle turbinate, you will see the superior turbinate. Medial to it is sphenoethmoidal recess. That is a sphenoid ostium. So very simple. And if you go little lateral to the middle turbinate, you will enter into the osteomeatal complex, which contains uncinate bone, bulla ethmoidalis. The only mobile structure in the lateral nasal wall is uncinate bone. So if you open up the uncinate, you will enter into the maxillary sinus. So this is a one. This is called as diagnostic nasal endoscopy. Before starting, you can do this. You can have an idea what's the exact anatomy is. So always the paranasal sinuses is like a house. We have rooms inside. So each rooms, if you want to enter into each room, you have to open the door. Generally, there are 4 doors in it to enter into the sphenoid sinus. The first door with the green color is uncinate. The second one, yellow, is a bulla ethmoidalis wall. First is uncinate, the second one is bulla. The third one we have given us in a red color, that is ground lamella. Ground lamella is nothing but the middle turbinate goes and attached to the lamina papricia. This wall is called as ground lamella. So we have to be little cautious in opening it. Sometimes it can injure the skull base too. So we have given the red color. The third one is ground lamella. The fourth one is superior turbinate. So uncinate, bulla ethmoidalis, ground lamella, and the fourth one is superior turbinate. So you will be seeing this in this video. So inferior turbinate, you will be seeing the middle turbinate in center. If you push it medially, you will enter into the osteomeatal complex. But if you push it laterally, you'll go into the fourth door, superior turbinate, very simply. You don't need to open any of the sinuses. You gently push the superior turbinate, but make sure that you are always in the inferior. Don't go superior and push it. Go inferior. You'll straight away see the sphenoid ostium here. Very simple. No need to open any sinuses at all. Straight away, you will be seeing the sphenoid ostium. So the next stage is sphenoid stage. When you do the posterior septectomy, so you will be connecting both the right side and the left side of the nasal cavity at the end. The posterior end of the septum is removed. So you can introduce the endoscope and work on the instrument on the other nostril, the binostril technique. If you see like that, you will be seeing both the ostiums together. We call it as owl's eye appearance of the sphenoid ostium. So if you enter inside the sphenoid ostium, you may have some septations, but always mandatory, the sphenoid septations will not be equally in the middle or always in the right, always in the left, not like that. And its attachment also varies. I'll be dealing it simply here. And the floor of the sphenoid sinus, make sure do not pull the mucosa. Always cut it, and superiorly or laterally you can widen it. But inferiorly, make sure you should be very cautious because we are having a branch from the sphenopalatine artery, the Hadad flap, which is elevated depending upon this artery. So we have to be very cautious in it. As soon as you widen the sphenoid ostium, you will enter into the sella. So you will be seeing a carotid bulge here, optic nerve, and opticocarotid recess laterally and medially. All these structures, exactly the sella, everything will be seen on this view. So until you reach this view, we have to remove all the lateral structures, especially in the anterior wall of the sphenoid sinus, so that as soon as you see the skull sella like this, don't ever go and start drilling the stella. So if you have any bleeding or anything happens, we can't be able to instrument and go into that field. So we have to wait until we have a wide area of the surgical field, then we can enter into the cella. The third and the last stage will be cella. Of course, this anatomy is very simple. You will be having a pituitary gland over here. This is a clivus area, the cellas area, and the sphenoid cella. This way planum cella area. If you enter still more, you will be seeing the chiasmatic, optic nerve, internal carotid artery, and the pituitary stalk over here. So as I discussed, there are various septations in inside the sphenoid sinus. In coming to the deviated nasal septum, you have to be a little cautious. If the septum is very much deviated, you avoid taking a harvesting a hard hat flap on that side. So like that, simple precautions in diagnostic nasal endoscopy itself, you have to understand. And this attached to the internal carotid artery. If you pull that septation, that's it. The internal carotid artery may injure. So you have to always drill and you have to enter it. These are some of the structures going inside due to the time restrictions. The next is sphenoid sinus pneumatization. You have to plan it before the surgery, whether it is very cellular, very pneumatized, or pre-cellular or concul. On concul, it will be very difficult for you to reach the cella as the anatomy will be very much malformed. So if you have a concul or something, you can go transcavernous also here like this. And this is a fantastic view of a carotid artery. And you can differentiate the one is suprachiasmatic, 2 is infrachiasmatic, 3 is retrocellular areas, and the 4 is intraventricular. You'll see some of the structures here. I'll be a little fast in this because of the time restrictions. This is suprachiasmatic, optic nerve, all the way coming chiasma, optic chiasma, and pituitary gland here. Something infrachiasmatic, your main artery, you will be seeing the superior hypophyseal arteries here. And this is, if you go little retrocellular, you'll be see the mammillary bodies and posterior cerebral artery, basilar arteries. Still more, you will be seeing the thalamus and the foramen magnum. So you observe here, this is an angled endoscope. How to use this? You have to always place or fix the head at one place. You see my one hand is not at all moving it. The second hand, you can tilt the light source. So the angulation will be changed. With this, you can navigate inside the nose to see everything. So for example, so this is a simple view. Straight away we are going it, but you can see that the angulation will be changing, but the view will not change. Just if you navigate simply fixing the head of the camera, or you will be seeing the opposite side of the eustachian tube. From one side you can go above because of the angled endoscope. So these are some of the approaches. We all know that's transfrontal, transcribriform, transplanum, transcellular, and transclival, and transodontoid. These are the sagittal views. Some of the coronal views are supraorbital approaches, transorbit approach, and middle coronal is transpterygoid. I'll be dealing with this topic in detail in the next talk, and posterior coronal views also. You can see with this view, first, we initially started with the state 0 degrees. But if you remove the small component of this place, we used to call pre-lacrimal. This is a lacrimal gland, so pre-lacrimal approach. Or if you remove some of the bones here is modified Denkers. So all the way the door will be open up the maxillary sinus. You can enter both the instruments, the endoscope and the instruments. Or if you want to go far lateral, you just remove the septum here and you can insert the endoscope from this side. So you can enter straight away here. So this is also can be done here. So some of the orbital approaches, we differentiate with the clock. 1 to 6 o'clock, we can approach it with the endoscopic thing. Of course, this is for reconstruction. Hard art plays very important, and it is a versatile flap. So this was a hard art flap we used in a pituitary case. So this is a bimanual technique. Always we use bimanual technique so that 4 hands will be using it. So this is a surgical thing, because rather than pulling it with a one endoscope and one instrument, if the endoscope is shown by the ENT surgeon, you can work like a microscope. The neurosurgeon can work like a microscope, one instrument and one suction also, like that you can work it out. So we will be giving a good view. And just to compare some of the small thing about the microscopes and endoscope, previously you assume this is a Taj Mahal is like a pituitary macroadenoma. What I said, the veranda, you should never destroy the veranda. You have to open up, you have to remove certain unwanted things, and wanted things has to be retained. The mucosa has to be retained. The entrance is nothing but the nose. So if you go in the axial view, you have to enter in this way and you have to reach the pituitary macroadenoma like that. So initially the microscopic view will be like this so that the targeted area will be less seen. So it was initially like this, but with the use of endoscope, we can go in depth and the panoramic view can be also seen, but the endoscope usage is restricted also. So if this is, if you use an angle endoscope, you can see down also. So to conclude, the nose is a natural pathways and passages. So no external scar is used, and panoramic view gives better visualization. Hospitalization also will be good, and morbidity is very minimal when comparing to the other method. And if it is a recurrence, as we use a normal passage, the recurrence and revision surgeries will be easy. So only bad guys don't deserve a nose. Our patient is always a good. So take care of the nose, which is very important, and make sure that you know the anatomy, or else we will end up in some of the complications. And this was a book written by me and published last year. We have all 100 unique cases with the complications, how the complication had and how the surgeon managed it. And thank you one and all, and a special thanks to Professor Ghosh for giving me this great opportunity. Thank you all.
Thank you, sir. Now, may I please invite Dr. Siddharth Sahu to give a talk on endoscopic transperineal surgery.
A very good morning. At the outset, I would like to thank Professor Siddharth Ghosh, Dr. Pandey, and the local organizing committee for this invite and this nice hospitality in this beautiful city of Shillong. So I'll be talking about endoscopic transperineal surgery, the basics, and it's mainly targeted at younger neurosurgeons and those who are in transition from microneurosurgery to endoscopic neurosurgery. Well, so common procedures performed by this endoscopic endonasal route by neurosurgeons are pituitary adenomas, most commonly the non-functioning pituitary adenomas, CSF rhinorrhea, optic nerve decompression for traumatic optic neuropathy, and cellular craniopharyngiomas and radcliffe cysts. I'll not go about details of the extended endonasal procedures. Those have been already covered, and my subsequent speakers will be covering that. So preoperative investigations, as we all know, MRI itself is enough in coronal and sagittal cords. See the status of the nasal cavity, any deviated septum, see the condition of the sella, I mean the sphenoid sinus, whether it is how it is pneumatized, what is the condition of the septa inside the sphenoid, the consistency of the tumor, you can get a very well knowledge from the T2 hypointensity or the hyperintensity of the tumor. See the intercarotid distance, the distance among the carotids in the intercavernous segment. CT mostly not required. Angio occasionally required. Sometimes if you have another suspicion or you are seeing additional vascular anomalies in the supraclinoid ICA or in the cavernous ICA, you can consider doing an angio, but routinely not required. Besides, routine evaluation for a pituitary cellular supracellular mass like hormones and visual assessment and routine patient clearances. Intraoperative checklist, this minimizes your misses or near misses. So patient safety checks. Now, if you're planning for navigation, For routine pituitary macroadenomas or microadenomas, you don't need navigation, but when redos or patients who have had multiple surgeries earlier, navigation is of great help. And if you are using navigation, your head needs to be fixed. Otherwise, simple head positioning on a head ring suffices for routine endoscopic surgery. You prepare your thighs and abdomen, then there will be throat picking, and ask your anesthetist for ET tube positioning. You're a right-handed surgeon operating. Mostly we'll be using endonasal binostril approach, so the ET tube must be fixed to the opposite side. And get your equipments, endoscopes at least a 0 degree and 30 degree, unipolar, bipolar, micro instruments, and glue and hemostats, dural grafts if you need at your disposal. The operating room setup, it is like this. The surgeon is on the right side, right-handed surgeon, and your anesthetist will to the front, and the nursing with the equipments on the foot end. The nasal stage is already detailed by my previous speakers. I will not go into the details. We are doing an endonasal binostril approach. Identify the middle turbinate. As you introduce your endoscope, you can do it yourself as you gradually see and orient yourself toward the endoscopic anatomy. It's not difficult. As you enter the scope, a 0 degree scope into the nasal cavity, the first thing that comes down inferior along the floor is the IT, inferior turbinate, and the immediately above is the middle turbinate. So identify the middle turbinate, and then our route, the usual route for pituitary macroadenomas is medial to the middle turbinate. We are not going to the lateral territory or the lateral corridor. That is for different pathologies. Most of the pituitary pathologies can be well handled by this medial corridor only. By lateralizing the MT, we will create enough space, and you don't need to resect the turbinate. Sometimes people resect the middle turbinate, but usually if you are using a binostril approach, you don't need to resect the turbinate, preserve the turbinate, lateralize it, and it serves as a guide when you are lost inside the operative field. You're preserving the middle turbinate. Put some adrenaline soaked patties and lateralize the MT. You create the space and localize, you directly reach the sphenoid ostia. And you can see here the nasal septum on the medial side. This is the left side sphenoid ostia, well visualized. The choana is below. Sometimes you don't see the ostia, so you can start elevating the septal mucosal flap 1 to 1.5 centimeter above the choana, above the superior surface border of the choana. And a posterior septostomy. In a short video, we'll see the nasal stage being done. So this is the medial turbinate, this is the inferior turbinate, this is the nasal septum, putting some adrenaline soaked patties medial to the middle turbinate and doing the same thing on the opposite side, lateralizing the middle turbinate, and you are creating the corridor and you get to the ostia. So nothing very difficult. Once we orient ourselves to the endoscopic anatomy, we start developing the flaps below the ostia. Our area of focus is this rostrum of the sphenoid and the mucosa of the rostrum of the sphenoid. Routinely, we don't use Haddad flap for pituitary adenomas. Mostly you don't need, because mostly there are no CSF leaks, or some minor leaks can be very well taken care of with fascia and fat. And if you're doing extended endonasal procedures, you will need Haddad flap. So once the sphenoid rostrum is removed, the mucosa is stripped, you enter the sphenoid, the sella. So once inside the sphenoid sinus, we must, as rightly said, the sphenoid septa, they are present, but they are not in the midline. They are vertical septa as well as horizontal septa. And the vertical septa, if they are present, they're mostly eccentric and paramedian. And sometimes the septa might be leading towards the carotid and towards the optic canal. So while breaking the septa, you have to be very gentle, and you don't need to remove all the septa inside the sphenoid sign, inside the sphenoid. You only remove the septa that are obstructing your access to the sellar floor. Identify the sellar floor. In macroadenomas, it is very well expanded, so it will be easily in sight. In microadenomas, it is a normal appearance, so you have to identify all the landmarks and then proceed. So identify the optic nerve, the cavernous ICA, and the OCR. So this is the endoscopic view. This is the 12 o'clock position. This is the 6 o'clock position. Here's the planum, the sellar floor well expanded. There's the septa, and inferiorly here it is the clivus. This is the boomer base. It acts as a marker to orient yourself towards the midline during the endoscopic surgery. And here it is the optic nerve, the OCR, and the cavernous carotid. So the sellar stage, we drill if it is the microadenoma, sellar floor is thick. Otherwise, it can be simply removed with a Carician punch. Dura is opened, either it is a cruciate or it's a linear incision. And tumor evacuation, traditionally, we go first the basal part of the posterior part, then lateral and anterior to keep the arachnoid sac prolapse till the late stages. till the last stage. Use a 30-degree once you are done with the basic tumor decompression to inspect the supracellular and the paracellular spaces, and then descent of large supracellular component can be facilitated by either a Valsalva maneuver, or if you have put a lumbar drain and inserting fluid or air inside it. But in my experience, I don't use a lumbar drain routinely, and it hardly helps to in descent of the tumor. So once you see the arachnoid descent, work for CSF leak, and even if there is no CSF leak, put a fat graft for some minor missed leaks that will be taken care of. Nasal flap for the reconstruction stage, not routinely required. If it is required, you have to take it when you are doing a extended endonasal approach based on the sphenopalatine artery. And fat and fasciolata already harvested, or you are planning to harvest either from the abdomen or from the thigh, and medialize the MT after the end of the procedure and put a nasal pack, and your procedure is over. We'll go to the surgical video. This is a 68-year-old male who come with a large tumor. And there is a septa, there's a sagittal view. The nasal stage is done. I'm going in, the posterior septostomy done. So now I'm on the sphenoid rostrum, taking out the sphenoid rostrum. As you take out the sphenoid rostrum, you will enter into the sphenoid. Now, once inside the sinus, there is a midline septa. The mucosa is gently being removed, and the septa is also being removed. Now, once having cleared that, the cellular floor well expanded. There is some septa in the midline. This cellular floor is eroded. There is a focal erosion of the cellular floor. So that's going to facilitate my removal of the cellular floor further with a simple Carrison punch. Now the dura is open in a linear fashion. And then you start removing the tumor with softly, as gently as you can. There is nothing much to pull when you are doing a endoscopic surgery. You cannot pull. Luckily, these pituitary tumors are very soft, and they easily come out with dissection with curettes. And once done the posterior part or the basal part, then we are going to the lateral corridors, and then we'll go to the superior or the anterior part. So gradually you continue with tumor removal, ring curettes, and sometimes if the tumor consistency is very hard, you may need the use of a CUSA, but many times it's not required. You can simply dissect it out with ring curettes. So continuing with the dissection, once you are done with the tumor resection, then you will see you will use a 30-degree to go inside the cella, and you are holding the 30-degree. When you are holding the 30-degree, you remain, your hand should be along the floor of the nose. When you're holding a 0-degree, you are remaining at the top of the nose. So that when 30-degree you are presenting with the lens up, you can see very nicely the supracellular compartment. You can nicely see the diaphragm ocelli, and you turn it, you see both the cavernous sinus medial walls, so that you can visualize if you have cleared the visualized area of any residual tumor. So now we are removing the tumor piecemeal. So I'm using a biopsy after I dissected the tumor with the ring curettes to remove as much tumor as you can without much force or much pull. And then I'm going with a 30-degree. You see above now the repairing stage, there's the arachnoid descending, putting a fascial graft in the dural defect, and then supplement with some fat graft, and then close it. So mostly, if you are gentle, there are no CSF leaks. For any small independent leaks, this fat and fascia are sufficient. I don't use glue usually. And some fat graft, and that completes the procedure. Okay. So the postoperative checklist: check vision and pupils, monitor urine output for immediate post-op diabetes insipidus, hormone supplementation as post-operative, as pre-operatively if the patient was already on some hypopituitarism or there has been some apoplexy. Post-operative CT to rule out any major issues. By routine MRO, I do after 3 to 4 months of the index surgery. And nasal pack removed on POD2, and serum sodium to check for delayed symptomatic hyponatremia on a POD2, and again around 7 to 10 days to keep a watch on symptomatic hyponatremia. So some cases, these are the pre-operative and post-operative MRs, sagittal and coronal views. So another case, case. So major things that keep us the surgeon worried is the bleeding and CSF leak during endoscopic surgery. Bleeding, minor bleeding can be very well tackled with gel foam, bipolar, Flowsil. DSA and PROCEED has not yet been required in my personal experience of around 100 cases till now. But if it is available as a standby mode, and if you are having a major injury from the ICA, you can always take the patient to the cath lab and ask your colleague to put a FD or a stent. Then CSF leak, most of the CSF leaks are done, taken care of with the intra-op repair. If there is a leak and lumbar drain, minor leaks can be taken care of with the lumbar drain, sustained for 3 to 4 days, and not sustained, you can do a redo repair. Extent of resection, the basic theme is whether you are using the NASP grade or you are using the Juris pituitary score. It's like the more the lateral spread of the tumor, the more the cavernous sinus invasion, the extent of resection falls drastically. So if you are talking about a NASP 3B or 4, the extent of resection falls down, the gross total resection around 50 to 30%. So if you have a residual tumor, the further options are customized based on the patient and the tumor characteristics, depending on how multi-compartmental was the tumor, how much residual is left, what was the supracellular and what is the paracellular extension, and what is the biopsy report, whether the tumor was an invasive one. So whether you are planning for redo surgery, if there is a major supratentorial supracellular component with mass effect, you can plan for a revision surgery by transcranial approaches. And if the tumor is invasive and subsequent surgeries are difficult or impossible, you can plan for adjuvant or salvage radiotherapy in either form, whether it is SRS, SRT or fractionated radiotherapy. Surveillance is also an option if the tumor there is a small residual, it has descended down, it is not causing any pressure symptoms on the optic apparatus, patient is not having any refractory headache, you have done an endoscopic good job, but there is a small residual, you can put it under MRI surveillance. And if it is documented progression on the subsequent MRs, you can plan for your second line of treatment. So finally, the roadmap, watch a lot of surgical videos and atlases, orient yourself towards the endoscopic anatomy, cadaver dissections a must, and practice equipment handling, because when you're transitioning from microscope to endoscope, the equipment set is different. The hand-eye coordination is important in endoscopy. And start with macroadenomas with a well-expanded cella that gives you a very nice corridor. ENT surgeon or a fellow neurosurgeon can assist you for the first few cases, and there has to be a fine balance between your aggression and the local resource availability in your working setup. So I conclude my talk with that, and thank you for your attention.
Thank you, sir. Thank you, sir. Next up, can I please invite Professor Dandabani to give a talk on expanded endonasal approach to giant intracranial tumors.
Once again, I thank once again I thank Professor Ghosh and Professor Pandey for giving me this opportunity. I'd be talking on our experience of expanded endonasal endoscopy for giant supracellular tumors. So the superiority of endonasal endoscopy over microscopy has been well demonstrated in literature, even in our own systematic review, when we compared the extent of resection in relation to cavernous sinus invasion for tumors, pituitary tumors without cavernous sinus invasion. Microscopic surgery is as good as an endonasal endoscopic surgery. But the more lateral the tumor goes, then the advantage of endoscope comes in. I have already highlighted, if we are using only 0-degree endoscope, then it is not having that much potential compared to microscope. But when you start using angled optics, the superiority becomes obvious. And in all kind of tumors, the now endonasal endoscopy has been noted to be superior in results to microscopic transsphenoidal. And another thing is navigation. Of course, any technology has a limitation, but a technology can always make a good surgeon better. And even in our own department, there was a debate whether it really helps. When we did an analysis of cases, when we used navigation, and even in relation to the extent of resection, we realized that the difference between gross total resection and subtotal resection is purely based on an extra 2 mm of bone removal. It is not a see, most of us are very good with anatomy, but that extra 2 mm bone removal which you do with because of navigation gives you that added edge towards gross total resection. And we have published this, that navigation, it really helps the more complex the tumor is, and also the angled optics, especially for large and tumors which are going laterally. And knowing the plane of the lesion is very, very vital. As I have already highlighted during the spinal intradural tumors, if you know the plane, you remain within the plane, it is unlikely to that you will have complications in most of the tumors. Most of the tumors, I think Professor Goel sir has always been highlighting that most of these tumors, they respect the plane. So even in giant tumors, sir had shown that the diaphragm is intact. So most of these tumors, this can become a rule of thumb. Some tumors are intra-arachnoidal like craniopharyngiomas. Meningiomas are extra-arachnoidal. Pituitary tumors are extra-dural, extra-diaphragmatic. So understanding that becomes very vital. And in sagittal plane, as you see, meningiomas are in the extra-arachnoidal plane. From this area, tuberculum, planum, diaphragm sellae, all of this, they lift the diaphragm up. In so many tumors which are small, we remove the tumor, you don't see any structure because the arachnoid is intact. You should not open the arachnoid just to see or just for teaching purposes. Of course, large tumors, the arachnoid becomes very thin, I agree. But most of the tumors, you can do an extra arachnoidal surgery for meningiomas. But when you are talking in terms of craniopharyngioma, they are totally different. They are intra-arachnoidal. They always arise in relation to the floor of the third ventricle. Understanding that becomes very vital. So even if the tumor is in the third ventricle, they are arising from the floor. So you can always find a plane from the floor to get into the third ventricle. It's impossible that there will be a tumor within the third ventricle, but the floor is normal, because the origin of craniopharyngiomas is like that. Choroid plexus papillomas can happen like that, but not craniopharyngiomas. And always the stalk is close. You may be able to preserve the stalk in most of the small, medium-sized craniopharyngiomas. The advantage of endoscopy is, in endonasal endoscopy, you see the stalk very early. Then you decide what to do. And there is abundant evidence in pediatric craniopharyngiomas that whenever the tumor is involving the posterior floor of the hypothalamus, the mammillary body area, there is metabolic syndrome and the outcome is not that good. So you have to be conservative in that area. For all other grades, you can be aggressive because first surgery is the best. And the another advantage of endonasal endoscopy is that you see the satiety center. See, you see the mammillary body here at the end of surgery, and you know how much invasion is there here, and satiety center is just here, this area, just close to the mammillary body. So you can actually see it, but it is impossible to see these structures when you are coming from transcranial approach. But again, how much you are going to use it is debatable. But in endonasal endoscopy, you have the option of knowing how much invasion is there and deciding whatever is optimum for the patient. And different craniopharyngiomas have different, they remain in different plane. For example, here the lilicus membrane is intact. You don't see posterior circulation. You should not open up the arachnoid just to see the basilar tip. Here, this was a retrochiasmatic and retroclival craniopharyngioma. So here the lilicus membrane was defective. And so different types of tumors need different strategies. And angled optics, if you so, most of these tumors supracellular, we look from below above. So the scope is in the floor, the instruments are on the top. This is at the end of resection, and we see that there is a chiasm, there is stalk, and there is superior hypophyseal artery here, and there is ACOM complex. The undersurface of the optic chiasm, you see preserved arachnoid with all its perforators. That is another advantage of endonasal endoscopy. This is another tumor in which it was a retroclival tumor with the angle posteriorly looking. You see that iliacus membrane was defective. So we can see the whole posterior circulation with all the nerves very good. But we should not kind of try to see. Depending upon the tumor, you may see. And sometimes calcified craniopharyngiomas may be stuck to the undersurface of the chiasm. This is one area. The transcranial approach will never give you the visualization unless you put in endoscope. The undersurface of the optic chiasm dissection, whether you want to do sharp dissection or blunt dissection, is up according to you. But you see, and then you can cut it here. And this is the posterior circulation PCOM. And this dissection also you can visualize and dissect in these kind of cases. And this is a case of cavernous sinus invasion. You see all the compartments. This is the ascending segment, posterior genu, horizontal segment, and this is the lateral compartment, superior, posterior, inferior, and this is the sixth nerve. So you are looking laterally because of the angled optics. And this is also another, because most of the pituitary tumors, when they invade cavernous sinus, always they open up a corridor in which you can look and you can resect. And this is a case of meningioma, tuberculum cellae meningioma, though it appears complex. And we studied CT angiography. We always do CT angiography navigation and see that there was no definite encasement. There were two lobules which were trying to go around the tumor, but it was not encasement. Most of these tumors are very fibrous and firm. So internal decompression is the rule, but it doesn't work. Most of these are firm, but sometimes you can use sharp internal decompression just to make the tumor have some space in the center. And we have kind of made it simple by our kind of 10 Ds. We first delineate, flap, drill, durotomy, devascularize the tumor, decompress it, and detach it from all the edges. And dissection constitutes 70% of the surgery is dissection. We dissect all around so much so that most of the surgery is dissection. Then you deliver the tumor. Whenever there is some vascular kind of adherence, first identify the proximal portion of the vessel and then dissect it. Like here, this is the chiasm. This is the A1 on this side, which we have noted. This is the ICA, optic nerve. And this is the A1. You identify the plane and be sure that to get the plane and then roll the tumor all around. This is the last portion. This bimanual extra-arachnoidal dissection is very important. You peel off the arachnoid around the tumor so that all the vessels and perforators are also mobilized. Now we are rotating the angle and looking at the contralateral side and then seeing it, and then last portion is this ACOM complex. Then finally the tumor is delivered and then optic canal is disengaged and then reconstruction is done. So this is the last portion where we are disconnecting. And this is another case of a giant papillary craniopharyngioma. As you see, the suprasellar cistern is free, but the third ventricular floor, this is the tumor origin is there. So here you can always get a plane and then you enter the third ventricle and try to go around, dissect and remove the whole tumor. And here we decided to sacrifice the stalk whenever we want to achieve gross total resection. This is another case of pure third ventricular craniopharyngioma. And this was a child of a 15 months old child. We wanted to be conservative, conical type of sphenoid sinus. So we did intracapsular extra-arachnoidal resection. And then here we see that we remained within like a pituitary tumor and tried to curate out the tumor with angled optics. And cavernous sinus invasion, we can enter the cavernous sinus in different strategies. Giant tumors have their own unique strategies. And the base of the tumor is very important. Whenever it goes superolateral to the optic canal, better to do transcranial approach. Sometimes you do combined approaches. And sometimes you get conical type. This was a case of McCune-Albright syndrome, where even transcranial would have been difficult. But we decided to make a tunnel with we drilled it and removed this large tumor. So there are contraindications in giant pituitary. We always drill and open up the tuberculum planum area. And these are the sequential steps for giant pituitary with cavernous sinus invasion. And for cranio, we always enter through the chiasm pituitary window. Sometimes the window is very narrow, a small bony opening is sufficient. And large lobes which are around the vessels, you have to be extremely careful. And meningiomas have the broadest exposure. Supergiant pituitary tumors are very complex. We have to be extremely careful. And different types of tumors have dissection strategies are very much different. Because of lack of time, I'll just highlight, even when there is a retroclival extent of craniopharyngiomas, you can do through endonasal, but posterior hypothalamic invasion, we are conservative. And whenever ACOM complex is stuck to a calcified portion, otherwise we try to achieve gross total resection as far as possible. And sometimes there is significant subarachnoid invasion, which Professor Goel sir had reported in his series for the first time. So in these tumors, we have to be extremely careful. The complications are very high. Under vision, you can choose to resect even these subarachnoid resection, subarachnoid invaded tumors, where you can see multiple lobules. But otherwise, when in cavernous sinus invasion, even in NOS4, it is possible by a transpterygoid approach to do a reasonable extent of resection, and any small residual, we can give gamma knife. So maybe with this, I'd like to close. Thank you.
Thank you, sir. Moving on, I'd like to call upon Dr. Narendra Kumar to give a talk on transpterygoid approach to petrous apex tumors.
Once again, fine. Good morning to everyone present here. This is a topic of endoscopic transpterygoid approach. And my sincere thanks to Dr. Vinod Felix, my senior, who has to present this one. And instead of him, and to its credits, I'm going to present due to certain reasons. And the sagittal plane is nothing but we will be in the midline. Midline, we'll be working in this, as I said, transfrontal, transcribriform, transplanum, sella, like that is at the sagittal plane, where we will be working in between the carotids. If you go little lateral to the carotids, we used to call as coronal planes. So transpterygoid, we will be working little lateral to it. So it comes under transcoronal. And the level of skull-base surgery goes with the basic surgery of sella surgeries goes like that. So we have to go little from the midline. We'll be going little lateral approaches too. So always the anatomy, the descending for the any surgical things. So this is a area we are going to highlight here. So the median nerve and the foramen rotundum. So if you remove the posterior wall of the maxilla, you will enter into see the neurovascular bundles. After removing it, you will enter into the transpterygoid. So this is the area of interest. So this is a dissection. Everyone, please get oriented to it. This is a right nasal cavity, the first picture. As I said, the first one is inferior turbinate. This is a middle turbinate and nasal septum. If you go in between and go little above, you will see the osteometal complex, this one, where you have to push the middle turbinate medially. You will be seeing the posterior frontal, that is an osteometal complex. With the backbiting forceps, we have to remove the only mobile structure of uncinate. As I told, we have to remove it little anteriorly. If you do 2 or 3 bites, you will enter into the maxillary sinus. So this is an ostium. You will be seeing easily. As soon as you see the ostium, it will be easy for you to widen up. The safest method is you widen up with the backbiting forceps anteriorly. As far as you go, when the hard bone reaches, you have to stop it, because the hard bone contains nasolacrimal duct. If you injure, sure, there will be some lacrimations in the eye post-operatively to the patient. So you can widen up anteriorly. For the approaches like transpterygoid, the small middle meatal antrostomy, nothing but widening up the ostium is not enough. You have to widen very little far away. So the posterior fontanelle also has to be removed here till you reach the posterior wall of the maxillary sinus. So anteriorly nasolacrimal duct, and posteriorly posterior wall of the maxillary sinus. So you will be seeing the posterior wall of the maxillary sinus as in this picture. Get oriented, this is a right nasal cavity. So as soon as the posterior wall of the maxillary sinus is reached, then we have to start the transpterygoid approach. Depending upon the lesion, if the lesion is very small or far lateral or infratemporal fossa, you have to go little laterally, then you have to widen up your entrance area. So like that, there are 3 to 4 methods in this. The first one is middle meatal antrostomy, is widening up the ostium, as I said. If you remove the complete medial wall of the maxillary sinus, that is endoscopic medial maxillectomy. So little more access will be there. If it is not enough, the lesion is far lateral, then you have to remove the nasolacrimal duct. You can cut it obliquely. Then you have to widen up, and little more anterior wall also have to be removed of the maxillary sinus. We call as modified Dinker's approach. So if the Dinker's is there, you can easily with a 0-degree endoscope, you can go far lateral and approach all the lesions posterior to the posterior wall of the maxillary sinus. So even if you want one more corridor, as I said in the previous talk, you can go from the opposite side, piercing the nasal septum. With that, you can go and you can approach. So not only 0-degree, 30, 45, even till 70 to 90 degrees, you can work it out in the nose without any scar in the external. So as soon as you open up widely the posterior wall of the maxillary sinus, you'll be seeing the 2 processes. One is orbital processes of palatine bone. The other is sphenoid process of the palatine bone. You have to drill the both. You have to enter into it, and you will be seeing the sphenopalatine foramen. Of course, the sphenopalatine foramen contains what? Sphenopalatine artery. So you have to see the sphenopalatine artery. With that foramen, you have to enter the ball probe, and you can see that it will be going and continuing as a maxillary. So you have to cut the sphenopalatine artery. You have to, you can use any of the hemostatic agents to cut it. And as soon as you drill it, you will be seeing the pharyngeal arteries. You have to bisect it and enter into it. You will be seeing a Vidian nerve little far away. That's a very important landmark in transpterygoid approach. So drill from the Vidian nerve, you can remove it little laterally. You will be seeing the contents of the Vidian canal, Vidian nerve, and the Vidian arteries. And these are the periosteum of the pterygopalatine fossa. So push it far lateral. You will enter into the pterygopalatine fossa here. And this is the one. And if you see this pterygoid base, then you can start drilling it. You will be entering into the middle cranial fossa. So like this, and before it, you have to cut the Vidian nerve. But of course, Vidian nerve, the patient may have some lacrimation problems also. These are the contents of the pterygopalatine fossa as soon as you enter it. We will see in some surgical videos too. So get oriented. This is a left nasal cavity, the same one. Velva area is the one in between this place, which is the safest zone for drilling it and enter into the middle cranial fossa. Velva V for Vidian nerve, and E for Eustachian tube, and petroclival fissures here, and pharyngeal fissure, and lacerum, foramen lacerum. So this is a Vilfa area. This one you can see here. This is a safest zone where it doesn't contain any neurovascular bundle. So it's a safest zone to enter into for the post-maxillary lesions. So transpterygoid approaches, we have to approach for the access to the foramen lacerum, the petrous part of the internal carotid artery, Meckel's cave lesions, cavernous sinus, and any lateral fissure, nasopharynx, fossa frozen Miller lesions like JNAs, we used to do it, and far laterally infratemporal fossas. So as I explained, there are 4 ways to go for transpterygoid approaches. If this is a axial view, if you open up here, this is wide middle maxillary opening, this one. If this is a nasolacrimal duct, if you open up till here, you will be calling as endoscopic medial maxillectomy. And if you are removing little of the anterior wall too, this is a pyriform aperture where you remove this bone also little, it's called as endoscopic modified Dinker's approach. So, and if you come from opposite side, combining all these 3, you can approach far lateral lesions too. So this is one of the surgical videos. It is a schwannoma case of the Meckel's cave. So you'll be seeing the lesions here. So we did a modified Dinker's approach endoscopically, then drilling of the posterior wall of the maxillary sinus. We are removing the bone over it. So as soon as you completely drill the posterior wall of the maxillary sinus and pushing all the contents of the pterygopalatine fossa, you'll be seeing it, this quadrangular space. The dura is seen here. We make an incision over the dura. You enter into the suprapetrous. Suprapetrous is nothing but it is above the petrous carotid. Lower it is called as infrapetrous approach. So this is a suprapetrous approach where we enter into the Mecken's cave. Slowly, with the use of a suction, we are removing this lesion. This was a schwannoma. As soon as the tumor is delivered, we observed a small CSF leak was there. And that was repaired with the fat and the Hadad flap. One point in transpterygoid is, the transpterygoid, we have to use the opposite side of the Hadad flap. As we are drilling the sphenopalatine area, of course, that side of the Hadad flap, you can't able to elevate. Even if you elevate, it will get injured. So transpterygoid approach, always try to go to the opposite side of the nasal cavity, elevate the Hadad flap. As soon as you start the surgery, preserve the Hadad flap of the opposite side. When you completed the surgery with the posterior septectomy, you can take that flap from the opposite side and you can reconstruct it. So this one also the mass. Time is restricted. So this is a pterygopalatine fossa. This is an instrument called as microdebrider. It's just used with very precautious. It is a usual instrument in sinus surgeries where it will cut, suck and irrigate, but it should be used in very cautious in skull-based surgeries. Just we remove the fat of the pterygopalatine fossa using that instruments and some of the fibrous tissues over there. So the tumor is dissected and removed it. So thank you one and all for watching this video. Thank you so much.
Thank you, sir. Next up, can I please call upon Professor Siddharth Ghosh for giving a talk on combined endoscopic and microsurgical approach for a giant posterior fossa tumor.
I have come across two very interesting cases of posterior fossa schwannomas, which I couldn't really find out where the origin is, on which nerve it's arising from. Maybe after this case, somebody can highlight me. Even this, I was not sure which nerve it's arising from. I had a similar case about 5 years ago with similarly a young lady who presented with a large that was a CP angle. I thought it's a vestibular schwannoma, but the 7th-8 complex was not involved at all. So this was a 11-year-old girl who presented with no imbalance while walking, sudden onset of loss of vision because of hydrocephalus, and frequent fall due to imbalance. And he had a double vision. She had a double vision of 20 days and intermittent headache. So on examination, the right pupil was 3 millimeter and left was RAPD, and right finger count only perception of finger movement was there. There was no other deficit. So if you see this tumor, it's a very large tumor with heterogeneously enhancing lobulated mass, which is seen in the prepontine cistern here, as well as in the retroclival region. So, and there are a few small hemorrhages were seen inside. The brainstem was displaced quite posteriorly by the lesion. So looking at that, the differential diagnosis, I thought it may be that it's a chordoma, but there was no bony erosion, and so the differential diagnosis, I couldn't definitely think that it was a schwannoma. So I planned for surgery in 2 stages. The first was the endoscopic view, because it was midline. So I took the help of my So he did a Haddad flap to start with, and then opened the rest of the things like usual, like opening of the sella and the retro and the clival region. So drilled the sella and the clivus to get a wide access. And the rest of the thing was done by me. So he opened the dura after this is the drilling of the clivus. So I opened the dura in a cruciate manner, and the tumor was right there. So I sent it for frozen, and it came as schwannoma. As you see, it was a very formous but relatively not very vascular tumor. So open posteriorly again. So sent it for frozen, and then started debulking the tumor. Just like a pituitary with the ring curette, took out the tumor with the help of the suction as well as with the help of the curette. It took quite some time because it was quite a large tumor. So my idea was to core it out the center part of the tumor as much as possible, and then go probably from the microscope from the temporal approach. So the tumor which is coming out in piecemeal. I made it faster here, 2x for the time. This actually I did with one hand only, so that's why every time I had to come out and put it in. So as you see, the tumor is gradually being debulked. It's very large tumor. It's almost about 5 centimeter. As you can see, still there is some tumor there. So after this is done, I asked my ENT colleague, they put a fat graft under the replaced by the head flap. This is the last bit of the tumor, as we could see from the midline. It looks like most of it like Anthony B cell tumors because they are very earless and little fleshy type of thing, which came out with curette, with a sharp curette. Going to the anterior part of the tumor. So it's over now. So put a fat graft followed by the Haddad flap. Then we did a, and see the Haddad flap being placed. Did a post-op MRI. As you see, the center part has been taken up, but the rim is still there. So this part is being close to the Meckel's cave. So I thought I'll go through the temporal approach, middle fossa approach. So this is a typical schwannoma. So the initial part was not recorded. So I just took a picture from the net. This is the usual incision, as you know. So this is the flap, the usual temporal flap. Then I did middle fossa approach, drilled the middle fossa. And this is coagulated the middle meningeal artery. Then cut it. Then reflected the dura. So saw through the navigation. So I opened the dura there. And I just did the cruciate incision. Also, I did a midline cut so that I can go to the end of the dura and end of the temporal fossa. Since the tumor, the temporal fossa was quite bulging, being on the right side, I just took about 1 centimeter of the temporal lobe to get into the tumor. And here you can see the fifth nerve there, fifth nerve here. So it's been separated from either side, and the tumor has been excised, gradually reflected. Using CUSA also. and microcystis. Navigation definitely helps. People who have the advantage of navigation should definitely use navigation for this type of things, because this gives you a very clear idea about where you are, and also to have the control of the, the neurovascular structures. So gradually reflecting the capsule and debulking the tumor. Still quite a large part of the tumor was there, which was in the, which was the rim of the capsule of the tumor. So gradually separated from the fifth nerve. We get a good plane. So I could go to the opposite side also from there, because the capsule gradually, I could pull the capsule and go to the opposite side of the rim also. So the tumor has been excised completely now. I thought it's excised completely. Then I always do a MRI within 48 hours to have the exact picture of how much you have excised. So this also I did and you see there is a small bit of tumor still here in the prepontine area, very small. There's a young girl, the father is a businessman, so she was insisting that the child should be fine. So I discussed with my radiology colleague, Dr. Shankar is here. He was my radiation oncologist. So we thought we'll give him hypofractionated proton beam therapy. As you could see here, this small bit of the tumor here in the prepontine cistern, that was taken care of by the proton beam. And the final biopsy was a schwannoma, but I still don't know what was the nerve it's been arising from, because the child did not have any neurological deficit other than child came with a severe loss of vision because of hydrocephalus, and came for a follow-up. She's fine. So she didn't have any deficit. So I just wanted to know, that's a young girl, 11-year-old girl. So any idea where it's originating from? Because I had a similar patients like that, where I couldn't find out that where exactly the nerve of origin. Thank you very much.
Thank you, sir. Can we now have the speakers, Professor Dandabani, Professor Siddharth Ghosh, Dr. Siraj Sahu, Dr. Narendra Kumar, to have a panel discussion, and may I request Professor Vernon Velho to moderate.
Thank you. Thank you, speakers, for a wonderful session. First, I think we will start from down up rather than from up down, since Professor Ghosh has shown us an interesting case. So anyone from the audience who could think of where this lesion has originated? It is bang in the midline. And if you see the MRIs also, it's a midline tumor. So there could be 3 nerves in the midline. Yeah, it's slightly lateral. Mic, please. Please give Professor Goel a mic.
When it is in midline, when it is clearly off the fifth nerve, which is completely seen
Yeah, it's
off the nerve.
and slightly below.
Yeah. Seventh nerve is medially off the tumor. All other nerves are off the tumor. So the patient presented with diplopia. My first guess would have been sixth nerve neuroma.
Correct.
But
Yeah.
if it was a sixth nerve neuroma, she would have definitely,
deficit, yeah.
without any question, she would have developed postoperative sixth nerve deficit. So this is a schwannoma of a unusual kind. Sometimes these kind of schwannomas are called unattached schwannomas. And these schwannomas can be in various places of the entire cranium, including in the subfrontal area, inside, and various unattached schwannomas. From where it arises, from where there are so many neural fibrils all over the place, maybe one of these fibrils.
Okay. Professor Ghosh, just one question. Don't you think you could have gone back again from the midline endoscopically and widened the amount of exposure and then got it out?
Since I do the endoscopy, I do pituitary myself. Till that's extended pituitary, I don't do. So I have a very good ENT skull base colleague. So he was comfortable with this much only. So obviously I had to.
I think you were just there and you could have, extended it slightly and got it out in second sitting. Any opinion from the house?
Dr. Danapani, what do you think about?
Sir, maybe I would have kind of taken the angled endoscope more inside and saw how much I can remove safely. And actually, but again, safety is paramount. There is no doubt. But when we see, we can decide whether we can dissect it from the adjacent structures or it would be difficult. Actually, if any vascular attachment or encasement is there, then I would have been little skeptical. But otherwise, I would have taken the angled endoscope more inside to look for the attachments.
So just a comment, when especially if you're going more laterally, you got to have special instruments. The normal curettes, they don't reach. So you got to design your own instruments, especially suctions. You got to have a 45 degrees or a 90 degrees angled suction, which is not there in any of the instrument trays. So please get them custom made. At least I have made instruments which reach laterally. Otherwise, it's a problem. Thank you. Thank you.
I want to ask one question to Professor Ashish Shudi is there. Could you have gone through the Kawase-Dolenz approach? You could have. Yeah.
But it's more in the midline, if you see, yeah. Yeah. Thank you. Next is, I think, Narendra Kumar. Any questions from the residents? See, as neurosurgeons, we are not familiar with the transpterygoid approach, but for ENT surgeons, I think it's a workhorse. And they use it very, very commonly for many tumors, especially in the pterygoid fossa. For us, it's a new territory. But I just want to ask you, what would be your absolute contraindication for this approach? Is there any contraindication?
Not exactly, sir. Benign tumors, we can easily go for it. And for any osteomyelitis like that, we are going there and taking a biopsy. So preferably we go for biopsy. In engulf tumors, we can able to do it, but not literally contraindicated like where it is a very big tumor, we will never approach it. Just for the biopsy, we will be planning for more for the transpterygoid.
Maxillary sinusitis. Many times we get scans which show maxillary sinusitis, sinus thickened. So what would be, would you still choose the approach even if there is sinusitis?
Yes, we are widening up the sinus very far lateral, and so that when the sinus is opening is very wide, so there is a very less chance of sinusitis. Even in the OPD, we can go into the angled suction and we will remove the secretions.
No, if there is infection. Would you go
Infections
through
will
that?
never.
You
we
have
should-
to.
we
And
should
what's the protocol? Because we need to know that many times we see scans just before the surgery and then we say the mucosa are thickened, we are seeing infection, sinusitis present. So what's your strategy for that?
So the sinusitis recently we are giving clarithromycin is very good.
So how long do you wait?
The European board says for 3 months, but we are doing at least a month and we are going for the surgeries. 6 weeks is ideal.
6 weeks ideal. So I think the resident should know that.
Sir, I would like to comment regarding the transpterygoid approach. What we usually do is that we do a tailored transpterygoid approach, that sometimes the sphenoid sinus is large enough that even without a transpterygoid approach, you may get access till the Michel's cave and the lateral cavernous sinus invasion, including NOS4, especially with angled optics. So what we initially do is first we do a wide sphenoidotomy, and then we see whether our instruments, whether 2 instruments are going comfortably into the lateral recess. So in that case, we don't routinely do transpterygoid. But whenever we have difficulty, of course, then the transpterygoid, whenever the sphenoid sinus is small, narrow, then it definitely gives an added edge by doing transpterygoid.
Thank you. Thank you. Any questions for Dr. Dandapani? Dr. Dandapani, do you do a CT angio 3D?
Yes, sir. In
routine,
all cases, all
especially
cases,
when you're going
yes.
lateral to the carotid.
Even we have noted that even in a routine pituitary, that has become a standard kind of protocol. We do CT angiography and navigation. We load it in the machine because lots of vascular anomalies, because our volume is so much that sometimes that I remember some 7 years back, I lost a patient because the vessel was within the sphenoid sinus. So even before I could kind of scrub in, ENT, my colleague was operating, even within the sphenoid sinus, the carotid got injured. So I realized that it is better to do in all, and we get to see lots of aneurysms which are incidental, and then we first tackle the aneurysm and then we tackle the pituitary. So that has become a standard protocol.
Thank you. Any question for Dr. Siddhartha Sahu? If not, then I will ask you, why do you just take one incision? What is your rationale of just taking one linear incision? Because many times you might have the tumor, if you debulk posteriorly, then you might have the diaphragm come and an arachnoid come in your place and plug it. You might not know what is there beyond that.
So it's not a fixed thing that I always use a linear dural incision. Sometimes I use cruciate incisions as well to open the dura. So one incision, sometimes if the tumor is very big, and I have seen the sagittal MR where I'm seeing that the chances of arachnoid prolapse early is high. There I take a linear incision that acts as a support. On the basis of that and putting my curates behind that, I debulk the tumor. And then if you are using a 30-degree, you can always go behind. And even if there is some arachnoid prolapse, you can put it to one side, put a cotton patty on that and go beyond that and do tumor decompression if it happens early. So it's not that routinely I take a linear dural incision.
Okay, I think we shall end with this. Thank you. I think we have asked everybody questions.
Thank you, sir. Thank you all for making this a brilliant session, and that concludes the topic on endoscopy.
Moving on, we have the next session on anterior circulation aneurysm, moderated by Professor Sanjay Bihari. We now have Professor Abida Shah and Professor Sukhdeep Java to take us through the 3D anatomy of circle of Willis. Over to you, sir. Before we start, a gentle reminder again for all the speakers to adhere to the allotted time.
So this is the last anatomical talk of this conference. And as we are beginning with the vascular session, we will see the anatomy of the vascular system of the human brain. So this is a dissected circle of Willis. As you can see, this is the ICA, the ACOM, the ACA. On one side, it is hypoplastic. This is the MCA. This is the basilar coming and both the posterior cerebral arteries. So this is how the configuration of the circle of Willis is in quite a few of us. And majority of the times it is complete, where you will have another opposite A1 also. So let's begin with the carotid artery. Yesterday you saw this petrolingual ligament, and as the carotid is coming out from the petrous segment and the lateral segment to become the cavernous segment, it is entering the cavernous sinus. It has two bends, one posterior and then one convex anterior. This is the first branch that comes out just lateral to the dorsum sellae. It is actually a trunk, the meningohypophyseal trunk, and it gives out three branches. A lateral branch that you can see is the tentorial artery of Bernasconi-Casanari. Then it gives one medial branch, which I will show you in the next dissection, and it gives one dorsal clival artery, which goes on to supply the clival dura of the posterior fossa. So this is the artery. As you can see, the bends of the cavernous artery, the posterior bend and the anterior bend. And then this is the clinoidal segment with the proximal and the distal dural rings. And then this is the intracranial part of the ICA, which joins to form the circle of Willis. So you see, this is the first branch, the meningohypophyseal trunk. And this artery that you see here going medially is the inferior hypophyseal artery that supplies the posterior pituitary. The next branch to come out of the cavernous segment is the inferolateral trunk. Okay, now you see this meningohypophyseal trunk. Sometimes it may arise as a trunk or sometimes as branches. You see this one is the inferior hypophyseal artery. This is the clival artery, as it is going to supply the posterior dura. And this one going laterally is the tentorial artery. And then this is the cavernous carotid, and it is turning out and becoming intracranial. Now, as it comes intracranial, it comes out here lateral to the optic nerve and then goes on to bifurcate into the MCA and the ACA. This is the third nerve. This is the optic nerve and the optic chiasm, and it becomes intracranial. It bifurcates into two segments, the anterior cerebral artery and the middle cerebral artery. The anterior cerebral artery has these parts, the pre-communicating, the A1, the infracallosal, the precallosal, the supracallosal, and postcallosal. So we normally use these definitions. We call it A1 and the ACOM segment, and then we just call it the distal ACA or the A2. So this is how it looks. So this is the internal carotid artery as it is coming out. It's giving its one MCA branch here. This is the A1 as it is going on. This is the ACOM complex, and this is the opposite side A1 and A2. So this runs above the optic chiasm and just in front of the lamina terminalis. It gives out a few lenticulostriate branches here, which will go on to supply the anterior perforated substance. This branch that you see here is the recurrent artery of Hübner, which, as we all know, it goes laterally and then curves upon itself. Then you see it arises generally in this location, either from this part of the A1, directly from the ACOM, or most commonly from this most proximal segment of the A2. Going further, before going to the sagittal view, we'll just see the arteries here. So this is the ICA, this is the A1, this is the MCA. Now the ICA has been retracted laterally, and here you see the basilar artery with its bifurcation. This is the third nerve, this is the second nerve. Here is the pituitary stalk, which you can see. This is the olfactory nerve. So now looking from when we look at it from the subfrontal approach, so this is the optic chiasm, this is the lamina terminalis, this is the ICA, the A1 going like this, the opposite A1 coming here. And when you suck in this region, the gyrus rectus region, you will see this whole A1, A2 complex along with the ACOM. This one here is the pituitary stalk. This is Lilliquist membrane, the diencephalic leaf. And once you go through that, you will enter into the posterior fossa. So here you see both the A1s are meeting here to form the ACOM, and then by going up to form the dividing into the A2s. So here this is the third nerve. Now this membrane has been cut, and here you see the basilar artery with with the bifurcation, the posterior cerebral arteries. So this is the anterior perforated substance, and you see there are multiple perforating arteries, the lenticular striate arteries. Some of them come from the A1, majority of them come from the MCA, and they go on to supply this critical area, which supplies the central core of the brain. Now this segment, when it turns here, so you call this infracallosal, precallosal, supracallosal, and then it terminates at the end here, joining with a few branches of the posterior cerebral artery, and that is the postcallosal part. So this first branch that is very consistent is the callosomarginal, and this one we all call as the pericallosal artery. and it goes on to supply this territory, which I will not have time to go into. So that when we look at it from a superior aspect, this is on the corpus callosum, and you see both the pericallosal arteries. Mind you, both these arteries are not lying at the same level. Generally, they are one above the other, not exactly at the same level. So this is just an image where, some bypass is being performed. Here you can see the sutures, and A2 bypass has been performed. So this is of the angiographic view showing the ICA on both the sides with both the MCAs and this is a complete segment on the anterior aspect. If the posterior cerebral artery also gets filled, then you have a complete circle of Willis. So now these are a few branches of the cavernous carotid, not cavernous carotid, of the ICA which comes out. So you see this branch, this is the superior hypophyseal artery, which goes on to supply the pituitary stalk. This is from an endoscopic perspective. Here you see the optic chiasm, and above this, the ACOM complex with both the A2s going up. Here, this is the cavernous artery, and you see this vessel. This is also a direct branch of the cavernous carotid, and this is McConnell's capsular artery. It goes on to supply the capsule of the pituitary. So this is an end-on view where you see the carotid with its turns, which are different when you look at it from an intracranial perspective. This is the basilar artery, just bifurcating here. This is the superior hypophyseal artery. More posterior, you have the inferior hypophyseal artery going, and then the McConnell's capsular arteries. So this is the A1. Now coming to the middle cerebral artery. So this is middle cerebral artery is the artery of this lateral convexity of the brain, and it goes on to supply all these critical areas. So it is divided into the sphenoidal part, the insular part, the opercular part, and the cortical part. So the MC has quite a few turns. So this is the ACA as it is coming out, the ICA as it is bifurcating into the ACA and the MCA. Now here you see, these are the perforating branches that generally come out from this M1 segment and goes on to supply, you see all these vessels that are very important. If you damage these vessels, you will cause a very bad neurological deficit to the patient. And this is the ACA, as you can see that it is going up and going to become the A2. Now this is the MCA as it is coming out. Here you see the divisions. So here at the Lyman insula, it will turn and enter the insula. Then it goes, then once it is on the surface of the insula, it will again turn into the opercular part and then comes out on the cortical surface to form the M4 branches. So this is when it comes out lastly, having this hairpin turn. And these are the terminal cortical branches. And there are they're divided into many parts and segments. So basically it supplies this lateral frontal, precentral, postcentral, parietal, temporal, and there are various branches that are important here. Generally, these central arteries are important and you cannot have damage to them. So this is when you look at it from an operative perspective. This is the Sylvian fissure. This is the region of the anterior Sylvian point where you generally make an entry to enter into the insula. There you see the MCA coming with its bifurcation here. Then it will turn in the opercular region. So here you see now the MCA on the surface of the insula. And these are all the long perforating branches. And then they turn here and run on the undersurface of the operculum, and then again have a turn here where they become the cortical branches of the MCA or the M4 branches. So this is an MCA here. You can go see it supplying on the AP view and angiogram. Now coming to the last part of the circle of Willis, that is the posterior cerebral artery, which is again dividing into pre-communicating the P2 segment, which has two parts, crural and ambient, the quadrigeminal segment and the cortical segment. So the PCA, the circle of Willis will be complete here when the PCOM comes and joins the PCA. So if it is a fetal type of PCOM where the P1 is not very prominent and most of the supplies from the PCOM, then it will be a fetal type of circulation. Majority of the times the P1 is dominant. So this is the basilar artery where it is bifurcating into the PCAs, and you see it's coursing into this. It has this course into the crural and the ambient cisterns. So this is the base of the brain where you see the circle of Willis actually. Both the ICAs going into the ACAs, the MCAs, the PCOM, and the basilar with both the posterior cerebral arteries. So now this is a closer view. You see this posterior cerebral artery turning like this. So this is the crural segment, the ambient segment, and then these are the cortical branches of the posterior cerebral artery. This is how it looks on the anterior posterior view of an angiogram. Now there are important branches that come up from the P1 segment. So this is the P1 segment. So where the segment that is just present before the PCOM joins it is the P1. Below there, you see the superior cerebral artery. This is the third nerve. And you see these important perforating branches, the thalamoperforating and the thalamo-geniculate branches as they enter into the posterior perforated substance. And then these are the main branches of the P1 segment. So again, from another view where you see there are multiple perforators on the back of this basilar artery and the PCA division, which enter into the brainstem and supply also the thalamus and the hypothalamus. So this is the PCA as it is turning around the cerebral peduncle and forming the crural and the ambient components. Now, as you see this vessel, this vessel is the medial posterior choroidal artery, which is branch of the P2. It will come here and then turn up and then enter the velum interpositum in the roof of the third ventricle and continues as the medial posterior choroidal artery. And another branch comes here that enters into the ventricle. Here you can see that is the lateral posterior choroidal artery and enters into the choroid fissure and supplies the ventricle in this region and forms the choroid plexus. So again, this is the view. You see the third nerve, the fourth nerve. This is the superior cerebral artery and the posterior cerebral artery. And now these are the terminal branches of the posterior cerebral artery. This is the parieto-occipital branch as it enters the parieto-occipital sulcus, and then the calcarine branch as it enters the calcarine sulcus. And this is on the AP view of the angiogram, where you see the basilar dividing in both the posterior cerebral arteries and then going on to supply the cortical regions. Thank you very much.
Thank you, ma'am. We now have Professor Sarat Chandra with us to give us a talk on clipology of aneurysm surgery.
Thank you very much. Again, it's been a wonderful Congress. And of course, Dr. Abida, that was an exemplary presentation. So I always thought that this lecture of clipology is very important because I never learned about which clip to apply, what are the different types of clips, because most of us learn it hands-on. We go and assist. Can I have the presentation?
Again? Fine.
So we never actually have a theory class trying to learn about different types of clips. And that is why I thought it is important, especially for the students. So if you go to the history, Cushing is credited for developing malleable silver clips. Now, Oliver Crona added winged flanges so that it could be removed but it was suboptimal. Then Dandy, we know that historically Dandy applied a malleable silver clip at the neck of an IC aneurysm. Now, most of the development of clips happened with Professor Yasargil. Of course, Professor Drake was also fundamentally very important. But when we look at the modern clip, what we have to understand that most of the force of application is measured at 1/3 of the blade from the tip. And that is the reason most of the aneurysms should be clipped in the distal half of the clips. Most of us, we think that the aneurysm, if it is clipped, now this is the area which has the least amount of force. So if you need to apply an aneurysm, the clip needs to be at least 20% or 30% larger than the aneurysm if you want to really clip it properly. Now you have this holding force, which is in grams. So you can see these are the standard measures. So a standard Yasargil clip will have 115 to 185. Standard temporary from 50 to 85. Standard fenestrated again is less. That is the reason whenever you use a fenestrated clip, you always need to reinforce it. You can never use fenestrated clip as a standalone clip. You need to apply one more clip. Mini clips, again, you can see that the force of application is less. So it's okay for small aneurysms, but if it is slightly larger, you may need to reinforce it. So these are the different ways by which you could apply clips, and we are going to study the most important part of it. So these are the names, and we are going to go in details to each one of them. Now you also have some special clips. For instance, you have this, some companies which are selling this reinforcing clips. So you have a clip and on that you can reinforce it with clip. This is very good. So rather than applying multiple clips, you could have a reinforcing clip. Now, Sund clip is something very useful, especially when you're tackling with blister aneurysms, which could be very dangerous. Small aneurysms, they are highly prone to rupture. And I think, and in case you have any kind of rupture from an artery, if it's too deep where you cannot repair the artery, you don't have enough time for a temporary clipping. So that's one reason that every OT should have a Sund clip. Now, this is not a special clip, but it's a very useful clip. I call it as Yasargil 746 because the blades of the clip, rather than opening sideways, they open in the superior inferior direction. Now, this is a technique which you should also know. So, for instance, if there is a rupture at the neck of the aneurysm, how should you repair it? So, taking a Teflon mesh, applying it on the clip and then repairing. Because rupture at the neck is one of the biggest disasters you could have. Then there is no way how you can actually control it. So let's look at some of the clip applications. That's an ACOM aneurysm, which has been operated. I hope the video runs. Thank God. So going through a SOCA approach, exposing the optic nerve and the ICA, opening the gyrus rectus, standard approach. Now here it's very important to preserve the Hubners because you've heard from the earlier lecture, and then we expose the aneurysm, and then you apply a very straightforward, simple clip after defining the aneurysm. But here I committed a mistake, and this is what you should not do. So after applying the clip, I found that the clip was taking up a vessel more distally after dissecting the aneurysm completely. And I was afraid to remove the clip. Now this is about 10 years old. So after dissecting, I found, that it was taking up a small vessel. So rather than readjusting the clip, I applied another clip distally, and that led to the rupture at the neck. So this is one strategy which you should never do. So fortunately, in this case, we were able to readjust the clip on the neck, and fortunately, everything went well. Now, this is an example of a simple reinforced clip. That's a complex ACOM aneurysm. So dissecting it out. Now I like to, all these complex aneurysms, you can coagulate and you can shrink the aneurysms. So I really like to do that because by shrinking, the idea is you get some amount of space. So when you get a space, that gives you an amount of space where you can actually apply the clip optimally. But in this case, it was already a ruptured aneurysm. So it had ruptured while we were doing, and then we applied 2 clips. So basically it was reinforcing, and there was a dysplastic bulge, which we had put some glue and then covered it. Now this is not a very uncommon situation, but in MCA aneurysms, when you have the bifurcation of the MCA, you could have one lobule on one side and other lobule on other side. So there's no way that you can actually apply a single clip for that, in which case you may have to apply 2 straight clips on either side. So in this case, we found that there was lobules going on both the sides. So I prefer to put a temporary clip because the lobules were very thin, they could actually rupture. Dissected out the lobules. So most of the dissection should be done prior applying the temporary clip. Only the final parts of the dissection should be done after you apply the temporary clip. So we apply one straight clip on one lobule. Dissect the other lobule, dissect out the M2, and apply another clip on the other lobule. So these are very fundamental strategies which every resident and student doing aneurysm clip should be aware of. Now, sometimes you may have to apply intersecting clips like this. So this is a giant MC aneurysm. So we have decompressed the sac. So there are temporary clips on both the sides. So there's a good degree of black backflow. So we apply one clip so as to reconstruct. Now, whenever you're reconstructing, it's always better to err more on the side of aneurysm than on the wall. Because if you try to err more on the side of the wall, it is possible that you may occlude the wall. So here in this case, we are applying perpendicular clips both on opposite side So this is a perpendicularly intersecting clips by reconstructing the MCA. And of course, I also apply a third clip because these clips don't have a very good holding force. So you always need to reinforce it with at least a third clip or even a fourth clip. So we remove the distal clip first, followed by the proximal clip. And then we confirm the good clipping by doing an ICG. Now, sometimes you may need to apply stacked clipping. So this is an example of a IC and MC aneurysms. So drilling the clinoid. So we drilled it both extradurally and then intradurally. Now, while applying the clip, there was a rupture here because we did not adequately expose the neck. Now, that is a very dangerous thing to do. So you have to expose the neck completely. But fortunately, we got a space by which we were able to apply the clip. And then we applied multiple clips in order to take care of the aneurysm. Now, sometimes in complex aneurysms, when the aneurysms face away from you, you need to apply perpendicular fenestrated clips so as to reconstruct the artery away from you. So this was a complex ACOM aneurysm and the aneurysm was facing away from us. So we had to reconstruct the aneurysm on the opposite side. So in this case, we took a perpendicular fenestrated clip and applied it away from us in order to reconstruct the anterior communicating artery. Now remember that whenever you apply fenestrated clips, if required, you need to apply more than one. Now this we did it through a keyhole approach. Now sometimes you may need to apply heel to toe kind of a clipping, and here you need to apply multiple clips. So this was a giant IC aneurysm, which we again approached through a eyebrow incision, and we drilled the clinoid process through the eyebrow itself. And then we had to apply multiple perpendicular fenestrated clips in order to reconstruct the artery. So whenever you reconstruct artery in such large aneurysms, it's very important that you apply and release the clip multiple times. Please do not be happy with just one single application, because you need to reconstruct the artery, for which case you need to multiple times you need to apply and release it so that you are able to reconstruct the artery. Otherwise, you will not reconstructing the artery and the artery can get blocked. So it's very important that you do this multiple times so that you can reconstruct the artery multiple times. So that is again through the keyhole approach. So this is how the clips, so 2 clips were applied. She was a pediatrician. That was the second post-operative day. Now, sometimes you need to apply heel to heel clips. Now that's a giant aneurysm. So here we applied multiple clips in order to reconstruct the artery. Now you can see that we are applying in the opposite direction, heel to heel clips. So heel to heel clips could be facing each other or they could be in the opposite direction with the base of the clips facing. So that is another clip reinforcing. So again, you have to apply multiple times and release it so that you're able to reconstruct the artery adequately. Sometimes you may have to do a picket fence, in which case you remove the aneurysm sac and apply multiple small clips in a perpendicular manner. And this is particularly useful when you operate giant MC aneurysms, because this is, so now this is a giant MC aneurysm which was thrombosed. So we apply temporary clips. We decompress the sac which was thrombosed. We cut out the sac. And now when you cut out, you have to be very careful that you don't shorten it too much. So it is always better that you could do it. Now in this case, we were able to release the temporary clips and find that there was a good backflow. So instead of single clip, you apply multiple perpendicular clips in order to recreate the vessel. and remove the thrombosed part. And then, of course, you have to confirm it with an ICG. All these clippings you have to confirm with an ICG. So that's how it is. So again, stacked clipping, this is another example of a stacked clipping for a giant MCA with hematoma. So that's a distal M1 segment. So we are evacuating the hematoma. Let me fast forward it. I'll just show you how the clips are. So these are the multiple stacked clips. You can see 1, 2. So these clips have been passed on the neck. So when you put, you just cannot apply a single clip on a neck. So whenever you apply a single clip, you need to apply clips of variable length so that you're able to cover the entire neck of the aneurysm properly. So that is what we ended up doing. So you can see we have put 4 clips because all these are reinforcing clips. You need to apply 4 clips in order to really support the neck, particularly for giant MC aneurysms. Now, sometimes you may get into this situation when you open up. In this case, we didn't think it looked like a saccular aneurysm, but when we opened up, we found that it was a fusiform aneurysm with a bulb. So the high risk of rupture. So in this case, we just applied a Sund clip, which reinforced the clip and reduced the intraluminary pressure. So you need to have Sund clip in your armamentarium because sometimes you come across the situation, you try to just put a patch, you put some glue, that's not going to be optimal. Now this is showing the Yasargil clip 746. This is very useful because rather than opening laterally, it opens in a superior inferior direction. So this was a case of a large PCOM aneurysm. So you can see that the neck of PCOM aneurysm is quite wide, in which case applying a clip perpendicular to it will have the risk of rupture of neck of PCOM aneurysm, which could be disastrous because trying to repair here will be practically difficult or impossible. So in such broad-based aneurysms, it's always better to apply a temporary clip, even though for PCOM, I generally don't prefer. And you can see the PCOM here, that's the third nerve. And now we are opening this clip both superiorly and inferiorly. It's a very useful clip. And one flange goes in the depth and one flange is on the surface. And you're able to very nicely clip the aneurysm. So you should have this 746. I don't know how it translates to other companies, but you should have the 746 in your armamentarium because sometimes only this clip works out. So clipping is often a science. It starts with a science and develops into a fine art. So careful planning is required. Do not be shy of multiple attempts till you get a perfect clips. Many of the cases we can avoid a bypass if we can clip very intelligently. And we need to learn this from masters like Professor Sano. I learned a lot from him. So if you have an intelligent mechanism of clipping, you can avoid bypass in a lot of cases. Thank you very much.
Thank you, sir. We now have Professor B.K. Mishra connected with us to give us a talk on optimal management of aneurysm. Are we audible, sir? Sir?
Yes. Yes,
Yes, sir.
Can you hear me?
Yes, sir.
And you are seeing my screen?
Yes, sir.
Okay. You're seeing it now?
Yes, sir. You're
Okay.
visible. Screen is visible.
Yeah. So I'll speak on ruptured aneurysms. I'm sorry, I'm not in India. I'm in the middle of a meeting. Thank you, Dr. Ghosh, for reminding me. So I'll share with you very nice presentation by Sarath. I enjoyed it, Sarath. Very nice, very complex cases. So I'll talk about the need for microsurgery in aneurysms today, in spite of all the advances. There's no question the microsurgery is more definitive, more durable, but there is high morbidity. Now, if you see the BRAD data, which was published in 2019 in JNS, the retreatment rate in the endovascular arm was very high as compared to the microsurgery arm. the complete obliteration rate was significantly lower in the endovascular arm, and the crossover, that means the patients who were put on endovascular arm, more than one third patient could not be such treated and then had to be changed and done by microsurgery. This is in a team which are the kind of mecca of microvascular or aneurysm treatment. Now, what about the different data which is available? There are four prospective randomized trials for sacral aneurysms. Of course, the ISAT was the most kind of quoted study, and that changed the paradigm in the aneurysm treatment, especially this ruptured aneurysms. But in ISAT also, the 1-year results were better, but not at 5 and 10 years, except for deaths in aneurysms as compared to microsurgery and endovascular surgery. The subsequent study, the BRAT, there was no difference at any time. The Finnish study, no difference. The Lee study, there is no difference. And there is a Canadian study which has published recently, which actually has better results in the microsurgery arm. So microsurgery is going to stay, especially if you do it properly, if you reduce the morbidity. So I'll give you some examples where it is still relevant in spite of all the advances. Endovascular treatment is not possible. And this is one of the very difficult cases. This is a young man who had presented with a coma in another unit with subdural hematoma, acute subdural hematoma. They did a decompressive craniectomy. The patient survived and then was referred to us for definitive management. His whole right ICA was diseased. It was blown out, which produced the subdural hematoma. And he had also an unruptured basilar top aneurysm. So we advised surgery. We thought that we'll excise this aneurysm, do a high flow bypass. The patient, kind of went away, ran away from us, which is not unusual in our country, because by that time he was all right. And he came back after 1 year with progressive hemiparesis on the left side and a significant headache. And that is when we did what we excised the aneurysm, because it was so big, the radial artery graft was short. So we opened the aneurysm in the middle fossa, decompressed it, ligated the carotid in the neck, and clamped it in the supraclinoid carotid, and then a high flow bypass from ECA to M2 by radial artery graft. And then we sent the patient for clipping the endovascular treatment of the basilar top aneurysm, which was unruptured, which failed. And so it came back to us. And what we did is another sitting after 3-4 months. We did the basilar top aneurysm clipping, and that was still possible. And the patient had some hemiparesis which were there before, but after 3-4 months, he's completely intact without any visual compromise, oculometer compromise, whatever. So this is the patient after the second surgery. You can see discharge, almost no deficit there. And this patient actually cricket player in Gujarat, I understand. So this is what we did, high flow bypass from ECA to M2, and then a second sitting, we clipped the basilar top. So this is another patient, gentleman who had a post-traumatic pseudoaneurysm of the proximal ICA, presented to us with repeated epistaxis. By the time, it was 1 month after injury, he was blind on the right eye, and he was also left hemiparesis, upturned. And so we asked our endovascular colleague in Mumbai, Dr. Karapurkar, I sent it to him, I talked to him, and then he said he would try a flow diverter because the patient was pseudoaneurysm, proximal, and the patient was already compromised in neurology. So I thought maybe better to do that. He tried all the modalities available with him that time, but he couldn't do it because there was a fracture segment in the aneurysmal wall, and he said if he puts a flow diverter, the artery may just give way. So he sent us back, and then again we did the same thing, the high flow bypass, but here you need to trap it because it's pseudoaneurysm. In proximal ICA aneurysm, the cavernous carotid, which we have reduced because of the flow diverter, we just do the ligation in the neck, in the carotid, internal carotid, and you do a high flow bypass, that suffices. But it's a pseudoaneurysm, you need to trap it and be proximal to the ICA, proximal to the ophthalmic in the intracranial ICA. Otherwise, it can bleed from there. And this was published in Sharath, who had published it. Actually, we sent it, and he had accepted in Neurology India. Now, this is, like what Sharath talked about, some of the complex aneurysm, you can still clip it. And this is one such. You don't, you need 4 bypasses if you want to do that. You can still clip it. This is a lady who presented with coma, grade 5 subarachnoid hemorrhage, large mass. This is circulating component, this thrombus component, MCA, right MCA, which had bled. He had unruptured left MCA. She's a lady. So we had to emergency, we operated, decompressed the aneurysm, clipped it. And then, of course, he needed time to recover from that. And after about few months, he came back for the other side and we clipped it. She remains compromised. He has a left hemiparesis, but otherwise functional. She presented with, as I said, grade 5 subarachnoid hemorrhage. You can still reform aneurysm or raphe. So that's an art you have to develop. You have to have a lot of patience to develop, and the vessels, the parent vessels are still intact. The aneurysm taken care of both sides. This is another unusual aneurysm where the aneurysm was ICA fusiform on the left side, had bled, grade 2 subarachnoid hemorrhage. The PCOM and enterochoroidal was inside the aneurysmal fusiform wall. So the endovascular treatment was not possible, and that is where we did it. And same procedure, and then wide opening of the ciliary fissure, the mainstay for any, many microvascular work, both in aneurysms and tumors. And once you do that, you reduce the retraction, lot of irrigation, because it's a bled aneurysm, as I said. And then we open the ICA. This is the internal carotid artery. We do drilling there. We use the drill, and we use the ultrasonic drill also. And then we get a segment of artery which is proximal to the fusiform aneurysm for temporary clip. And then we clip multiple fenestrated clips perpendicular, the blades perpendicular to the parent artery. The common garden type of aneurysm clipping is the blades parallel to the parent artery. Here it is perpendicular, and all these aneurysms, you need to open it. The giant aneurysms at the base of the skull, the fundus is stuck to the base of the skull. The dura, you need to open it, otherwise it will not collapse. And that's what we did it. This is aneurysm branches between the aneurysmal clips. And then we open that, we try to coagulate, we open it still in spite of the temporary clip, in spite of the temporary proximal and distal clip, it's still bleeding because there are branches between these clips which are still patent. That is why where we use adenosine, we more clips. And once we have done that, we take off the temporary clip. We do the ICG. We also do the fluorescein. The ICG shows the bigger artery is better. The fluorescein shows the finer or the perforators better, as you'll see here. And then we put, this is a disease artery. There is a high risk of recurrence. So we put some cotton around that. That's the ICG showing the normal ICA flow. And then we do the fluorescein, which show the small artery, the perforators better than the IC. So we do mostly both the things together to confirm. And then I'll just show you, we put some cotton there and we some glue. And you see the artery and you see the direction of the clips. These are all perpendicular and the parent artery is intact. And the patient had a very good outcome. This is another thing where endovascular treatment is still not possible. Moya with aneurysm of the P1, P2 junction, where we clipped the aneurysm and we did the STMC anastomosis in the same sitting. Again, cannot be treated. Now, blister aneurysm, again, difficult for both microsurgery and endovascular with a very friable. This patient is a young teen who had multiple aneurysm, including a basilar top, which actually had bleed. These are unruptured multiple aneurysms. You see the, kind of berries there, very, very angry red one. So what we do, we use a construct of muscle and a little bit of cotton there. We put some glue, put it on the aneurysm there, on the aneurysms, and they clip it. They clip taking a little bit of the wall of the artery, so that otherwise these are almost like give way. These are very, very friable, and it gives way. Then you have to do a bypass. So you can get up with these are other clips. The same thing was done for this. As I said, he had the basilar top which had bled, though we had done already clipping that one after we did this thing. Now, the endoscope assistant, there's a lot of interest there. Now, this is a standard PCOM aneurysm, but sometimes the endoscope does help in getting whether the clip is completely taking the aneurysm and what are the branches like. I'll show you that clip is already done. And we're cutting the aneurysm. We have opened it up the aneurysm. I still cannot see the distal PCOM, whether it is patent or not, and the branches coming out the PCOM. In spite of trying all the angles, this microsurgery, then I do endoscope. And when you put the endoscope, you can see this better. This artery, you can see this is much better. That's the third nerve. And you can see beyond the clip, you see that clip blade is taking beyond the aneurysm. And so that's an adjunct we use. We don't do endoscopic aneurysm surgery, but we do take it as an adjunct. Now, some patient with ischemia, this is a lady with a 70-year-old lady who presented with infarct with our neurologist, and fortunately they investigated further, and you can see very small circulating component in the arterial, in the DSA. I don't have it here. So this is a very distal M4 aneurysm with a clot there inside. So there are two branches going there. You can see that's a fusiform MCA distal aneurysm. So we are putting two temporary clips. We have left this branch so that it is perfusing that segment, and we open up that aneurysm, the wall after the temporary clipping. There will be some bleeding there. We take up the big clot inside that, and you will see that it will back bleed there. Once there is bleed is there, we see that we put the temporary clip on the final artery. We back bleed it, and that is taken care of now. Another temporary clip, and then we suture it with Tenno sutures. So reform the arterial wall, and the vascular supply is redone. And this is again another 60-year-old gentleman who had presented with infarct with our neurologist. Very small circulating component, you can see that. But at the aneurysm, at the operation, you see the huge thrombus MCA bipercussion aneurysm. It had to be opened, something like an endarterectomy, and the flow was restored. Patients with mass effect, and this is gentleman with all the vessel disease, the right side, the left side vessel, the posterior circulation, everything is disease. Pan-dolichocephalic artery, but he presented with progressive visual compromise, mainly on the right side. And we actually were not sure how the best way to take care of this. So we waited for about a year till he forced us to do something, because he was going blind on the right eye and the left eye getting worse. So we did the same thing, high flow bypass. So bypass does help in many of these complex cases where there is no option, including no option of the endovascular treatment. So this is another gentleman, again, in his late teens, who presented with headache and the visual compromise, failed endovascular treatment, distal inferior wall IC aneurysms. Very difficult because the perforators and corridor are all inside that. It's a huge aneurysm. As I said, it failed the endovascular treatment and failed balloon occlusion. So we did this, and this is a very thick walled aneurysm. So no clip was sitting there. So in spite of the temporary clip proximal to the aneurysm, you see that. We put multiple fenestrated clip after the holding it with a bayonet forceps to compress the aneurysmal wall, and multiple typical fenestrated clip blade parallel to the parent artery, proximal to distal, and then distal to proximal. But in spite of all our endeavor, there was some part of the aneurysmal wall which was still filling. But I left that because there was compromising the anterocorridor and the perforator, and we accepted that because we didn't want to compromise the patient's quality of life. And then we started off with this. We landed up with this much, which was much more easy for the endovascular colleagues to take care of, which was sent back to the endovascular colleague who had referred this patient. So microsurgery, sometimes endovascular can be complementary. Now, the standard of care for proximal unruptured aneurysm of the ICA today in most centers, especially in the West, is flow diverter, and rightly so, because there are risks involved in open surgery. But does it always help? Is there no problem? There is problem. This is one patient. I'm seeing more and more these patients with failed or complications, significant edema with visual compromise, and then in spite of the steroids, it continues to worsen the vision. This is another patient, again, ruptured aneurysm, which are endovascular treatment, again, vision compromise, which does not help. This is another patient, a giant proximal aneurysm, presented with some headache, but the multiple flow diverter finally landed with right hemiplegia and a bedridden patient. So if you have a mass effect on a giant aneurysm, especially on rupture, it's better to go in and treat that by microsurgery to decompress the visual pathway, and the patient has an improvement. It's a lady with 4-centimeter aneurysm, which we did this, and this is what we would advise. Now, this is a more recent patient, 2019, 62-year-old man, very proximal ICA aneurysm, which was treated by flow diverter. He was getting the vision worse on one side, and this was in another center, 2019. After the first flow diverter, vision in right eye worsened, and the left eye started going down in 2020. They put a second flow diverter. The vision became blind in both eyes. The aneurysm is almost taken care of. There's a very small area of aneurysm, but you see the mass, the significant mass effect, and this was presenting with hemorrhage. to again Dr. Karapurkar actually. And so he called me up. He said, Basant, you have to do a bypass. He may bleed to death because there's a very small circulating current, very nice flow diameter, beautiful angiograms. But patient was having epistaxis, bedridden, blind both eyes. And then we did the same thing. Of course, he remained blind, but he subsequently developed hydrocephalus. We did a shunt, and this is published in Journal of Neurosurgery. He's better now. He's blind, but otherwise better, and he has a shunt also. Now, this is a more recent patient, and this has been multiple endovascular treatment. Like you can see AV coiling, contour 2021 recoiling, and he presented last year, October, to us with bedridden, GCS down, cranial nerve involvement, left hemiparesis. She had a shunt. This is a foreign patient. This is a foreigner, I can't remember, European, some lady. So this is the aneurysm which was there, significant mass effect, and this was the circulating component when she came to us after multiple flow diverters. This is what she presented to us in a bedridden state. And so the Pandurang, which is my endovascular colleague, neurosurgeon, we discussed, and he said he could put some coils so that we can be easier. It would not rupture when we open up, which he did. Unfortunately, the coils, because of the coils or whatever reason, they say deteriorated. And we thought that because the aneurysm is taken, we'll wait for some time. There's very good coiling there. Aneurysm circulating component is gone, but the patient deteriorated. And we had discussed after the coiling that we'll do after some time if there is recirculation. But in the night, patient deteriorated. So we had to do next day morning, we had to go in and do an extensive surgery. This is a long surgery, but we did the extradural anteroclenectomy, anterotemporal prolectomy, subtemporal tironal approach, a 1.5. We did the aneurysm decompression, and so we removed many of the coils. See, there is the proximal. You see the coils there coming out. So we are removing coils. We decompressing the aneurysm because there's a lot of mass effect the patient had. All this is a difficult task. But at the end of the surgery, we thought it was good. The brain was lax. The aneurysm was not filling. And we thought we were okay. But unfortunately, the patient remained in altered sensorium and they did not. In fact, she got worse with that. But I think it's too late, too little, too late. This was the brain was very lax. So we were very happy that we had taken care of that. Brain was looking good. It was not swelling. But unfortunately, this didn't really do well. She's still alive, but compromised, very severe compromise. Off ventilator tracheostomy, but as you can see, the brainstem is okay, but she's not well. So flow diverter is not without risk and not a panacea, and coiling is not a good option for giant aneurysm. So a aneurysm like this is an adult patient who presented with visual compromise, hemiparesis, headache, and we did the same thing, OC, extradural anteroclenectomy, intradural posterior clenectomy. And these few millimeters of posterior clenectomy does give you space to get into the neck of the aneurysm, and you can have and surprisingly easy because the aneurysm neck is free of any clots. So we put two multi-curved Yasser-Gill titanium clips, and we took care of the aneurysm, and we did the ECG, ICG. You see the PCA, right PCA, one of the branch of PCA there, right PCA, one branch of PCA, left PCA, and the aneurysm is not filling. But one cautionary for the young neurosurgeon, ICG is not confirmatory, and CT angio is not enough. For all this complex thrombo, giant aneurysm, multi-clipped, you have done it, you need to do a DSA because CT angio post-op is also not enough. Again, this patient had the third nerve paresis post-op, 3 months down the line, he's absolutely fine, there's no problem. So old-fashioned clipping, which is a disappearing act, can occlude most aneurysm. Final slide, flow diverter is not a panacea. We need to individualize, and microsurgery is going to stay. Thank you very much for your attention.
Thank you, sir. Moving on to the next talk, we have Professor Matthew Abraham to talk to us about microsurgical approach of complex ACOM aneurysm, complex MCA aneurysm, and keratico ophthalmic aneurysm. Over to you, sir.
So my talk is, I have 3 talks in a chain. My first talk is on anterior communicating aneurysms. I think there's significant overlap with what the other speakers have already dealt with. So as far as the ACOM is concerned, we are familiar all the vessels of significance, the bilateral A1 segments, the bilateral A2, the anterior communicating artery, the Huebners, the perforators of the A2 and ACOM. Fortunately, they do not come to your view most of the time. Bilateral orbitofrontal branches and rarely the bilateral frontopolar vessels. So these are the projections of the ACOM. We are all familiar with this. You have an anterior view, you have an anterior projection, you have a superior projection, which is very famous for the direction of approach and the complexities. The inferior projection, quite a notorious projection for its bleeds, and posterior projection for all the perforators. I shall just briefly deal with all of them with one example, and also deal with one of the how we tackle a complex valve. Can you switch this up? Yeah, this is my personal series of 112 aneurysms, of which 337 is ACOM artery aneurysms. So this is the position that we commonly use. The ACOM requires, the general concept is that very little rotation, but I think ACOM requires a maximum rotation. And mild extension, too much of extension will give you problems. So I'll just show you the simplest of ACOMs. This is the anterior projection. So the sylvian being opened. By default, I go by terional. I seldom go by subfrontal. It's a choice. Subfrontal has some advantages, but you have to retract a full brain. By the time you open the sylvian, you will find that the brain is lax. I always remove the gyrus rectus. You can see that this is the olfactory nerve. The gyrus rectus removal is not a negative move. It's a proactive move in reducing the frontal retraction. The gyrus rectus is being sucked out. And you can already see the ACA as well as a small portion of the aneurysm already. Now you can see it's quite simple. You can see all the branches coming into it. You can see the A2s as well as the A1s, and the aneurysm is somewhere here. As earlier said by Dr. Sharath, for the anterior projecting ACOM, the clip is a side angle clip. It's a main workhorse for the ACOM. You have to pass a probe to see that your clips will pass freely. Fortunately, no perforators will come directly into your field in an anteriorly projecting ACOM. I'm avoiding the opposite A2 and putting the clip. Always perforate the aneurysm. You're competing with the interventionist. Perfect clipping is required. You should not leave any redundant neck. Okay, so that's clipped. Now this is the inferior projection. The inferior projection is fairly a simple aneurysm, but it can give you a small shock if you're a beginner. No perforator comes into your field. It is stuck to the chiasm or to the optic nerves. It's quite easily clippable. You can see that this is lying down and stuck to the optic nerves. So, but this is what happened. My PDF postdoctoral fellow had just started his section, and this is what happened. Never pack a bleed. Just put a cotton right at the bleeding spot. The smaller the cotton, you have done the job. If you pack an aneurysm, this one, the patient is gone immediately. The pressure is transmitted to the deeper structures and you're gone. So see, I'm putting the tiniest of cottons there. You have to block it with the tiniest of cottons. I'm attempting a fundus clip, which I'm not able to get through, but you have the opposite A1. The opposite A1 is the culprit in most of these bleeds. The opposite A1 is caught, and the aneurysm becomes tamed. It's a very simple, tameable aneurysm. The blunder is to put a large cotton, pack it off. Some people even go for in the anxiety, go for a frontal lobectomy. Those are not required. Intraoperative rupture perhaps becomes a little more common as the surgeon becomes senior, and may not, contradictory to most of literature, it may not really affect the outcomes. The superior projection. This is a projection where you have all the anatomical differences and the complexities. You can see there can be a twist. So when do you call an aneurysm a complex aneurysm? When you have a deflection from the normal projection. If you have two variations in its projection, you will call it a complex aneurysm. So you have a twist here, can have a twist. That's because of the asymmetric flow of the blood. And you may have a tilt, aneurysm may tilt, and there may be a yaw. There may be a tilt forward or posterior tilt. So this is a superiorly projecting ACOM. The characteristic of this aneurysm is the neck is more complex. There will be a neck from the ACA as well as a neck from the A2. You can see there is a neck here, and they are better clipped with a fenestrated clip going around the A2 and reconstructing the ACOM. You can see the first clip is applied, but I know that this is only reconstructed the ACOM. Portion of the A2 neck is still there. A parallel second clip, fenestrated, short, the tip missing the opposite A2. Now, I just try puncturing the aneurysm. There is still filling. There is some more residual neck left, and I know where the neck is. It is against the ipsilateral A2. A third parallel clip around, just a clip. So this is a case where you stack 3 clips, all of the same type, fenestrated, straight, short. So you have an array of short, fenestrated, straight clips, small fenestration, not the fenestration for the ACA, for the ICA, the short fenestration, and I'm opening the aneurysm fundus. You can see this is the array. The A2 is in the fenestration. It's quite healthy, and the ACOM is reconstructed by the inferior clip. So this is a complex this thing where you have this, the neck is twisted. This is the ACOM, and the neck is curved. So you have a curved neck here. So what do? You have to convert this curved neck into a straight neck or use the variance. Again, a gyrosectus has been removed. I've put a temporary clip here. The first fenestrated clip, straight fenestrated clip, goes on to it is meant to catch this part of the neck, this part of the ACA neck. Again, the same rule with the all superior projecting ACOMs, an ACOM neck and an A2 neck, a curved combination. So I have obliterated this, but if we see, some portion of the aneurysm is still filling. That is from the remaining A2 neck, from here. Now, how do I do it? How do I? The same rule I'll pass the next fenestrated clip. I have adjusted so that the small ACOM neck is occluded. I have passed a hook around to see these limits, which has been edited off. You can see this is actually clipped. Here there is a small residual neck. You can see this. I hope you can see there is a small portion of the neck that is behind this. Now, if I pass this fenestrated clip, I don't get it's curved. So I have to bring this in alignment with my first clip, and that is done. So I will say every ACOM is clippable. I have operated a little more than 300, and I have a feeling that no procedure failure, immediate procedural failure occurs for ACOM. It is the most favorable, surgeon favorable aneurysm of all. I've opened the fundus. So the posterior projection, it's perhaps the most difficult one, even for an experienced surgeon. You can see normally no perforator faces you. The ACOM can have 4 to 12 perforators arising from it. And they're all from this direction going towards the brain, towards the base. So you have to go for a fenestrated. I've already put temporary clips around. And this fenestrated right angle is the best option. But you have to inspect the clip after the application. See that its tips are visible. I can see the tips here. I can see the clip tips here. In continuation to what Dr. Sarath had said, the strongest clip is the fenestrated right angle. Fenestrated right angle shot. So thank you. Can I continue in the next presentation? My next presentation is on complex middle cerebellar artery aneurysms. I think we have seen enough of middle cerebellar today. I'll just go to two specific aspects which I think I have a small difference in my technique. I personally do not believe in coagulation of the aneurysmal wall for specific reasons I shall come to. And is it visible from here? I can hardly see. Okay. This forms 15 to 25% of all aneurysms. They are the most difficult for the interventionists. They may grow to large sizes. It's the most likely aneurysm to present with a parenchymal bleed. So naturally, it comes to the surgeon. Great majority of these aneurysms will come to the surgeon. Unfortunately, surgeons in many centers have limited themselves to MC aneurysms and have left an important chunk behind. That is the ACOMs, which are highly surgeon-friendly. 80 to 90% after the bifurcation, 90% project laterally. What are the trunks? Characteristic of an MCA is one of the trunks will be behind the aneurysm. That's a blind spot. Limited blind spots for this one. It's the least convenient for intervention with a failure rate, with a absence of occlusion as high as 40% and long-term failure of around 55 to 60%. The technique is you can go transsylvian or superior temporal gyrus, subfrontal, or from the opposite side. The transsylvian is the most popular. You can go from proximal to distal, where you can get a proximal control. The MCA aneurysm really may not require a proximal control. It may look a little odd, but in many circumstances, the proximal control will evolve as you dissect. Distal to that is the distal to proximal opening, where you go deep into this, one of the easiest methods. Everybody will be doing it. The sylvian is stuck only at the surface. The sylvian is free as you go to the depth. So you open the superficial, go deep, and open the sylvian out from inside out. And then the superior temporal gyrus approach is it's a very sweet approach. Whenever you have a large hematoma, you remove a little bit of superior temporal gyrus, you bypass everything, you just go into the sylvian, and you have a clean field. And the subfrontal approach, that is a traditional old approach where you get a proximal control, maybe slightly an overkill frontal retraction for an MC aneurysm. From the opposite side, when you have a bilateral aneurysm, the MC aneurysm is the sweetest aneurysm to clip from the opposite side. Only thing, you may occasionally get a olfactory compromise because of your approach. Bilateral olfactory transient compromise is the only real problem, but it's eminently clippable from the opposite side. The difficulties can be a giant size, wide neck incorporating the trunks need to be restructured. It's the restructuring that makes it important that the surgeon does his job and the intervention is unable to do it. So when you go for an MC aneurysm, always be prepared to restructure it. The unwieldy walls do not permit us. You have seen many of these giant aneurysms, and many of the aneurysms are rigid. The wall does not permit a clip. In such circumstances, you cannot reshape it by coagulation. The moment you reshape it, there is an intimal separation and the parent vessel will get occluded. Then you may have a few cases where you have to extract the coil. So the technique is clip reconstruction with multiple clips, wrapping. Occasionally, you may have to wrap. The best material to wrap is linen, is cotton. Small strands of cotton can be aligned. Endarterectomy to soften the neck. The real answer for a complex neck is actually not multiple clips. The real answer in most circumstances is endarterectomy. When you do an endarterectomy, the aneurysmal wall becomes pliable and easily clippable. And in the MCA, this is exemplified. If you clip the MCA, the parent vessel is relatively small. When you have a large this thing where you apply multiple clips, the distortion is too much. And the intima gets pushed into the MCA to such a degree that you may have late occlusions of the MCA. So bypass and trapping, and you can have hybrid techniques. I shall go into a neck reconstruction, a reasonably simple aneurysm. This becomes complex because of the neck. It has already, small leak has happened. Use the small cotton. I'm putting a proximal clip. And also putting a fundus clip. Fundus clip is the answer for your MCA temporary bleed, small volume bleeds. Don't go for the perfect clipping. If you clip the fundus, you get plenty of time. No need of a hurry. All failures of prolonged clip is not from the duration of the clip, but from improper clipping of the final clip placement. Time is not too much of a matter. We are pressed to think that in 15, 20 minutes, something will happen. No. You are opening up MCA vessels after 6 hours and getting the best outcomes for strokes. So the panic associated with the temporary clip is unnecessary. Now that has thrombosed off. That small opening has thrombosed. It's no longer leaking. So this neck, this vessel is arising from the aneurysm. So there is no way you can reconstruct this with a simple clip. So I applied it parallel. I have taken off my temporary clips. Now I'm putting this clip parallel to this clip so that it's 2 clips now. But does that answer? These will separate. You can't leave it at this spot. This will separate off and aneurysm will again fill. So the tension on the neck should be relieved. You can't put a curved clip and accept it. To relieve the tension on the neck, I'm putting this 3rd clip, which is coming into this. Is that enough? You shouldn't leave it at that spot. Now the aneurysmal wall can contract and give you a distortion of the clips and cause a refilling of the aneurysm. In such circumstances, it is best to aspirate and open them up. Once it is opened, the endothelium is permanently opened up and it will just thrombose off and the wall will get reconstructed. So this is the simple reconstruction with 3 clips for a aneurysm is incorporating one of the trunks. So this is an aneurysm, which is a large aneurysm with an unwieldy thickened wall. You can see this is the wall here. It's a very firm, hard structure. You can see the large main MCA. So it's a relatively large vessel here. So this is not amenable to such a clip reconstruction because of the consistency. It's very firm and hard. So I'm hooking around this vessel. If you try to shrink this vessel, this will just collapse into the main lumen. So I'm going to cut off a portion of this. You can see most of it is empty. It's so thick walled, only a portion of it is filling. So I've removed the wall, portion of the wall, and still it is a very firm structure. So this is what is to be. The ideal option would be to remove the intima. I'm sorry for the image going to the corner. You can see that I have the temporary clip is not working on the largest one, so I'm putting a permanent clip at its low pressure surface. You can trim it at the neck, just beyond the neck you can trim it. The sharp scissors is the best tool. It will not puncture the wall. Blunt tools will actually tear it off. It is a little more difficult than the carotid endarterectomy. It is a little more delicate. So that is a small bleeder from a tiny perforation on the aneurysmal residual wall. It's clipped easily with a simple curved clip. You have to compete with the interventionist to give a perfect occlusion. So you can't give leave residual aneurysms. Okay. Thank you. I have another talk. I'll start off with my third one. This is surgery for IC ophthalmic segment aneurysms. This is one region which both the interventionist and the surgeon hates. The ACOM is the favorite for both. So this is the Bouthelius classification. This is a more practical classification. I mean, this is the traditional classification that we used to follow. That is the different segments of the ICA. A more practical classification is this, the New York University. But this whole region cannot be differentiated on a routine angiogram. The para-ophthalmic, this whole region looks like any. From your pictures, you will have to take this as one single entity. You can expect them to go below the clinoid, sometimes is a proximal cavernous sinus. You should have arms to deal with all this. Then we have large dimension. It's enclosed in tight, bony, and ligamentous confines. It can involve the cavernous sinus. The aneurysmal wall may be of varying consistency, flimsy or thick, or maybe partially thrombosized, and there is always an issue of cross circulation. The anterior clinoid is the kingpin in all this. That is the main structure of interest. It tethers down the ICA, and release of the anterior clinoid releases the whole region. And then further lateral cutting on the carotico-ophthalmic membrane will release the entire ICA from the cavernous sinus. So you can see the clinoid process. You can have some variations. You can have the interclinoid connection may be there, which can actually sometimes cause a problem. This is the optic strut is the most important thing. Although we talk of the anterior clinoid is removed to remove the optic strut. So removal of the anterior clinoid is not enough. You have to remove the strut as a whole. The ventral wall, you cannot see the fundus. On the dorsal wall, the fundus is present, and in the presence to you initially giving you some anxiety, even before you have a proximal control. The carotid control is useful, but not absolute. It will not give you a field sufficient to do your surgery. So this is a ventral wall aneurysm. A piecemeal anterior clinoidectomy is going on. This is the traditional radial anterior clinoidectomy. The anterior clinoid has been removed, and you can see the strut there. So don't start opening at this spot. Remove the strut also. Drill the strut as deep as possible. Nobody will complain about how sweet your jalebi is. So remove as much as possible. And now you cut the remaining dura, falciform ligament, deep into the region where your strut was remaining. So you can see this is a ventral wall. This is a small ventral wall aneurysm. These are very relatively simple aneurysms. If you have a technique of clinoidectomy, you can see the aneurysm here. They are clipped with this right angle fenestrated, which I said is the strongest clip. It will just miss the PCOM. The fenestrum will just miss the PCOM. So next is the dorsal wall aneurysm, which is actually among the most formidable aneurysms that neurosurgeons come across. Perhaps a trace more difficult than the basilar in some circumstances. So this is, the craniotomy has been done, and this is a Sylvian. This is a giant dorsal wall aneurysm in a young lady, postpartum. So this, I'm going to do this is the aneurysm wall scene. I'm going to do a single piece clinoidectomy here. This is a fast and quick technique, very elegant when it comes to a short ICA in a PCOM. You may have to quickly go for a clinoidectomy. So I've just exposed this. This is the roof of the optic nerve against the sphenoid wing. I'm just passing the drill. A small size diamond drill is a very safe tool. It will not injure anything. You try it on your nail, you will know how benign it is. The higher the RPM, the safer the drill becomes. So it's a single piece. I'm just broken it, and I'm just in this lateral direction. This comes off in a flash. You can see it's coming off from the cavernous sinus. And now this aneurysm is a giant aneurysm. So you really do not know where the optic nerve is. So I refashioned my incision. You can see the optic nerve going around she did not have a visual field deficit, despite this picture. So I'm actually taking my incision little more laterally. This is a carotico-ophthalmic membrane. I need little more control. So I'm extending my incision from this region. This is just a flimsy layer. The deep ring is actually a flimsy layer of arachnoid-like material. It can be, and this is the proximal control in the distal part of the carotid. Now I'd use flow seal. This image is more than 10 years old. Now I'd use a flow seal. Flow seal is very, very elegant in controlling this, but it will produce a transient third nerve palsy. So this is the further direction of the dissection of the, I have proximal control. I have distal control somewhere underneath here. I have a distal control here. This clip blade is going into the cavernous sinus, actually, into the distal cavernous sinus. The second clip here aspiration. You have to continuously aspirate. There will be some blood still leaking in even after your. So you can see there's a small nubbin that is hiding underneath is going underneath the frontal base. It's too tiresome to dissect that from the perforators of the ACA. So I'm just cutting it off. This will be all stuck to the perforators of the ACA here. So I've just cut the wall. I've committed to clipping it. So this has been fully dissected. And this is a ordinary right angle clip. This array is very useful for this sort of dorsal wall. After that, I'm going for a fenestrated right angle around it, passing well below the and the temporal clips are removed. You have to inspect the opposite side whether you have fully clipped it. So this is the aligning of the clips. This is a what do you call it? A tethering clip, where I just cannot get its name suddenly. Reinforcing clip. Reinforcing clip, which it's good for you to sleep well at night after this. So this I made a small study about 50 consecutive patients. This done around close to 7 or 8 years back. With a follow-up of 4.5 years. There's a female preponderance. 22 large aneurysms, 9 were giant. So the proportion of giant aneurysms is much higher here. 45 aneurysms of blood lesions. Mortality in the series was 6. 3 with large infarcts. 39 patients had no significant deficits other than unilateral visual field deficit. 5 patients had mild to moderate deficits. Clinoidectomy. So you can get almost 90% outcome for these. Clinoidectomy and dural ring opening was performed in 48 patients. Only wrapping was performed in 2. There is no incidence of rebleed. 41 patients had at least 1 post-op vascular imaging. 38 patients had no significant residual aneurysm. Thank you.
Thank you, sir. I now invite Professor Kuntal Kantidas to deliver his talk on microsurgical clipping of Dhaka aneurysm.
Good afternoon, and thank you, organizers, again. So I shall be talking about microsurgical clipping of Dhaka aneurysms. Dhaka aneurysms are relatively rare, and they have several unique features. Like they are very small, usually at the time of presentation. They have a high propensity to cause bleed. They generally cause intraparenchymal hematoma, unlike subarachnoid hemorrhage that you see with circular Willis aneurysms. And they largely remain a surgical disease because there are many complexities which prevent successful endovascular treatment on most occasions. So when we talk about Dhaka aneurysms, we talk about aneurysms which arise distal to the intercommunicating artery. So it has got the A2 segment, which is below the corpus callosum. We have got the A3 segment, which is precallosal. We have got the supracallosal segment. The A4 division is based on the presence of the coronal suture. So most often what we see are aneurysms in this location. Aneurysms which occur distally are mostly mycotic, and the rare ones often arise at the A2 segment, but they're very rare. But most often we have aneurysm at this location. So aneurysms of this location are primarily dealt with by 2 approaches. One is the interhemispheric approach or a frontovasal approach. So the commonest approach is the interhemispheric approach. As you see, this fissure is relatively not well developed if you compare it with the Sylvian fissure. And you cannot drain CSF from the basal cystins like you do in the terminal approach. It cannot be done through this approach. So it further increases the surgical difficulty. So I'll show you one case just to highlight the problems that we have. So here is a patient, 38-year-old female with grade 2 SH. We have an aneurysm here at the A3 segment. And there are multiple branches which are coming out from the neck of the aneurysm. The aneurysm is multi-lobed. So we went ahead with the commonest approach, the intrahemispheric approach in front of coronal suture. Let's see what happened. First of all, the brain is tense, so we had to drain some CSF from the ventricle. So that is problem number one. Now we have to take the intrahemispheric approach. We are going in. Sometimes bridging veins will cause a lot of difficulty. The second thing is it is very difficult to find out the right plane because the cingulate gyri will have interdigitations and swelling of the brain will further complicate things. With a lot of struggle, we go in the midline. So we can see there is some amount of subpile dissection out here. This frequently happens. As we keep on dissecting deeper, we find the corpus callosum, which is quite reassuring. We can see the pericallosal arteries over here. So the distal artery gets exposed first. So this is a peculiarity, unlike other aneurysms. Now we retrogradely dissect and try to find out the proximal portion of the artery. Let's see what happens. Now this is another problem. Sometimes even before you have established proximal control, the aneurysm will rupture. So what do you have to do is just keep the aneurysm, the suction close to the aneurysm, let it bleed and put a tentative clip. Now the bleeding has stopped and it has given you time to go around the aneurysm, do some amount of anterior corpus callosal resection. Now this is very important. Once you do that, you see the proximal vasculature comes into your vision. We can see the proximal arteries now. So a late proximal control often typifies an intrahemispheric approach to these aneurysms, unlike the circulovillous aneurysms. Now you have time. You go around the aneurysm, you dissect. Generally, I prefer 5 minutes window, 5 minutes of temporary clipping, then I release it. But here, since the aneurysm ruptured, we had to do it quickly. So we see that the aneurysm is has multiple lobes and the branches are arising from here. So first of all, we put a clip across the neck. This is still not the final clip. Once this clip is placed, we remove the tentative clip. This was the point of rupture. Now you should not stop at this point. You have to make sure that the aneurysm is gone forever. So to be able to do that, you go in, look at the neck of the aneurysm, see if there is anything left behind. And in this case, there was some amount of residual neck, which required me to place the clip more proximally on the artery. But here you'll see that there's still one portion of the lobule is still over there. This is the temporary clip. So some amount of aneurysm bulge is still there. So we need to put one more clip. A fenestrated clip was applied over there. So from this video, you see that there are several problems with distal intracerebral artery aneurysms. But with experience and with persistence, you can circumvent that and you can have a very good outcome. Angiography shows patency of all the vessels and the aneurysm is gone. And you have a functional patient. So in my mind, the key to successful surgery of DACA aneurysm lies in 3 A's. And this pertain to access, be it intrahemispheric or basal subfrontal. Yeah, these limiting structures. Then the aneurysm often has a premature rupture even before you go in. The proximal control often comes late, particularly with intrahemispheric approach. And since these aneurysms are often dysmorphic, so you have to be prepared for different kind of clipology. And regarding approach, there is a lot of confusion whether go ipsilateral, contralateral, a basal approach versus a vertex approach. There are institutional biases as well. And there is, in today's time, mini craniotomy is also another option. So how I generally approach them, I go by the location of the aneurysm. Most often these are located in the supracallosal location. In this position, I would go for an intrahemispheric approach, unilateral, usually non-dominant side. Even if there is a bleed, it can usually be tackled from this side. For those aneurysms which are located just below the corpus callosum, probably a transvasal approach is more suitable. It gives you proximal control. Otherwise, you can also come from top. But the thing is, you have to resect the anterior part of corpus callosum. And the rare variety where the aneurysm is more proximal can be tackled with pterygoidal approach. And our manuscript has been accepted. Some of this can be done through keyhole approaches as well. So let's see one such case. This was a 60-year-old lady with SH. There is corpus callosum bleed. And you see in the angiogram, there are 2 aneurysms. If you look at this video, you can see 2 aneurysms. This is one aneurysm and there is another aneurysm. So we have got a kissing aneurysm just above the corpus callosum. So we decided to go ahead from an interhemispheric approach in this patient. This is the surgical video. So apart from swelling of the brain, there is another problem that you often come across, that is a bridging vein. So if you put a retractor, this bridging vein may tear from the sinus and it can cause a lot of bleeding and can compromise your exposure here. So one useful technique out here is arachnoid lengthening. So what you do is you cut the arachnoid on both the sides of the nerve, whatever length is possible. What it does is it makes the vein free. So whatever retraction you place on the brain, it is not transmitted to the vein. So the vein is preserved. Then we follow the standard dissection of going to the interhemispheric space, utilize the blood clots over there. And you have to understand that the corpus callosum will have a bright, shiny look, not the creamy look of the cingulate gyrus. This is sometimes confusing. So you have to keep on dissecting persistently, and we can see the shining corpus callosum right now. So you can see the pericallosal arteries, callosomarginal arteries. And in our experience, the callosomarginal arteries will give you a natural navigation, and most often you will not require navigation in such aneurysms. You can remove partially the hematoma, which will further expand the space, but be mindful that hematoma is also safeguarding the aneurysm. So you have to do partial removal. Now you reorient your microscope and you see that this is the area of interest. You see that the aneurysm is stuck to the frontal lobe. So one technique that we find useful is dissection around the aneurysm, taking a cuff of brain. So you have to work on the side of the brain, not on the aneurysm side. And with progressive dissection, you can separate the aneurysm with the clot over it, and you can, in fact, play with the aneurysm because the cuff of brain is actually protecting it. And this allows you to go over the top and find the proximal vessels, which are coming in from below. So you have the two pericallosal arteries here. There are some fibrous strands which need to be divided. And it has to be done because otherwise clipping ergonomics will suffer. So we have two pericallosal arteries, both harboring aneurysm at similar location. This is what we call as the kissing aneurysms. This one had ruptured and this one hadn't ruptured. So again, we have to dissect the artery. You have to see all the vessels coming out from here. We have done the ICG angiogram. The Flow 800 software allows you to see it this way. Then you place a right angle clip because the clip application has to be parallel to the parent artery. This is the best configuration. Then you have to make sure that the aneurysm has been completely clipped, and then the unruptured aneurysm is also tackled at the same time. Following this, in order to relax the brain, you can drain some amount of CSF by opening the corpus callosum. And you see all the vessels, patency of them, as well as any residual flow. If there is any, it has to be seen by post-op angiogram. Now, this is the surgical space you see. So progressively, the space expands. And we can see that the vein is preserved here. This is very important to preserve the vein. Otherwise, it can complicate things. The patient had a good outcome, as you see here. I'll take you to another case. Compared to the previous case, what you see here is the aneurysm is located below the corpus callosum. This is where the genu should be. So this is the infracallosal aneurysm. And the aneurysm is projecting superiorly. So this is one case where there is you can go for transbasal approach. This is what we did. The frontal craniotomy has been done. These are the two frontal sinuses. They have been exteriorized. Now we have to deal with the supraoccipital sinus by ligating it and dividing at the most anterior part. And usually it doesn't cause any compromise of the venous circulation. So we have cut dura on both the sides. It is important to dissect the olfactory tracts because any traction on them can lead to their injury. Now, if you trace the olfactory tracts posteriorly, they will take you to the optic nerves. So you have natural navigation available with you. You see the contralateral ICA. Now we are dissecting in the region of the pituitary fossa. See, compared to the previous approach, you have a lax brain. So basal interhemispheric approach will give you access to the basal cistern. You can open the basal interhemispheric space. You can free the structures here, and soon you will be seeing the pituitary stalk. This is the pituitary gland and the pituitary stalk. We can see the H of the anterocommunicating artery. Now, what you have to do is just keep on tracing the vessel. You see one vessel is larger than the other. And from the angiogram, you see the larger vessel is the one which has the aneurysm. So you have to keep dissecting antegradally. So here you have the proximal control first. But the problem is the dissection can be long and arduous. We have to keep on dissecting. The retractors here are just holding the lobes away. As you can see, there is not much of deformation of the lobes. This is very important. So this is the area of the rupture of the aneurysm. one has to be very careful here. If needed, you can apply a temporary clip also to dissect. I always prefer temporary clipping right at the end where I actually need it to be. This reduces the chances of intraoperative aneurysm rupture. The key is to dissect the aneurysm and its neck from all the vessels around it. Otherwise, during clipping, these vessels may be either kinked or may be incorporated inside the clip, neither of which are desirable. So we have the aneurysm totally dissected, the neck is free. So all we need to do is use an appropriate size clip and clip it across the neck. And clipping is not only enough. At the end of clipping, you have to make sure that the clip blades have not taken inside them any of the important branches, including the parent artery or any of the branches arising from here. And finally, whatever you have done, just document it with another angiogram. So we see all the vessels are free. And the angiogram shows patency of all the vessels and the aneurysm flow is gone. And the patient made an uneventful recovery. And this is the surgical cavity you see. So to conclude, in my mind, the key to successful surgery of DACA aneurysm lies in understanding the 3 A's. And rather than having fixation on one particular approach, possibly an approach tailored to the location of the aneurysm and projection of the aneurysm is more logical in my mind. And despite all the difficulties that you may have seen in the videos, most often these patients have a very good outcome, possibly because of their location away from the circle of Willis, for which the vasospasm chances are much less. Thank you.
Thank you, sir. As it's already past 3 p.m. and it's time for us to break for lunch, we'll postpone the panel discussion as a common one after the session on posterior circulation aneurysm. And we'll resume back at 3:45 p.m. for another interesting talk. Please enjoy your meal.
Hello, hello. Hello. Hello, hello.
Welcome back, everyone. I hope everyone had a great lunch. Next, we have a talk on artificial intelligence in vestibular schwannomas by Ms. Babia Pava. Before she begins, I'd like to call upon Professor Ghosh to say a few words.
Dr. Bhavia was actually, she's finally a medical student, just finished her exam, I think going for an internship. And she was the president of the Young Dandy Society. She's very interested in neurosurgery, has always been interested, and she has a lot of publications already on her. I think she will tell us about her publications. She's always interested. She's one of the person who has also encouraged a lot of young students to take up neurosurgery. Okay, come, Bhavya. Thank you.
Thank you, sir. First of all, I really want to thank Dr. Ghosh and the Adult Dandy Society for giving me this opportunity. I genuinely didn't expect India to be this progressive because I have myself been very much demotivated to pursue this field specifically because in our country, we don't have any neurosurgical rotations in med school. We literally don't know what happens inside the OR as a med student. I had a different journey why I wanted to be a neurosurgeon, which we'll talk some other day. But for today, I'm Bhavya. I am an intern in UCMS, and I've been the founding president for Walter E. Dandy Neurosurgery Medical Students Club for India. Today, I will be talking about artificial intelligence for vestibular schwannomas, which is an emerging field in neurosurgery. Now, we all know what vestibular schwannoma is, so I won't go there, but there's another word here, which is called artificial intelligence. It's basically a program that can sense, reason, act, and adapt. In simpler words, when we are simulating the human intelligence in real time by the means of a computer or a machine, it's simply called artificial intelligence, hence the word artificial with intelligence. And machine learning is basically an application of artificial intelligence where the coders are coding some algorithms and we're using input data to train a certain model which can predict future. Sounds crazy, right? There's another tinge to that, which is that the algorithms, their performance basically improves with more data and time, because the more the data, the more the predictive power is supposed to increase. Not always, because there's a thing called overfitting in ML models, which if anyone's interested, they can go and search about it. Then there's another subset of machine learning, which is called deep learning. So there are a lot of ML models like neural networks, support vector machine, Bayesians, decision trees, random forest, blah, blah, blah. But deep learning is basically when neural networks are used to predict something in simpler terms. We'll see what neural network is later. Now, until now, in the past 20, 30 years, very few studies have been published for ML in vestibular schwannomas. And the very first study, surprisingly, was published in 1996, which was detecting the localization of the vestibular schwannoma by the means of an MRI. And ever since then, many studies have been published predominantly in the past 4 years, which tells us that how newer and how novel the utilization is of the ML in VS. So where can ML be used as a clinician? Right from the point the patient comes to you in the OPD with the symptoms of tinnitus, etc. for VS, you can diagnose the patient using CT MRI, but the mere utilization of ML for the diagnosis is in 3 to 4 terms. One is to differentiate between cystic and solid tumors, the vascularity, and to localize it, as well as to differentiate from other tumors like meningiomas and GBMs. Now, humans can do that too, but in a country like ours, where the proportion and the ratio of the doctors to the patients, it's very deteriorated. So this can ease the process of diagnosis. Then comes the most important application that I missed is volumetrics, that is measuring the volume by the means of auto segmentation. And this is most commonly studied as well, where an MRI and CT, predominantly MRI, has been used as an input variable. We'll see what an input is. Then comes the treatment. We know that for smaller tumors, 2 to 3 centimeter, we're mainly going for gamma knife as per the RANO guidelines. And for more than that, we prefer aggressive surgical resection. And gamma knife, ML can also be used. That apart from size, what are the other factors in the inputs that can be used to differentiate? So in simpler terms, ML can tell you as a clinician that should you go for surgery or should you go for gamma knife in this patient, provided the size is between 2 to 4 centimeters as seen in other studies, which is like a controversial size for a VS. Then comes the post-operative. Another important implication that I missed for the treatment was gamma knife planning, because the dose is again a controversial topic, like what's the median marginal dose, how much dose do you give to the surrounding structures, to the cochlea, to the labyrinth. So ML can be used to identify how much dose can be given to either of these, what could be the maximum dose, what could be the median marginal dose, at what ISO doses. And then finally comes the post-operative complications. And like we discussed yesterday, that there are 2 major complications. One is facial nerve paralysis, and the other is hearing impairment. So gamma knife can predict the at-risk patients. ML can predict the at-risk patients for these paralysis, and then we can modify those factors when we know that, okay, these are the factors which can identify the at-risk patients. So we can modify those factors before giving gamma knife. And we'll see that later. And finally, we have recurrence and local tumor control rate and overall survivals. Now, these are the inputs that have been used so far. And it could be clinical features of the patients. It could be MRI. It could be CT, pure tone audiometry. Most commonly, studies have used a conjunction of one or more than this to increase the sensitivity and the accuracies of the model. Now, the efficacy or the efficiency of the model can be detected in the form of 2 major parameters. One is the accuracy of the model, which is an engineering parameter. And we have an AUC, that is the area under the ROC curve, which we make for logistic regression, which is the simplest form of machine learning that we use in daily life in our research publications or in whatever stats that we do for our studies. So the accuracies and the AUC, yes. So more than one model, more than one inputs are used to increase the accuracy or the AUC of the model. This is engineering jargon, but if somebody is interested, they can see that CNN, which is convoluted neural network, they've been most commonly used. And the supposed reason for this could be because most of the studies have been about auto segmentation, which is seen on imaging modalities. And CNN neural networks give very good results when an imaging modality is an input modality. So predominantly that could be the reason. Other models are SVM. SVM gives very good results when it's not an imaging modality, it's an input, like clinical features or audiometry results or the pre-hearing grading, the WHO grading for pre-surgery hearing loss. The other algorithms, you don't have to go in detail because your engineer would do that for you. Okay, so I'm going to discuss a small research experience that has recently been accepted in Neurosurgery journal, the Red Journal, where I've conducted a study with 4 different ML models, where we saw 4 models. It's LR, the simplest form of ML is what I've been talking about. ANN, that's artificial neural network. We had SVM and decision trees. They were trained to predict hearing preservation after gamma knife for vestibular schwannoma and neurofibromatosis type 2 patients, which is a very rare subset. Now, these were the inputs that were first. These data points were extracted for each patient. And you can see there are some numbers there. So these numbers are basically the regression coefficients, like what's the relation of these inputs with the outcome predicted. But this is not Pearson's correlation. This is Lasso's operator coefficients, because Lasso is an operator that is very commonly used, like has started rather been using to increase the efficiency of models that are being treated, specifically that is ML. And the orange ones are the one where some kind of correlation was seen, with the highest being the pre-gamma knife hearing grade. on the basis of the WHO impairment grade 1, 2, 3, 4, and then the others. And the ones which are white in color, they had no relation. So these inputs were not used to train the model. So this was the result. Usually an AUC value of 0.8 plus minus 0.5 is considered to be a good AUC value. And astonishingly, all the 4 models had an AUC more than 0.75, which means that the model was very well trained, and AUC is nothing but the predictive power of the model. The highest was for LR, that is logistic regression, followed by ANN. And surprisingly, because I told you that neural networks give very good results for imaging modalities, but we did not have any imaging modalities. So this is a very big achievement for an ANN model. So what's the interpretation? As I said, the higher the AUC value, the higher the predictive power. And what does it mean for a clinician like yourself? That is, you can adjust the input variables that I talked about. Like you can adjust the dose and see what the AUC comes in the model for that specific patient. And if the AUC is achievable over 0.8, it simply means for a neurosurgeon that model can be very safely utilized in your clinical practice as per the historical data. So adjusting the values can therefore improve the hearing preservation rates. What do we conclude? That ML models are at an investigational stage, and significant advancements in ML technologies that are required to enable the clinical translatability of ML. Efforts should be made to completely automate the workflow. And I'm not saying that the job of a neurosurgeon is completely taken off because you have to do the surgery in a vertilus. But what I'm trying to say, as I mentioned before, is that in India, this can be a big remarkability because the neurosurgeon to patient ratio is very devastating. And if even an ounce of time can be saved, that time can be used in neurotraumatic patients because India is having the largest burden of neurotrauma cases. Last line for those who are really interested in ML. There's a checklist which is called the tripod guidelines, which are suggested to report the results of any ML study. So if there are 22 items and we see the total adherence, it's called item adherence. And if that item adherence is more than 75%, we say that tripod is achieved. Now, what does this mean in simpler terms? It simply means that your evidence of the study, which, we use different ways of evidence like Oxford criteria, Newcastle's Ottawa scale. But for ML studies, tripod is suggested. And if it's more than 75%, it means it's got level 1 evidence and subsequently. Thank you so much.
Thank you. Moving on to the next session on posterior circulation aneurysm, moderated by Professor Matthew Abraham. Again, a gentle reminder to all the speakers to adhere to the allotted time. Now, for the first talk, I now invite Professor Ellen Tripathi to talk about the scopes and pitfalls of posterior circulation aneurysm. Over to you, sir.
Thank you very much. Good afternoon, everyone. Thank you, Professor Ghosh, Professor Anil, and of course, my friend Salim Abdullah could not be here. And thank you, the organizers, wonderful venue. I bring greetings from my family. This is Cherry Blossoms in Washington, D.C., small family together, just been last couple of weeks back, actually. So it's a bit too long. Thank you. So whenever we hear about posterior circulation aneurysm, we used to think, okay, let it go to the interventionists. But having said that, we must realize that subarachnoid hemorrhage aneurysms are basically, we are the boss, we are the captain of the team. And IVR, of course, is a very important member of the team. But we have to decide together. And what happens if they can't do it? You can't leave the patient in the corner of the ward like they did before the cooperative study in 1960s and leave them to die. So we have to do it. So in that case, it becomes more challenging. If you did not do many complicated aneurysms like we've seen today, wonderful presentations by my previous speakers, unless you did them, how are you going to address the failed ones or the ones that the relatives, the patients want you to clip? So let's discuss with a very few examples, because I have been warned, and all of us have been warned about the time, and especially Professor Ghosh said that you limit your presentation to 2 to 3 videos. So that's what I'm going to do.
Now, when we talk about posterior circulation aneurysms, we know what we are talking about anatomically and the vertebrobasilar system basically. And they are rare. In some treated series, 0.5% of the aneurysms operated were posterior circulation aneurysms. And we know largely most of the series quote less than 10% incidence. And out of them, of course, basilar top and then pica are more common. And in fact, they are the ones that we can clip and good results. I will show you some examples. Now, the basic general principles of aneurysm surgery for the sake of residents, we have to expose, we have to dissect, preserve all the branches, perforators, and clip the neck, and without doing any damage to the brain. The approaches for posterior circulation also, pterional, frontolateral, especially if the basilar top, which is common, is above the posterior clinoid, and subtemporal if it is below the posterior clinoid, and of course retrosigmoid for pica and the other similar aneurysms. Now the difficulties, as we know, why it is said that higher morbidity for posterior circulation, because of the depth, the brainstem, and the lower cranial nerve, especially the perforators to the brainstem, the difficulty of proximal clipping for the access, experience. Now, mind the word experience. Unless you do some, how are you going to have experience? And the higher morbidity from all the complications. Now, the availability of alternative treatment, I already said, coiling and flow diverters and all the new implants. There's a big explosion of implants, whether it is industry-driven or physician-driven, that is for all of you to decide. But there is always a bias while we are training. I mean, of course, my training in 1980s and early 90s was slightly different. That time we didn't hear of all this. But nowadays, when people are training, residents are training, they can get an interventional training, but usually it comes after MCH or DNB. And by then, obviously, you have gone through all the rotations. And when you go to intervention, you like that because that's less bloody and less invasive. But that's not the fact. I will show you some studies where the training of surgery is also equally important. And all that glitters is not gold. It's not that coiling and FD, like we have seen earlier today, they're not the panacea of all aneurysm surgery or aneurysm treatment for that matter. The universal facts are the surgery is gold standard, long-term results are better, higher complication rate in posterior circulation aneurysm, length of stay versus cost of implant. Now, mind you, in our situation, the cost of implants is a very important point. And many people, when you talk to them, usually it is twice or a little more than the cost of surgery. So they kind of shrink. And many people cannot afford that treatment. And many of them have to buy the treatment. So there is a higher incidence of dissecting aneurysms in the posterior circulation, as we all know. Now, these are the studies that we looked at about the training and what happens. The old days of see one, do one, teach one, or Halstadian model of training is gone. We have to really train hard, and we do that by various techniques. But then the primary goal of treatment of aneurysm is to treat the disease effectively, efficaciously, durably, with underlying and with minimal morbidity. So, of course, we have had, the workshop is here. Many places there are workshops, a very good advantage for the trainees, young residents and trainees. But then, like I said, the bias becomes later on in the training. If you go to training interventional radiology, there is a bias towards intervention rather than clipping. Now that brings us to the complications of the coiling that we all know, various series up there. Nobody used to talk about non-leak perforation, but that was a very important point of the failure of treatment and recanalization of the aneurysm neck, of the aneurysm sac. Now, the current trend of management, as you know, is majority of them is IVR, intervention radiology. The advantages are less invasive, less morbidity, patient's choice. Many of them will come from Google. They said that, please do the coiling. We don't want our heads to be opened. But then the hard realities are slightly different. And the problems are the difficulty in vascular access in some. I will give an example. Cost, availability, like we discussed. And surgery is, of course, minority, but it's gold standard, like we already discussed. And experience is very important. Now, very small series, majority of those I treated were pica aneurysms and some basilar, and that is because of the intervention radiology interference or taking over. Now, this is a distal pica P3, P4 level with intraventricular hemorrhage, And as you see the anatomy of the pica, the P1, P2, up to P3, you can go retrosigmoid. But beyond that, the aneurysm, I will show you the video, is of P3 and P4 junction. And this is the anatomy, lateral sagittal projection, diagrammatic, and these are the segments that is accessible to the different approaches, two approaches we normally do for pica. Now, this patient was operated in park bench position, and this is a 54 years old male patient. We operated retrosigmoid and standard opening. I will just fast forward it. And of course, the main problem here is the lower cranial nerves, and they looked at the vertebral artery. The vertebral artery was, of course, there, but it was ICA and pica common origin. So that's the 7th, 8th complex, and slowly going upward towards. Now you see the vertebral artery there, and the artery supplying the aneurysm going all the way around there. This is brainstem. These are the perforators of the brainstem, and you see the arteries. I'm sorry, a little bit out of the center. This is the artery, and the aneurysm was right in the 4th ventricle. So this was a P3, P4 junction aneurysm projecting into the 4th ventricle. And this is the proximal clipping. This is the arteries distal pica going into the 4th ventricle. The aneurysm is digging into the 4th ventricle, that you will see very soon. And I'm trying to lift it out of the 4th ventricle and put a clip at the neck. And only problem is the retraction was going a little bit critical. And that is where the aneurysm was inside the 4th. This is the lower part of the 4th ventricle, and near foramen lusca actually. And this is the neck. Go out. And that's neck of the aneurysm. And what you see is inside is the aneurysm. Sorry, I'm taking it out. You see that? So that's a very distal aneurysm, and the interventionist said, I can't access. So what would you do? If you did not have the courage or, faith, I should say faith or understanding, of course, a lot of anatomy, a lot of radiology understanding necessary to do difficult aneurysms, but we could do it, and the patient did very well and discharged on 5th postoperative day. Now, this reminded me of the Horseshoe Bend that we recently visited. Beautiful place in Arizona, where the Colorado River is doing all these damages over millions of years. If you get a chance, please do visit. It is near a place called Page. Now, we had vertebral aneurysms, and this is one vertebral basilar junction aneurysm. Of course, it was a few years back. There was no flow diverter for this kind of aneurysms, so we had to go for clipping. But the problem was that while this is what right side retrosigmoid approach, again the lower cranial nerves, that's a huge aneurysm, very wide neck. This is the towards brains. This is distal. This is proximal, and so I'm trying to find the both arteries. There was a little bit of bleb there, which I of course did not see. In fact, me and my colleagues were operating, and I was standing by while dissecting the aneurysm. And what we thought, we'll do a clip here in the distal vertebral and explore the proximal and put a clip there, isolate it, and then reconstruct the aneurysm, the artery with the multiple clips. But the lower cranial nerves for the residents is a problem here. See that? So that's the distal vertebral. And here is the proximal vertebral. That whole thing is aneurysm. So there was no chance of course, nowadays they will say we'll put a flow diverter. Few years back, we did not have that suitable, and it was going to be very expensive anyway. So after doing that, I'll just fast forward it. And so the aneurysm bled from the lower bleb, and we had no other alternative but to give adenosine and do a cardiac standstill. And for a few seconds only, you get 20, 30 seconds. And during that time, you have to dissect, preserve, and then once you give the adenosine, you see the blood stops, and you get 20, 30 seconds, where it very quickly comes back. And then we reconstruct the aneurysm with multiple clips. So unless, you had the experience, unless you had the courage, so sometimes the divine intervention is necessary. Again, this is a picture from my family trip recently, Valley of the Gods in Utah, where the Forrest Gump, if you've seen the movie, the hero runs near there and takes pictures, Valley of Gods and Monument Valley. Now, this is the lady operated for 3 aneurysms. She came with a ruptured PCOM, and then there was a right ICA, also a vertebral aneurysm. I don't know whether you can see the clip. So 3 aneurysms, including one vertebral artery. This is quite a few years back, and this lady came from Bhutan. Fortunately, she went back after 3 clippings and a shunt for the hydrocephalus. That's the day of the discharge. So yes, complications, complicated or difficult cases will come. But the one I'm going to show you now, probably the last video, because of the time sake, is a ruptured basilar artery aneurysm. And this 68 years old female, of course, hydrocephalus, and WFN is grade 2, grade 3 to second day postictal. These pictures don't show you much, but you do a 3D. The problem was that the cost of implants was very high and the intervention radiologists were not available. See, that happens. Sometimes you have one person who can do it well, he's not there. You're not going to put your hands on the head and wait. You have to treat the patient, save the life of the patient. This one, this aneurysm projected, I'll finish very soon, projected to the left side. This is posterior cerebral, superior cerebellar. I approached through the right side and just quickly forward. So because the tip, the basilar bifurcation was below the clinoid, I did a subtemporal approach, standard as described by Charles Drake and all senior and legendary vascular neurosurgeons. So subtemporal approach, temporal lobe held, internal carotid artery. I'm going to the Lilliquist, opening Lilliquist. This is posterior clinoid. This is third nerve. So drilling the posterior clinoid, medial to the third nerve, Lilliquist membrane, trying to find the proximal basilar trunk. And these are the branches. This is on the right side. That was on the left side. The aneurysm was right here. So you have to do a little bit of holding the carotid. Now, unfortunately, if the posterior communicating is fetal, then you have a worry. Because of the subtemporal approach, the posterior communicating is way in front there. So I could find a proximal basilar artery, dissected the aneurysm, did a proximal clipping, and then went on to do the clipping of the aneurysm. And this patient did very well. Now, sometimes this is real time. There's no editing. So 30, 35 minutes, you're out. So yes, they are challenging. It is a neurosurgical problem. And of course, all these cases are primarily treated by us. Us means neurosurgeons, of course. And as I said, IBR radiologist is a very important member of the team. But we are the captain of the ship. And we, with the proper experience, exposure, and knowing all the pros and cons, we should be able to help these patients. One thing always remember is customer services, what the patients want, what the hospital wants, especially in private hospitals like I am working. Thank you very much for your attention. Sorry for the overtiming.
Thank you, sir. I now invite Professor Sanjay Bihari to deliver talks on microsurgical approach to pica aneurysm as well as basilar top aneurysm. Over to you, sir.
Good afternoon. I'd like to share with you some points about surgical management of pica aneurysms. So the important thing about pica aneurysms is that it has several components. So first is pica vertebral artery junction is the first one. Then the anterior medullary segment is from vertical pica up to the inferior olivary prominence. Then the lateral medullary segment is from inferior olivary prominence to the lower cranial nerve involvement. And then the tonsillomedullary segment is from lower cranial nerve involvement up to the lower segment of the tonsil. And tilovelotonsillar is from the lower segment of the tonsil right up to the peripheral branches, and then the cortical branches supply the vermis. I'd like to show you in 22, as Professor Tripathi had said, as you go from midline to paramedian, the approach changes from midline suboccipital craniectomy to far lateral approach. And I'll show you some of the cases. One of them, there was this giant thrombosed aneurysm, which was treated like a tumor, and there was hardly any vascularity in it. And so this is one of them. There's very little vascularity. Most of it was
thrombosed, and we could actually take it out. One important thing is that in this 22 cases, CT angiogram missed a lot of two aneurysms, and they were later on detected on DSA. The other important thing is pica will sometimes present only with intraventricular bleed, intra-fourth ventricular bleed. And you have to be very careful that if you get an intra-fourth ventricular bleed, please do an angiogram, and not only a CT angiogram, but a DSA, because you might miss out a pica aneurysm. Pica sacrifice you can do when it is distal, but for proximal, which means anterior and lateral medullary segment, and also tonsillomedullary, right up to the lower cranial, please do not sacrifice pica, because many of them are dissecting aneurysms, and you may not be able to clip them completely. So let's look at one aneurysm, which was right in the midline. And this is right in the midline. This is one tonsil, and this is the other tonsil, and this is the branch of the peripheral branches of pica. And there you see, you can see the aneurysm. There's a little bit of, we did a little bit of tonsillar removal, and you can get this is right in the midline. This is very simple to do. And this is one of the aneurysms. Then this patient presented with fourth ventricular bleed, and you can see that there is one aneurysm here. You can see one aneurysm here, which is right at the cerebellopontine angle, close to the lower cranial. So as you can see, this is the retromastoid suboccipital craniectomy. This is the vertebral artery. This is the aneurysm, and there are branches of lower cranial draped over this aneurysm. So we have to dissect this aneurysm. This is vertebral, and this is the pica. So I'll just show you the video. And so again, going into the drained cerebrospinal fluid from the cerebellomedullary cistern, saw the lower cranial nerves. And then this is the pica, which is just draping over the fundus of the aneurysm. This is the vertebral artery. And there is one lower cranial nerve on the aneurysm. And so some of these aneurysms, which are peripheral aneurysms, will be actually accessible to the retromastoid suboccipital craniectomy, and just an approach there. So that's the second type of pica aneurysms, which you can easily look at. So here also, this is actually just remove the lower cranial nerves, and the vertebral artery is right in your view. Just make sure that the neck is well dissected, and you can just apply a clip there and take it into a clip. And this is also a good one. The third one is an aneurysm which is more anterior. So if you draw a line here on the CT angio, you see this, and this is basilar artery. This is one vertebral artery. The other one is very narrow. And this is an aneurysm which is nearly close to the midline. And this also, all of them presented with subarachnoid hemorrhage. And in this case, this is the retromastoid suboccipital craniectomy with a little more exposure of the lateral aspect. This is the tonsil, the cerebellum retracted. And then you see that this is pica, and this is the aneurysm. And this is the jugular process, which you see from within the thing. These are lower cranial nerves. So sometimes you have to drill the jugular process, but here we could actually get to the aneurysms without drilling the jugular process. And this was it was clipped. So just to show you the video, you see this is the retromastoid suboccipital craniectomy. This is cisterna magna being opened. And of course, you can follow the tonsillohemispheric branch downwards, and that's where the aneurysm is. You can see the jugular tubercle, sorry, not process, but the jugular tubercle. Sometimes you have to drill it. Sometimes you have to drill the condyle, and all of them get you anterior to the brainstem. And as you can see that a part of this aneurysm is red and part of it is pink, which refers to the vessel, and I don't have proximal control. So obviously it's a little stressful situation there. So if it bleeds, then it's going to be a mess. So, but see, we are going more and more progressively, we are going more and more anterior. And as we go more and more anterior, the degree of difficulty goes on increasing. And so all these patients made an uneventful recovery. The fourth one was at the vertebral pica junction. And here you see that what we have done is, this you cannot see very well because there is a lot of subarachnoid hemorrhage. This came on the second day of surgery. And it was not possible to access the vertebral pica region, and the vertebral artery was shifted to one side. So what we did was we resected the tonsil on one side, and this is all blood. This is subarachnoid hemorrhage all over. And once we resected the tonsil, then it was possible to get to the the aneurysm here and to the proximal vertebral artery here. So therefore, and this is the pica going here. So it was possible to, so it's kind of draped around the aneurysm. This is the neck of the aneurysm, and we could actually completely dissect it off. And sometimes, it is good to just see a part of the fundus by a subpile dissection and keep the pia intact over the aneurysms, and then you can actually clip it. So this is at the vertebral pica junction, but then it is more medially placed. Now the degree of complexity went on increasing because now this is at the vertebral pica junction. This is one vertebral artery. This is the second vertebral artery. This is the basilar artery. And you see that you have to reconstruct it from behind the lower cranial nerves. Probably now I would prefer to probably put a stent there. I'm not so sure, but it was pretty difficult. And you see the lower cranial nerves, we had to work between the lower cranial nerves, and you see the aneurysm. So we had to use fenestrated clips, which took one of the vertebral artery and then took the aneurysm from behind. And this patient had a STOMI course, significant lower cranial nerve involvement, had to be tracheostomized, and but gradually improved. Now, this is one patient who presented with significant subarachnoid blood. So sometimes when you get subarachnoid blood and the CT angio is negative, you please repeat a CT, an angiogram after some time, because there will be a posterior circulation aneurysm in many of these cases. And you see, this is a very low-lying aneurysm, almost reaching the foramen magnum. And the interesting thing here was that there was a complete dissection of the vertebral artery here. You see this aneurysm here, this is irregular. This is the basilar artery, a lateral view, and these are the posterior cerebral arteries, very thin. When you look at this, this is the AP view, you see that this is bihemispheric pica. This is one pica, this is one pica. And this is dissected, and basilar artery is hardly getting any supply, and this is the posterior cerebral artery. So this is a dissecting aneurysm of the pica with very narrow basilar artery. So this was operated in a far lateral approach. We did not mobilize the vertebral artery, but we kept it in our view. This is C1 arch, this is lateral, this is medial, this is superior, this is inferior. And then we just kept this in our view, did a suboccipital cranectomy, opened the dura, and a little far lateral approach without rotation of the neck really helps in actually reaching the cisterna magna and reaching beyond the cisterna magna. And this is the aneurysm. This was the aneurysm which was seen. And you can see that there is only one pica. This is the dominant pica with this aneurysm, and this is vertebral artery here. And therefore, we actually took it there. And after that, we applied 2 clips and took it out of circulation. So this is the, just kept the vertebral artery in our view. So just in case there was a rupture of the aneurysm, we have proximal control. There was no need to actually mobilize the vertebral artery. And so this is the dura being opened, and so opening the cisterna magna really releases a lot of CSF, and it acts like the membrane of Lindquist in the supratentorial compartment. And this is the blood. This aneurysm had blood, 4th ventricle, and all the basal cisterns. You can see the blood all around. And this was a pica aneurysm. So therefore, the far lateral approach really helped, because it helped us to reach the vertebral artery there, and there is a thick arachnoid over the aneurysm. You can see, and the clot was all around the brainstem. So the next thing, so you can see that now you see this is the brainstem. You see the aneurysm there. Gradually we are dissecting. This is the distal pica, and this is very, very important because it is supplying both sides of the cerebellum. This is a bihemispheric pica here, and so just we actually rotated it on all sides, ensuring that the entire pica is in our view, and we could see the pica vertebral artery junction. And this far lateral approach with all the C1, C2 nerves and all that really helps. So now we could rotate it all along, and the part of it was thrombosed. And now what the important thing is, when we're trying to apply the clip, then it was rotating on this bihemispheric pica. So this is the vertebral artery, this is the pica, this is the neck of the aneurysm, and this is the entire pica. So sometimes, it's very good to have a right approach. And as soon as we applied the clip with the aneurysm in place, there was a kinking of the pica. So then the important thing was to just kind of remove the cap of the aneurysm with the thrombus and apply a second clip on the thing, and then we could actually secure a good, and then we can see the entire pica. We had to make sure again that there was no kinking. So this is the vertebral artery. You can see the entire pica, and a second clip was applied just to ensure that this does not kink. So there were out of these 22 patients, there were 3 mortalities. One of them was there was a concurrent basilar artery aneurysm on the opposite side. As soon as we brought this patient to the ICU, we had clipped the pica, but as soon as we brought this patient, then this bled, and the other 2 developed a low cranial nerve involvement. So to conclude, a fourth ventricular blood without subarachnoid hemorrhage, you can talk about pica aneurysms. The second very important thing is pica aneurysms have multiple variations, and you have to be very careful about these aneurysms. You have to be very careful about the variations. And pica aneurysms proximal to or including tonsillomedullary segment will require meticulous preservation of the parent vessel. You can't sacrifice it. Thank you very much for paying attention.
Thank you, sir. Next in line, we have a panel discussion on anterior as well as posterior.
You're stealing my thunder. This one more. Why is the arrow not coming? The cursor is not coming. Yeah, thank you. So taking on to the next one. Yeah, so then surgery for basilar apex aneurysms, just to show you a few cases here. And so one of the cases, you see that this is a large, or I don't know, between large and giant aneurysm, which is actually splaying the peduncle right at the basilar apex. And as you can see that a part of it is below, the neck is below the dorsum sellae, and the fundus is about the dorsum sellae. And when we did the CT angio, we found again the same thing, that the 2 vertebral arteries are okay. This is basilar, and this is a little bit above the thing. And on the sagittal image, a part of is above the dorsum sellae, and this is the basilar artery here. And so what we did was zygomatic osteotomy, frontotemporal craniotomy, extradural. What we did was temporal dura separated from the cavernous sinus dura, and then the middle meningeal artery was removed. And then the important thing is this is the greater superior groove for the greater superior petrosal nerve, and this is the petrosal nerve which is being cut. And this is where the internal carotid artery is. That's the landmark for the internal carotid artery. Then the cavasses quadrilateral is being drilled. This is the arcuate eminence here. This is the and after that is drilled, then we came to the frontotemporal craniotomy. The dura is open, and because we had already drilled the cavasses quadrilateral, we went subtemporal here, and we cut the superior petrosal sinus, and then cut the tent just posterior to the fourth nerve. This is in the arachnoid is the fourth nerve, and this tent is completely cut. This gives us a lot of space there, and proximal and distally. And it converts the posterior fossa and middle fossa into one single compartment. Then a very good sylvian opening. You see the ICA. This is the dorsum sellae seen in the carotico-optic space, but the aneurysm could not be seen, and I didn't want to take a risk. So we went lateral to the carotid artery in the segment. So this is the third nerve going into the cavernous sinus. Here will be the internal carotid artery, and this is the area where there is blood. And because there's this aneurysm bled already. And you can see the fundus of the aneurysm in the space between the third nerve and the carotid artery here. So this is the fundus of the aneurysm, thick arachnoid all around. But the problem is there is no proximal control. So, and the fundus is also not very clearly defined. So just parallel to the third nerve and in the corridor lateral to the third nerve, we opened the arachnoid. And once we had opened the arachnoid here, so this is the tentorium here, this is the anterior aspect, this is the cavernous sinus, this is the third nerve, and we are opening this, just trying to get proximal control of the basilar artery. So you can see that this is the proximal basilar artery, and this is the entire large or giant, I don't know, aneurysm, and which had already bled. And this is the posterior cerebral artery. This is the third now, and this posterior cerebral artery is draping like this and coming down like this. So still, I'm not satisfied with either the dissection around the brainstem, nor do I have adequate proximal control. So first of all, what we've done is just trying to dissect the posterior cerebral artery and trying to dissect the aneurysm from the brainstem. So that is the first aspect. And now with a little bit of, just drilled the bone a little more and then retracted the dura. So I could get proximal control here. I could get the posterior cerebral artery here. So now the entire posterior cerebral artery ipsilateral is dissected. This is the third now. This is the giant aneurysm, and the carotid artery is here. So we are working in two corridors, lateral to the carotid artery and lateral to the third now. And now there are some perforators going to the brainstem that we have defined. And this is a very important part. This fascia is the fascia between the carotid artery and the oculomotor nerve. We often neglect this fascia, but just opening that also gives you a huge corridor there, and which also makes you can see the opposite side, the opposite posterior cerebral artery. And so once you do that, I'm trying to now go to the opposite side of the aneurysm, trying to understand where the posterior cerebral artery is in relation to the aneurysm, very gently, just making sure that I know. Oh, so that's where I see the posterior cerebral artery there. You can see the posterior cerebral artery is seen. So now I have a fairly good idea about where both the posterior cerebral arteries are. I have been able to lift up the aneurysm from the brainstem, and I have a good corridor. I have a proximal control. So therefore, and now the first clip will be here going a little angulated forwards, so that it makes, and it has a fenestration which takes the ipsilateral posterior cerebral artery. And so very gently, so the key is to go very gently. There are two clip technique which everybody is talking about is very important. You can actually apply distal clip first or a proximal clip for second, but you must have a two clip technique with such large or giant aneurysms, because if you don't do that, if the clip is still pulsating, that means it is not properly placed. You must ensure that. So now I can see the opposite posterior cerebral artery. I can see the third now, and I know where the junction is, and applied the second clip with the fenestration taking the ipsilateral posterior cerebral artery. So this is done, and then just to ensure that the clips are well placed, just did the ICG, and it shows this is one posterior cerebral artery, this is the other posterior cerebral artery, and so this is quite well placed. And then post-operatively, patient did reasonably well. This is the final image. And post-operatively, what we did is we did a CT angiogram, and that shows that it's completely intact, and these are the artifacts. This is the dorsum cellae, this is anterior, this is posterior, and you can see both the posterior cerebral arteries. And of course, there was no infarct in the occipital area or something. This patient did quite well. There was a transient third nerve palsy which improved after some time. In the case 2 is a small aneurysm which is quite low as compared to dorsum cellae here, and this is some angulated view which shows the vertebral arteries are co-dominant, and this is one posterior cerebral artery and this other one, and this is the aneurysm here. And here what we did was we did an extradural clinoidectomy. And before you do an extradural clinoidectomy, first of all, the sphenoidal wing has to be coagulated. But the most important thing about an extradural clinoidectomy is to open the meningohypophyseal band, orbital band. So once you open the meningo-orbital band, then the entire clinoid process comes like this. So this is the third, fourth nerve complex, and this is the second nerve complex. And between them, you get the entire extradural clinoidectomy. So this is the second nerve, this is the third, fourth nerve, and the cavernous sinus, and this is the internal carotid artery here. You can see it. And then because there was a subarachnoid hemorrhage, you can see all the blood in all the cisterns here, and the brain was a little tense. So opening so there's blood in the carotic optic space, opening the membrane of Lilliquist drains a lot of CSF. Please go slow here so that as you drain CSF, the brain starts relaxing and you get more and more space here. And gradually, I'm just trying to find out, like Dr. Tripathi said that you in the carotid optic space, maybe I can get the aneurysm, but it was not because it was lower than the dorsum sellae. So there was no way I could get it here. But anyway, what I did was to just open it. And this is the dorsum sellae that you see here. And the same technique now, because it is not available, not present here. So what I did was just retracted the temporal pole, just making sure that the third now I can see. Now the CSF drained, so the temporal pole is, and just keeping the superficial middle cerebral artery completely intact. This is very important. Vein, sorry, very intact. And this is the pituitary stalk here. This is the third now. And this is, you can see the pituitary stalk. And gradually as you dissect, you can see now the beginning of the aneurysm. So again, this is the carotid artery. This is the third now, and you can see the basilar artery aneurysm here. And it's covered by a clot. And this is the proximal part. Again, the same thing, you should not directly go to the aneurysm. You have to take proximal control, and you get a lot of space here. So it's not like there is no space, there is a lot of space there. If you find different corridors, you will get a lot of space. So this is now, the brainstem is exposed, the proximal basilar artery is exposed, and just trying to dissect out, this is the ipsilateral PCA, and this is the aneurysm. And it is covered by clot. There are some perforators, very important thalamic perforators here. And creating space there. This is the pituitary stalk, which is often draped over the aneurysm. And the opposite PCA, I can see the opposite PCA going here. So you see, it's not very difficult. You actually, this is the aneurysm, and you can clearly see the opposite PCA there. So now I am gradually dissecting out this clot here. And you can clearly see the neck here. You can see the opposite PCA. You can see this PCA, the superior cerebellar artery, and the ICA, and you can see the aneurysm there. So just creating space. But now now I'm in a very comfortable position. I have the neck of the aneurysm with me, and I have dissected. And this is the contralateral PCA, the ipsilateral PCA. Only this piece of clot is there. I could ignore it, but this is the proximal basilar artery. This is the third now here. So, so this is the aneurysm. But when I dissected this, so so there's no proximal clip application. I tried to avoid temporary clip application. I already knew that I had the entire neck in view. So I usually avoid clip. So what I've done is the fundus of the aneurysm we have clipped. Now, once the fundus is clipped, I have a very good neck control. So then I just apply a single clip. And the advantage was also that I could clearly see the opposite posterior cerebral artery. So this is the pituitary stalk, and you can see the contralateral artery. So, so this is clipped, and you can see the opposite posterior cerebral artery. And then we did a ICG, and this is now, ever since I have left SGPGI, they have a better system now, but that time it was black and white. You can still see both sides, and this is the basilar artery and the contralateral ipsilateral. And then post-operatively, we also got, this is the view, and a little bit of, when you do an extradural clinoidectomy, there will always be some dural breach, which you also have to kind of seal, so that there's no CSF leak from there. And now this is post-op CT, which is reasonably okay. And you can see both the posterior cerebral arteries are well seen here. Just to show you one or two cases, sometimes this is completely anteriorly directed, and therefore you have to be very careful that you may not see the contralateral posterior cerebral artery, because this is actually embedded into the dorsum sellae. And the fourth one, which is also a very interesting one, this is just, there are no videos. I just wanted to show that this is a flow-directed aneurysm of the basilar artery, a giant aneurysm, and we applied 2 clips exactly the same way. This is the post-operative image, which includes both basilar arteries are well seen. And this is my last slide. So this is the ICA, and this is the third now. This is the posterior clinoid process here. And so this is the basilar artery, because this is very high up. This is much above the dorsum sellae. And this is the ICA, this is the middle cerebral artery, this is the basilar artery, this is the pituitary stalk, which is draped this is the pituitary stalk which is draped on the aneurysm. You can only see the ipsilateral PCA. So the only thing is work parallel to the PCA and apply the clip, and then hope that on the opposite side, the PCA will be intact. And then once you applied the two clips, then you shift it downwards and see the opposite PCA to make sure that it is in position. Thank you very much for your kind attention.
Thank you, sir. We'll now have a panel discussion on anterior as well as the posterior circulation aneurysm, moderated by Professor Sanjay Bihari and Professor Matthew Abraham. I request the speakers of both the sessions, Professor Ellen Tripathi, Professor Sarat Chandra, Professor Kuntal Kantidas, to take part in the discussion.
So coming to anterior circulation aneurysms, beautiful presentations. I have some very basic questions for all the masters in the field present here. There are several people here, youngsters, who want to start aneurysm surgery. And all of us who work in big hospitals, we have 80 clips with us. We have fenestrated clips. We have this type of clip. We have that type of clip. Dr. Sharat told about clipology and so many things. Now, the problem is if somebody is starting a career, then what is the basic minimum instrument requirement which the person should ensure before he goes to operate? And do you really plan your surgery and then get a clip which is ready for that particular surgery? It's open. That question is open. You have to take the mic because everybody can hear.
The neurosurgeons don't want to take in surgical. I think they'll spend their finances on a single plain DSA and a catheter. I'll be very frank. This is the news from the biggest training program in the country.
People will do surgery, aneurysm surgery. It's not like it won't be done.
In the trust hospital, we have got established, as you see, a large clip bank which is accumulated over the years. But in smaller hospitals, which I have seen the practice, is that the clip people itself bring a reasonable set of clips for you. I think that problem is taken care of. So you have to realize whether you're going with the Sugita system or whatever system, find out the dealer and tell him in advance. So he brings you a reasonable number of clips. You can look at it and tell them that I want this also. So they do that. So they bring it. So in private hospitals, even in Apollo, sometimes we have a in-house sitting thing, but we get extra clips from the clip. So that's not a problem in all over the country,
So, yeah.
I had a comment actually. We currently purely placing a clip and preventing a rebleed is not enough. This is going to evolve, if particularly a young patient, the disease is going to evolve over the next 2-3 decades. So only with perfect occlusion of the neck will you get a. So there is, I don't think we can compromise on the clip array that is available now. That will actually destroy the entire field. I think we should encourage the clip company to bring the
can you speak into the mic?
Bring the whole array of clips so that any number can be used. You better be liberal on the clips and on the variety of the use.
What a system that we developed there was that we borrow about 60, 70 clips from them and pay for about 15 of them. So 15 are our property. And as soon as we take one, then we replace it and then pay for it. That is something which can be.
There is a problem. Actually, here currently, the dealer buys only those clips which are
used.
Yes. The rest of them are all kept away. It took me 6 months in Ernakulam to prompt him to buy the whole array.
Actually, all the rare clips. So what we have done in a trust hospital, we have a huge clip bank, all the complex ones. But the point is that most of the times you're not using those complex oriented ones. Most of the times you're using the standard ones. So you keep replacing those and keep building on the complex ones. So reinforcing all those, you keep it. In the rare situation you may require. But the common aneurysms, obviously, you can have a reasonable clip bank, which probably all of you should do it if you are in private practice. In fact, I carry a full set of bipolar forceps despite being in Apollo. I have recently bought the entire set because it makes sense, no?
And we'll go fast because there are many questions which I
Please,
have to
please,
ask.
go ahead.
The second question which I have is this thing about temporary clipping. Even now, I'm not sure how much is the safe temporary clipping time, and should because there were two views. Sharath and I think Dr. Tripathi were using temporary clips, but Matthew and I were not using temporary clips. So, what is the philosophy, and how much is the actual time for which you should actually apply a clip safely? Because what I feel is that if you apply a clip, then you are kind of becoming predetermined into dissecting fast, and there is a pressure on you. But if you are gentle, then 90% of the times you can actually dissect the entire thing before you can take it. But of course, the philosophies can differ. Yeah,
I have a view that as a surgeon evolves,
very short, so that
as a surgeon evolves, the number of ruptures actually may increase rather than come down because you're dissecting it fine to the very tip. So rupture is not something to be worried of. It is part of your tactic of controlling the neck perfectly. Now the issue is if you put up a temporary clip early, you will have a more prolonged ischemia. Maybe if once you're confident with your technique, I think a late temporary clip would be a better option, as sir was telling. The second issue is, I don't think it is the duration of the temporary clip that is going to affect you. It is the perfection of your final clip placement that is going to be. We are now
so what is the time that you propose?
Now, I've had a situation where there was a 40 minutes one, absolutely no problem.
What is a safe time for you?
It is said to be 20 minutes based on burst suppression of the yield.
So 20. Sir?
Thank you. I think with experience, of course, you avoid temporary clip, but for young people, I think you must be prepared for a temporary clip. Because if you put a temporary clip, of course, not too early. You know where it is, you're going to dissect. If you do a vascular surgery, aneurysm surgery, you should be prepared for rupture. And you've seen beautiful methods how to control the rupture and how to get the aneurysm. Should not fear about a rupture.
So,
and always you should have an assistant.
So what is your time, sir? What is
5 minutes release and then 5 minutes release. So yeah, you can go on if you are operating on a difficult aneurysm.
So what you're saying is that intermittent 5 minutes.
That's right.
Ashish, yeah.
I think the same 5 minutes intermittent, but I apply the clip temporary clip very late. It's only for temporary clip is applied only for if there's a branch over the fundus which I want to dissect. If I want to do, I love the water bath coagulation. I keep on irrigating and I keep on making the neck. For that, I need a temporary clip. The rest, I don't need a temporary.
Thank you. The next question which I have for all of you is that I have noticed that you are applying multiple clips, wall reconstruction and clip and clip and clip and clip, 4 clips, 6 clips. I have always realized that anything more than 3 clips means that there is going to be some perforator injury and my patient is not going to wake up. So what is your experience on that? And say, for example, a giant aneurysm, rather than cutting it, I would, because it's a thick walled aneurysm, it's not going to rupture. I will turn it around, make sure that it is all in my view, and then maybe see the optimum part of the neck and then clip it. So there are many ways in which you can do it. Another thing is that rather than taking the clip in one go, if you put temporary clips, rupture the aneurysms, then the number of clips significantly decrease. So these are some of the techniques, but what is your take on this? How many clips do you think is optimum? And what is your experience about perforators coming in your multiple clips when you're reconstructing vessels? Sir? Nobody's volunteering.
Let me answer this question.
Yes, sir.
If you can do clipping with one clip, that is the best.
Yes.
And you should strive for having one clip. Of course, in some situation where the aneurysm is large neck, when the aneurysm is huge, where you want to put multiple clips and all, I think strive for one, but if necessary, put more than one. And if there is a beauty, if you have put one, and then you have some leeway for further dissection, and you have leeway for further dissection of the perforator, so the next clip will be a little better.
Yes.
So I don't see any harm in putting more than one clip, but one clip, if you are putting right in the neck, that is the best.
In putting 5 or 6 clips is always, Dr. Patuk, would you like to add to that? Yeah, you can.
I agree with Professor Goel.
But many a times, as Dr. Matthew mentioned about, to have a complete obliteration of the aneurysm, you need to use maybe 2 or 3 clips. So I so often use in it.
10 minutes more because it's two sessions together. Yeah. Yeah, Matthew.
If you are requiring a very large number of clips, your technique may not be great. In such circumstances, I have a feeling that you can modify the neck more by doing endarterectomy or soften the aneurysm, temporary clips around, make it soft. You're having to put 7 or 8 clips. That means it's not a great solution.
There is something. Yeah.
Something.
Yeah, Ashish, yeah, please go ahead.
My policy is 1, 2, max 3.
Yeah.
So,
Yeah.
the best thing is, if it's a non-calcified aneurysm, bottle bath coagulation. Keep on irrigating, keep on coagulating close to the neck. The neck forms. This I learned from Incodoling. And second is, if it's a calcified aneurysm, endarterectomy helps, but sometimes even the outside wall is there. You need a series of a couple of them. You need a fenestrated, non-fenestrated, something like that, because you're clipping a curtain actually.
Absolutely. Now, coming to specific aneurysms, one was carotid ophthalmic aneurysms. So there could be several ways in which preoperatively you could find out whether it is below the anticlinoid or it's away from the anticlinoid, and your degree of difficulty decreases significantly if you know that a part of the aneurysm and you have proximal control and it's not part of the proximal part of the neck is not in the anteroclinoid. So what are those things that you look at, Dr. Matthew, to... So what are the landmarks that you look at on angiogram?
I look for the bone, whether your anteroclinoid is pneumatized. That's all. I think a reconstruction of the...
Yeah. So actually, to just specify it further, first is anterior clinoid and look at the proximal part of the neck. That's number one in several views. And the second important thing is there is a little constriction just distal to the ophthalmic artery, or just proximal to the ophthalmic artery. That tells you that this is the distal ural ring. The third is the ophthalmic artery is just distal to the distal ural ring. That tells you whether the relationship of the aneurysm to that particular thing. So these are some of the ways. There is one more important point here, which I think we need to discuss. Yeah, sir, please. Sir, Mike, please.
If you have any doubt, expose the neck. Let's say a very small exposure. At least you're ready.
Yes.
Rather than asking the anesthetist to compress the carotid, at least you got a clip there.
The other thing about the carotid ophthalmic aneurysm is that if there's a good cross flow from the opposite side, then you have a good, you can actually get away with a lot of issues.
I want to make one point.
Yes, sir.
When cavernous sinus surgery was evolving.
Yes, sir.
At that time, about 30 years ago, which operation of mine was the most fascinating and tantalizing for me was intracavernous aneurysm surgery. During that time, that was, Vinko Dolan had come and described all those things. So that we were doing, and we used to have disaster after disaster. You will also remember caroticocavernous fistula. Fabian Isamat had described that open the cavernous sinus, introduce muscle in the cavernous sinus.
Or electric current,
and,
thrombosis.
Parkinson triangle open, this and that. I was doing myself during that time. You must also understand and recognize that things have evolved since then. Like if I do cavernous sinus aneurysm now, I will be considered an absolute fool.
Yes.
If I do caroticocavernous fistula by surgery, I will be recognized as a fool.
Yes.
Similarly, we must also recognize that caroticocavernous fistula is at a threshold where endovascular is also evolving and surgery has also evolved over the period of time. And we have to recognize that there are options available. If you find some controversy when you see, you don't think that I can do it and I can do it, and you can, of course, do it, but you can create a disaster unnecessary. So you should keep that option. For instance, posterior circulation aneurysm. Believe me or not, all the time we were struggling with basilar artery aneurysm and basilar artery trunk aneurysms and things like that. And if I recognize for last several years, these have been taken over by endovascular.
Yes.
My take on aneurysm surgery today is I will say all MCA bifurcation aneurysm I will do by surgery. All ACOM artery aneurysm I will do by surgery, when others even like to, hang over with the endovascular disc type of implant and that kind of thing. But I will say ACOM is a beautiful option. Like DACA aneurysm, beautiful surgery. Cavernous fistula, this ophthalmic artery aneurysm is here and there. And we must, if there are surgically beautiful things that we can see little bit dissectable carotid artery and this and that, of course we should consider surgery. But if you think that there can be some little bit extension in cavernous sinus, you have to expose that area. I don't think we should now, and in this age and era, stick our neck and say, yes, we can do it. Other thing is this blister aneurysm, for instance. These are also very tricky aneurysms. And if you are recognizing clearly, some people do bypass before the blister aneurysm surgery. I recognize that Dr. Ghosh is getting restless.
Fine.
And
Can we have 5 minutes for just specific aneurysms? Huh? No. So the next point I'd like to mention is when you are doing this DACA aneurysm, vein coagulation, supposing, how do you prevent vein coagulation, vein rupture? Kuntal showed that you can actually dissect out the vein, and yet some of the veins may have to be sacrificed in the interhemispheric fissure. What is your principle for vein sacrifice in the DACA aneurysm?
I will say about DACA aneurysm. My experience with DACA aneurysm is that the surgery on these aneurysm and the outcome after surgery can be highly unpredictable. Like you think, one thing that DACA is there, even if you take the anterior cerebral artery, what will happen? Nothing will. That is and then that is the reason we go and clip the neck. It ruptures very frequently, you clip. But the outcome, sometimes you have done a beautiful clipping and outcome can be an unconscious patient. And have you experienced that or no?
No, but I mean, specifically technique of surgery, because we should not actually, yeah. So what are the methods in which you preserve veins?
There is a small issue with this DACA. They might have bled, multiply bled. Of all aneurysms, these are aneurysms which have multiply bled. There is often a very difficult interhemispheric corridor when it comes to. This is one aneurysm where image guidance will help you. You can actually go through one of the cingulate, making the narrowest of exposures. So this is what Sir said is, you can very often have a patient who is abolic.
Yes. One small point, which, just one. So, one small point where I think aneurysm surgery really helps is, do not focus on the aneurysm initially, focus on dissection of the, say, Sylvian fissure. Go on dissecting it to a large extent. If you make it very open, then it automatically falls apart. Or if you have a DACA, then rather than making a very small craniotomy, make a larger craniotomy so that you can work between two veins and open the fissure. And that way, either you work in the anterior corridor or you can work in the posterior corridor. So, there are some ways in which, and never go to an ACOM aneurysm before you open the membrane of Lilliquist and drain CSF from there, and open the supracellular cisterns and drain CSF from there.
I think DACA has only two suicidal points. One is the vein and one is the proximal control.
Yes.
You can master these two, DACA is a piece of cake. And the best thing is a wide longitudinal exposure over the superior sinus, so that whatever you may be using an MRV or you may be using a venogram, and that's nothing, you cannot predict the course of these veins.
Yeah.
And these veins are important.
Yes.
And like Dr. Goyal said, they can have unpredictable. You
Yes.
knock off a vein, there's a big venous infarct. Normally there may not be a venous infarct, but in this colloid cyst may not be a venous. But here, I've always seen a venous infarct happening. So have a long longitudinal exposure. Open the interhemispheric fissure widely, not in the transverse axis, in the
longitudinal axis.
You must expose the pericallosals and then I go a bit lateral and walk over the corpus callosum, take a bit of the genome, maybe 5 milligram of genome, and then you're right on the proximal control, because there the angulation is around 60 degrees.
Yes.
You must have a proximal control before you even touch the aneurysm.
Yes. The other very important point is, when we are dissecting the fundus and the neck of the aneurysm, there is a very nice technique. Rather than coming to the point of angulation of the aneurysm and the vessel, always go from fundus downwards, because here there is nothing. When you come here, then it may bleed from the neck. Here, if it bleeds from the fundus. So you will still be able to control it. That's a very small technique that you learn. One small. And the other important point is, keep it very irrigated. That irrigation gives you elasticity. The veins keep it irrigated. The aneurysm keep it irrigated. It allows a little bit of elasticity, which really helps you. The tissue doesn't get stuck to your, instruments. Yeah.
It's a small contradiction with what Bihari sir has said. What?
Yeah, sure, please go ahead.
there is in emphasizing on the fundus approach. Yeah.
The neck.
There
No,
is,
so neck.
I'll just say my subjective feeling is this is one aneurysm which can be, which can be.
No, I'm not saying go to the fundus. I'm saying fundus to neck rather than neck to fundus sometimes. Not actually dissecting the fundus, but there getting a injury here is a disaster. You don't know where that junction is. So just start a little above and then come down. That helps. Sorry. So I think would you like to ask some questions, please?
Yeah. Regarding posterior circulation aneurysms. My question is, which side will you approach basilar top? Will you go from the side where the fundus faces you, or you will go from away from the fundus?
Now that depends, but usually basilar top aneurysms will be right in the center. It will be like superior cerebellar will be more on the side, but usually what happens is basilar will be the other thing is if you go from the side, if the fundus is pointing away, then it becomes very difficult to actually go to that side. So sometimes it might be a good idea to approach it from the side facing the fundus. Sometimes that might be an idea.
Suppose the percheron is arising from the opposite PCA, proximal PCA basilar junction, then going from the side of the fundus is tremendous advantage. Away from that, you'll never see that. That is the thing which you'll never see.
I take it on the high and the low riding. If it's a low riding and I'm using maybe a subtemporal or a anterior transpetrous approach, then I have to go on the side of the neck. The fundus has to be away from me because then you have a proximal control and you can water bath coagulate and do that. But if it's high riding, you cannot be on the fundus cannot be pointing at you.
There's only one point I'd like to tell you in basilar top aneurysm when you're starting it. Please do an anterior temporal polectomy. That really helps. If you do an anterior temporal polectomy, you get a huge space lateral to the third nerve, between the third nerve and the internal carotid artery, and it makes your job very simple. Just do an anterior temporal polectomy initially. Yeah.
Can I add this one? Do you think a polectomy is required or just an uncus removal is required?
I think more than the polectomy and the uncus, that gives you for the retraction. But I found that even if you're using a proper temporal polar approach with good relaxation of the brain, I think more important is cutting the falciform ligament. If you have the ACPs coming, the Incos 3T approach, or more important, which I found is cutting the oculomotor trigone. If you cut the trigone over the third nerve, you can actually mobilize the third the tentorium. And if it's much low riding, cut the tentorium behind the fourth nerve.
What about the division of the PCOM?
Yeah, the division. I feel that the last one I should have mentioned. Drilling of the posterior clinoid must be mastered. That is something that the cadaver dissection programs don't have it now. They had it when I was training, but drilling of the posterior clinoid. Anterior clinoidectomy is straightforward. It is intradural, extradural. Drilling of posterior clinoid.
One aneurysm sir had shown the posterior clinoid
was bulging
over the. Just over this.
So I think if you want to do these aneurysms, drilling of the posterior clinoid must be mastered.
I heard Laligam Sekhar mentioning about 2 points. The side of approach for basilar top. One is if you have a fetal posterior cerebral posterior communicating, avoid that side. And second is if the fundus is very tilted to that side, you go from that side. Otherwise, you go from the non-dominant side. These are the 2 points.
I just wanted to ask you a question about the pica. Voice is such an important thing. A person's social position actually depends on how he can talk. Most pica aneurysms which are more proximal will result in some form of lower cranial nerve injury. You absolutely cannot avoid. So do you think the interventionist has a clear edge at that spot? Although it is a reasonably simple aneurysm.
If it is completely accessible, see, many of the pica aneurysms are dissecting aneurysms where surgeon has a little role except to just, clip the distal pica, or the endovascular surgeon can just block the pica. So many of them are like that. But the point is, if it is accessible and within your reach and very close to the lower cranial nerves, it is possible to do them. But if it is anterior to the lower cranial nerves, then it might be a big issue. And especially, you cannot actually sacrifice pica there. So in that case, endovascular team does have a role. However, the pica is very tortuous. So sometimes the endovascular people will not be able to put any coil into it.
Most of the time, pica is blocked by the endovascular people. Hardly ever it is coiled. I'm yet to see a properly coiled pica. Like the DACA also, more than 2/3 of them are occluded. Yeah, they knock off. I just wanted to, this is a basic point. Always throughout the history of treating aneurysms, the interventionist had the first choice. If they can do, then it will not come to the surgeon. But when it comes to posterior circulation aneurysms, do you think the surgeon should have a first choice? And then only will the training evolve. The confidence of a surgeon is destroyed by a bad basilar top. The sweet basilar tops will tilt the balance in favor of the surgeon. Your opinion regarding? Yeah. Do you think that we should have a first choice when it comes to a basilar? In the discussion,
I would say the patient has the first choice.
I think in interest of time, we'll stop now because there are people waiting online for the talks. So we'll go to the next session.
So let's move on to the next session on AVM, moderated by Professor Adil Chadla. For the first talk, we have Professor Ravi Mohan Rao connected with us to deliver a talk on microsurgical excision of AVM. So, are we audible, sir?
Yeah, I'm able to
Sir?
hear you.
Yes. Okay, sir. Over to you, sir. So, are we audible?
Yeah, I'm audible. Should I start my talk?
Yes, sir. Yes, sir. You can proceed.
Thank you very much. I'm going to talk on a few pearls of AVM resection. I work at Apollo Hospital, Seshadripuram, Bangalore, and this is my neurosciences team, and we are a group of 3 neurosurgeons who do surgery together. I thank Professor Siddhartha Ghosh for this wonderful opportunity to present my talk. And my apologies that I was not being able to be present there for some reason. Now, how do we make AVM surgery safer and easier? The first point is adhering to principles of AVM surgery and very important, appropriate case selection. And I personally use targeted embolization to reduce the risk of hemorrhage during surgery in higher grade AVMs and in AVMs which are bled with a weak spot in the nidus like an intranidal aneurysm, either arterial or venous. The AVM resection rules are known to all of us. One has to study the MRI in multiplanar dimensions, carefully study the DSA to assess the arterial feeders. The approach should be adequate. It cannot be a mini craniotomy for AVM surgery. Arachnoid dissection obviously is very important to expose the arteries and securing the arterial feeders serially, sparing the en passant vessels. Circumferential dissection of AVM is a central tenet of brain AVM resection, and not just deepening the plane in one area. Securing the deep feeders come towards the end of the surgery, and these are sometimes very troublesome because after a long surgery, these are very thin-walled, fragile, and sometimes they rupture and may retract into the white matter and cause troublesome bleeding. Finally, securing the venous pedicle at the last. So I straight away come to some cases to illustrate these points. I like showing this case because the steps of AVM surgery can be shown very clearly in this case. This is a 17-year-old male who presented with seizure in 2016 with no focal deficits. A left posterior temporal AVM with fMRI showing language area posterior to the nidus. And this is fed by branches of the MCA and draining into the superior sagittal sinus. The maximum diameter is around 3 centimeters. So the annual risk of bleed in this patient is roughly around 2%, which can be cumulative over a long period because the patient is very young. The risk of epilepsy is 10 to 15%. We discussed, because this is an unruptured AVM, we discussed conservative medical management, stereotactic radiosurgery, microsurgery. The parents were very well educated, and they went through a lot of literature also. And then after discussing the pros and cons, they chose craniotomy, and we decided to do a craniotomy, language mapping, and excision of AVM. This is during
Now,
a craniotomy.
what does the king wear on his head? What do you see time with?
So I'll go to the language map, which was done. This is the frontal lobe, the temporal lobe, the AVM nidus, the draining vein. We, as I don't see the feeding artery and its branches, this arachnoid has to be dissected, and this is the language area posterior. You can see a sulcus separating the AVM nidus from the language area, which makes this very safe. I will fast forward this video in the interest of time. So the arachnoid is being dissected. This is the artery, feeding artery. You'll see numerous branches coming, which feed the AVM nidus, around 10 to 12, both from one surface and then underneath. So serially ligating them one by one. The idea is to spare this en passant vessel, which is going to the temporal lobe. I also use an isocool forceps, which is non-stick in doing this. These are the feeders from underneath the artery, which are going into the AVM. So they are all serially dissected and then ligated. This is the arachnoid being separated over the draining vein. And then we see some branches going over the draining vein to supply the AVM nidus. These are the arterial branches going over the draining vein to supply the AVM nidus. Once you have secured most of the feeders, then that artery is rotated out of place, some dissection of the sylvian fissure, and then we start seeing the AVM nidus buried in the brain. So one needs to go in this brain AVM plane to circumferentially dissect the AVM nidus. So you see more and more of the nidus coming into view. And this bleeding from the surface of the nidus, when you go too close to the nidus, in this case could be easily controlled with some cottonite pressure. And then you see the deep feeders. These deep feeders are very fragile, and in spite of low power setting, they can sometimes rupture, as I want to show. And then the end can retract. So what I do is usually try applying clips, silver clips on them, and then ligate, coagulate, and cut. So this is applying silver clips on the deep feeders. That was the M2 which was seen in the depth. And then as the nidus is progressively freed and rotated out of its bed, finally it rests on its venous pedicle. And now the AVM nidus has been rotated out, the venous pedicle secured. And the ICG angiogram, though you can't see the deeper part, at least in the superficial part, whatever is exposed, there is no nidus left. This is the post-op angiogram showing complete excision of the AVM. And the patient's reading, writing, immediate post-op was normal. And he passed his 12 standard exams and started doing his, pursuing his career further. So eloquent region AVMs can be safely resected with proper planning and execution. The next case I want to show is a 28-year-old female who presented with sudden onset of headache and progressive left hemiparesis due to this bleed from mesial temporal AVM. The bleed extended into the external capsule area. She started becoming drowsy and developing hemiparesis. This is the angiogram showing the mesial temporal AVM located more in the region of the amygdala. And the cause of the bleed was a feeding artery aneurysm. And the patient was taken up for targeted embolization of occlusion of the feeding artery AVM and the weak spot in the AVM nidus. However, during the onyx embolization, there was onyx reflux into the MCA, which resulted in cutoff. However, this was recognized very quickly, and appropriate action with balloon angioplasty reconstituted the MCA, and the patient did not suffer from any further consequences. This is a video which is quite long, about 5 minutes. So in view of lack of time, I will fast forward through it. The same principles as shown in the previous case was followed. And then finally, there was one feeding MCA aneurysm which was clipped. So this is the aneurysm which was clipped. And this is the post-op angiogram showing complete excision of the AVM. And she's an IT professional, got married and runs half marathons. So her life is back to normal from a stage of developing hemiparesis and drowsiness. So neurological deficits in AVMs can sometimes, which bleed, are potentially reversible, and preoperative embolization can make microsurgery safer. But one should be aware of the complications of embolization and be ready to tackle it if possible so as to minimize the complications. The next patient is that of a choroidal AVM 31-year-old male who came 6 years earlier but refused any further treatment, came with a bleed, severe headache, became drowsy, had this intraventricular hemorrhage. And this is the choroidal AVM in the temporal horn, which can be seen. And this is the CT angiogram and DSA. And the pre and post-op angiogram pictures, which shows complete excision of the AVM. Patient is doing well. The next case is that of a left basifrontal AVM. This is a Sri Lankan 42-year-old presented with headache and right hemiparesis, and imaging showed a left frontal hematoma. This is the AVM, and this was fed by lenticulostriate arteries. And there was a small feeding artery aneurysm in the lenticulostriate artery, which had caused the bleed. This is the feeding artery aneurysm. Again, targeted embolization of the feeding artery aneurysm was done. And this patient was operated under MEP monitoring. And these are some intraoperative pictures showing the AVM. And this is the post-op DSA, which shows satisfactory excision of the AVM. And at 1 year follow-up, the patient is doing well and no neurological deficit.
Can you just walk for us?
This is a 44-year-old female who presented with sudden onset of headache with left hemiparesis, which improved, a callosal bleed with IVH, a cingulate gyrus AVM, and this is the pre-op angiograms showing feeding artery, multiple feeding artery aneurysms with the high flow AVM draining into the superior sagittal sinus and into the straight sinus. And there was a lenticular, this is the post-op DSA, which shows complete excision of the AVM. But however, there was a second compartment which was not directly connected with the first compartment. This is a lenticulostriate artery feeding the component here, which could be reached from the surgical approach. And this patient was sent after some time for gamma knife treatment. These are the feeding artery aneurysms which are not clipped during the initial surgery, which shows some signs of regression. And this is the angiogram done during DSA for gamma knife. And the patient received gamma knife, 7 years follow-up, 4 years after GKS for the deep component. She's doing well. She was a good painter. Again, some were talking about in the DACA aneurysm presentation about patient not doing well cognitively. Similarly, this patient was good for all practical purposes, but she has not resumed the painting. And she refused post-GKS angiograms and any treatment for the flow aneurysms. So flow-related, this is a controversial statement. Flow-related unruptured aneurysms in high-flow AVMs can regress or lie dormant after AVM resection. And psychological problems can arise after successful AVM surgery, especially in the cingulate region or in the mesial temporal region. This is a 51-year-old lady who presented with seizures. Again, another example of a cingulate AVM. And with a lenticulostriate aneurysm, intranidal aneurysm, a huge venous varix and sac. So the total length of the AVM, including the venous sac, was more than 5 centimeters and had a PCA supply. And this was the exquisite diagram done by my interventional radiologist Sharath to plan the targeted embolization. And this is the targeted embolization to take care of the thrombosed aneurysm, to take care of the aneurysm. And this is the after the targeted embolization showing the preservation of the venous drainage. And the MRI showing no hemorrhage after the targeted embolization. This is the CT angiogram and the post-resection specimen of the AVM and the post-op angiograms. Initially, patient had leg weakness, which improved continuously, which improved fully during follow-up. She is a teacher, has resumed her occupation. This is a 61-year-old lady, some few cases before I end, showing high flow frontal AVM. She presented with seizures, targeted embolization, and post-op DSA showing complete excision. Another patient, mesial temporal AVM, who presented with IVH, initially refused surgery or treatment, presented with IVH, and then agreed for surgery. This post-embolization. Here, embolization made surgery difficult. This is one thing which I want to tell, because there was a diffuse AVM all around the embolized part, which made which gave rise to troublesome bleeding throughout the duration of surgery. And this embolized AVMs can sometimes be very hard or firm and difficult to mobilize and rotate. So that's the downside of preoperative embolization. And this is the post-op angiogram showing complete excision of the AVM. The last patient is that of a 23-year-old female MBA student who presented with right hemiparesis. This is a very longitudinally extensive AVM in the left parietal lobe with a bleed just behind the sensory motor strip. In the superior parietal lobule, she had hemianopia pre-op, and these are the MCA feeders. And this is the PCA feeders. Preoperative embolization again. But in the embolization, one cannot take care of the deep feeders. The superficial feeders, which can be easily tackled by surgery, are the usual ones knocked out by the interventionist and not the deep feeders. And during surgery, I had a very severe problem with the deep feeders, had an intraoperative bleeding hemorrhage, which required EVD placement and evacuation of the hematoma. However, the story ended well with this patient. This is the post-op angiograms showing excision of the AVM, and the patient recovered fully, completed her MBA, had campus interview, and I started working. So these are the locations. Totally, I have 22 AVMs, and 8 of them are eloquent since coming into private practice. These are the various locations, which included a CP angle AVM. I want to mention this patient came with tinnitus. After the excision of the CP angle AVM, his tinnitus disappeared, but then reappeared. His hearing is intact, and till now he has that disturbing tinnitus without an AVM. So these are the results. Transient deficits of hemiparesis, dysphasia, and altered sensorium resolved after AVM excision. And one patient had persistent hemiplegia, which was there pre-op. And one patient has persistent tinnitus after surgery. So careful case selection is the key. By microsurgery, we eliminate the risk of rebleed immediately, and preoperative embolization should be used carefully in making surgery safer. Thank you very much.
Thank you, sir. We now have the next talk on microsurgical excision of AVM by Professor Bartek Diera. As we are running late, I request all the speakers to stick to their allotted times.
Dr. Pandey for invitation. I'm going to share my experience with the AVM surgery. As we have seen, Dr. Ravi Mohan Rao has nicely shown a case and elaborated very well about the principle of microsurgery for AVM. So we all know about AVMs are very complex, challenging, and a very heterogeneous group of disorders where you can't see two similar AVMs, and नहीं आया ना? आया आया? So these are a very uncommon pathology, and one can see no two AVM nowadays are similar. So these are a most heterogeneous group of disorders, and we all know about the rupture rate of unruptured AVM, and when it is rupture, and there is a high rate of re-rupture. So that's the reason we need to treat these pathologies. And for young residents here, it is very essential to look for the CT scan. When you see the lobar hematoma in a young patient, it is unless proved otherwise, one has to consider about AVM in a differential diagnosis. Many a times unruptured AVM presents with the seizures, and one can see the calcification on a CT images, and sometimes hyperdense signals, and mostly diagnosed on the basis of MRI and MR angiography, but DSA remains the gold standard. We have our aim of the AVM treatment is that decrease the risk of bleeding and the complete obliteration of the lesion. So whosoever methods you use, the goal is to complete obliteration of the AVMs. We have options about the microsurgery, stereotactic radiosurgery, endovascular embolization. Many times combination of this modality or sometimes observation can be the best treatment in a given patient. AVMs graded on the basis of Spatzler-Martin classification that grades varies from grade 1 to grade 5, and it's generally recommended like the grade 1 and 2. It's recommended for a microsurgery. Grade 3 multimodality treatment includes the microsurgery, embolization, and stereotactic radiosurgery. While observation, unless it ruptures or a progressive neurological deficit, one has to consider for intervention. So microsurgery is having a very high rate of complete obliteration, more than 90% in most of the series, with a long-term durability. So principle of micro surgery already Dr. Ravi Mohan Rao has mentioned, but I want to mention about some of the equipments you need to have when you plan for a microsurgery, along with some adjuncts in the form of functional MRI or tectography. Many times stereotactic assisted craniotomy help, and we often use the procedural ultrasound as well as the intraoperative ICG study along with the 3D reconstruction of the AVM models. Here, I want to mention about the craniotomy has to be generous. You have to identify not only the nidus as well as the feeding arteries, but the draining vein. And many times it help in the decompressing the brain as well as opening the basal cisterns. And while opening the dura, one has to be very careful. If you are not careful during the dural opening, you can have a disaster before you start the AVM surgery. And pre-operating reading of the image is very important. You can see here almost this venous pouch is almost abutting to the bone. So if you are not careful about this during the craniotomy, you can have a disaster. Also, dural opening, one can leave some part of the dura attached with the AVM nidus rather than completely separating the dura from the nidus. You have to identify the major feeders. So once you identify the proper feeders, if there are limited feeders and you identify the feeder and put a appropriate temporary clips, and immediately you will see bluish discoloration of the AVM, bluish discoloration of the vein, and then your AVM surgery will be very easy. So finally, the dissection of the nidus, obliteration of the draining vein, and the excision of the nidus. Here I'm going to show two cases. Like my first case was a 21-year male. He was actually referred from a periphery. Initially, he was having a severe headache. Then he underwent an MRI image that showed a very large hematoma, but he was very conscious, and he was advised for a tertiary center's reference, but he refused. When he came to us, that time he was having a clot in the right parietal region along with a significant brain edema. And we did a right ICA injection, a DSA, that right ICA injection show this temporal AVM. So here it is again like so much coincidence, what Dr. Ravi Mohan Rao shown this almost more or less same AVM. But again, like in this AVM, I want to highlight that AVM is mainly fed by the
having a two pattern of arterial supply. One, that artery directly ends inside the AVM, and many a times the artery send multiple feeders or tweaks that supplies to the AVM, and the distal branch of the artery supplied to the normal brain. So if you are not careful during the dissection or either endovascular embolization, you can create a new neurological deficit to the patient. So here is a surgical video. I have recorded this video in a fast forward mode, but I want to want to mention about the dural opening. There are many times arachnoid strand attached to the dura, and if you are not careful about, you can damage the AVM nidus, and ultimately you can start having a bleeding. But mainly it's the arachnoid dissection. You have to have a clear-cut arachnoid dissection around the major arterial supply. Here again, this is the AVM having an end passage artery. So there are multiple feeders that were supplying to the AVM nidus. So all the feeders one has to identify and ligate properly. Many a times these vessels are so fragile. If you do coagulation and cut, and immediately will start bleeding, and because these are the major feeder coming from the end passage artery, so you have to be very careful. Arachnoid dissection also in the pi arachnoid plane in the surrounding brain parenchyma surrounding the AVM. So once you ligate, then coagulate, and then cut all the feeders, because this is the end passage vessel, you have to separate this perforator supplying the AVMs, and again you cannot have a dissection if you are not turn the vessel. So all the feeders were subsequently ligated, and then you can see there were multiple feeders. So if you are not careful enough, then while turning the vessel, the feeders can suddenly avulge. So this was a case of a rupture AVM. So once you take care of the most of the feeders, then you start dissection in the it is always a circumferential dissection in a case of the AVM. So this was a hematoma in here, and one can see this is the dissection around the AVM. One has to be careful about this deep feeders. If you are outside the deep feeder, then you are safe. You are inside the feeder throughout the AVM, then it will bleed like so. Here you can see in the dissection in the higher magnification, this all feeder has to be included in the AVM dissection and has to be coagulated precisely. If you are not careful about, it will bleed, and it will bleed torrentially even though you have finished your exercise the AVM. But sometimes this bleed can be notorious for you once you identify. Again, like many times there is a small feeders very close to the draining vein, so you have to identify before ligating the draining vein. So here there was one more feeder very close to the draining vein, and that was taken care, and after that AVM this draining vein was coagulated and cut, and then finally this was just a removal of the AVM nidus from the surrounding brain parenchyma. So this was the post-operative CT scan, and post-operative DSA reveal complete obliteration of the AVM. So one can see here. So here you can see the post-operative image. Initially, there was because of the underlying clot, the vessel was elevated, and then once it was AVM was excised, clot was removed. Then you can see this distal artery nicely filling the patient without neurological deficit. The second case was 28-year male. He presented with actually altered sensorium. He had a positive of movement on the left side, and MRI brain showed multiple flow voids in the right parieto-occipital region, and this is the digital subtraction angiography show the feeding mainly from the parieto-occipital and the calcarine branch of the posterior cerebral artery, mainly on the right side. And there was also feeding from the middle cerebral artery. We always do rotational angiogram for a better understanding the angio architecture of the AVMs. And believe me, if you have to have enough time, you have to spend enough time for understanding this various arteries, veins, and the feeders that supplies to the AVM. So this I usually operate patient in a most like to operate patient in an anatomical position. So here I operated this patient in a semi-sitting position. So this is all about you have to have a repeatedly look at the angios and identify the feeders, how many feeders from where they will be coming. Here you can see in the AP and the lateral view. Here the feeders the feeders are coming just feeders will be just below the craniotomy. You can evaluate that in that way. Second thing is the MCA injection. You can see the feeders are coming from more inferior and laterally. And also you have to look for because when you see the arterial phase, you only see the arteries in that phase. But when you have to also evaluate the venous phase, because when you see the image, intraoperative image, you will have a both artery and the vein. So you should be able to differentiate this artery and the vein. And so this was when we opened the dura, we found this sort of a picture. So in that you have to correlate where are the PCA feeder, where are the MCA feeders, and where is the draining vein. So this is the operative video. This is a very small video. You can see again, like intraoperative ICG is a very important. So again, as I mentioned, like in this ICG, you can see this is the arterial feeder. So these arterial feeders, you have to correlate where are these arterial feeders. And again, these arterial feeders were from the PCA branches. Here are the feeders from the MCA branches. So I took first from the feeders from the middle cerebral artery branches on the lateral side. My aim was to turn the AVM towards the fox. So my dissection started from laterally, taking care of the middle branches from the middle cerebral artery, then progressively ascending towards the feeders from the PCA branches. And again, like the deep dissection has to be very careful, and if you are not careful during this deep dissection, you can have a significant bleeding from the perforators deep down. I will just keep the video. So here I'm just taking care of this feeders from the vertebra, the PCA branches. And again, intraoperatively, we check again, like there is a significant reduction of the flow because there was one more feeder coming from the medially. And finally, we were able to identify and can see the fox, and that's now the only draining vein that were attached to the AVM nidus. So always like enough coagulation cut with we often use the Liga clips. So this was the post-operative specimen, and this is the post-operative angiogram showing a complete obliteration of the AVM. This is the vertebral injection. This is the lateral view, vertebral injection. This is the right ICA injection, AP view. Again, ICA injection, lateral view. So this is the post-operative neurological condition of the patient. Sometimes Broca's area AVMs are challenging. This patient, young patient, presented with a speech arrest, repeated speech arrest. He was having a Spetzler-Martin grade 3 AVM, and that was successfully excised using a microsurgical principle. Down. So again, like a precise dissection of the AVM nidus under higher magnification. And this is the post-operative angiogram, and this is the...
Hello, my name is Prakaran Naidis. I have been done my brain operation in January 2014.
So post-operatively, he was having a complete speech, and he has finished his engineering study. This is my last case, 53-year female, presented with a large clot, huge AVM in the left frontoparietal region. That was like, again, a large craniotomy, excision of the AVM. And this is the post-operative angiogram showing a complete obliteration of the AVM. This case was done without, actually all the cases were done without embolization. And this is a post-operative patient. So over almost like 112 patients were of AVM were evaluated out of 145 that I operated. Most of the patients were Spetzler grade Martin grade 1, 2, and 3, and have a complete excision rate of around 96% with a mortality of around 2.6%. So in conclusion, surgery on AVM requires extensive knowledge and the planning. Detailed anatomical study of the angio architecture is a very imperative. microsurgical principles should be strictly followed, along with the judicious use of adjuncts and as and when required. And the execution of AVM excision can be best achieved by a precise patient dissection. Thank you.
Thank you, sir. Now I'd like to invite Professor Atul Goyal to deliver a talk on strategy and philosophy behind microsurgical excision of AVM.
So AVM surgery is the last chapter of neurosurgery. AVM surgery is difficult. AVM surgery is dangerous. AVM surgery is anatomical. AVM surgery is philosophical. The most important issue in AVM surgery is, yes, I can do it. Yes, I can do it safely. Yes, I can do it completely and beautifully. I'm not saying we are always successful in what we think, but yes, we have to be very clear in what we do. And we have to know, after studying the angiogram, after studying the AVM, what are the good points? What are the bad issues? Whether removable or not, whether too dangerous. Many of these patients come with the only symptom of headache. Now tell me, but headache is a symptom, and headache can be a big symptom. If the person comes with headache, you cannot say, I just go and enjoy your headache. But on the other hand, if for headache you create an hemiplegia, that is not acceptable, or unconscious or death. So you have to study the AVM. You have to study the intricacies of AVM, nidus. Most important issue in AVM surgery is your personal experience, your personal, not pseudo confidence or overconfidence, because if you take an AVM and you're not able to do it during surgery, you will create a disaster, not for the patient, but for yourself. It will bleed, and everybody around you, who are your fans, who are your students, will make a mockery of you. And the patient, of course, will have a tremendous issue. So in my estimation, my experience is about 500 cases or 550 cases. I like AVM surgery. I enjoy AVM surgery. Sometimes I get fascinated by AVM surgery, and sometimes I take wrong decisions. But AVM surgery is, believe me, a game of hemostasis, a game of perfect hemostasis, a game that you have to win. You cannot do partial resection. You have to do complete resection. My treatment for AVM is, my strategy is only two. One is just leave it. Don't touch it. Second is surgery. Partial AVM embolization, partial radiation treatment. I don't like, I don't do. So bleeding and hemostasis, these are the games that neurosurgeons play all their life. And in AVM surgery, it has to be executed to perfection. It has to be executed to the topmost level. It will bleed, small AVMs are okay, but dangerous, difficult AVMs high flow AVMs will bleed from here, sometimes from multiple places. How to control your situation at that time, how to control multiple bleeding points at the same time is an issue. If you are not able to do, and you just do some kind of a mockery, you will create a mockery for your own self. Everybody in the theater will laugh at you. I'm not saying it is difficult. It is dangerous. So AVM surgery, the site is important. Number of vascular territories that feed the AVM is very important. Degree of flow in the AVM is the most critical. You have to understand how heavy is the flow in the AVM. And if you understand this degree of flow, you have understood the AVM. Flow-related aneurysms indicate high flow. Intranidal aneurysms indicate high flow. Multiple feeding vessels indicate high flow. Presence with severe headache indicates high flow. Large AVM indicates high flow. So there are many indicators of high flow which you have to understand. So AVMs can be in a relatively simpler zone, and this is simple means there is AVM surgery is not simple in any case, but this is relatively good zone for AVM surgery. Presence of aneurysm and feeding vessel aneurysm, intranidal, is a high flow. And when it is high flow, it becomes more difficult. That is the defining thing in AVM surgery. Large feeding vessels, dangerous in the absolutely motor area and the speech area. Patient comes with multiple convulsions and speech arrest, as we have seen. Whether you would like to do multiple nidus within the same area, diffuse kind of nidus. So I grade AVM surgeries for me, for my surgical decision. One is I leave a large number of AVMs, no operation. But when I try to define surgical issues, I grade them with my own, I don't depend on any other classification. When I see location, this, that, everything, I divide easy. Of course, easy is not a good word. Safe, difficult but safe, very difficult and risky but possible, and not safe or not possible. So this is my classification. Now, this is a deep-seated AVM in the deep brain. Now, it is very critical to know whether it is intraventricular or outside the ventricle. So now we have beautiful DTI investigations where now if it is intraventricular, relatively straightforward. Outside the ventricle is dangerous. We used in models for the first time in the history of neurosurgery, we made models first by relatively simpler material, then with some other kinds of material, and we reported this for the first time models. And I think models are very beautiful to be made and to be understood and to be for the operation. So this is the AVM. You see, this is the model. It gives you where is the AVM, how to handle where. Now we are trying to make color-coded models, and they will be, you see, you can hold the model in the hand. During surgery, you can mark your incision. Of course, AVM surgery is not about just modeling. It is various kinds of perfection things that you have to do. This is another AVM model. You can extracranial vessels. You see how you can see and beautiful. Now, this patient has come with headache. This is a young, beautiful girl. This is quite an AVM. I'm not saying it is heavily dangerous AVM, but it is quite large. And only symptom is headache. And means when it is large, more than 4 centimeter, it is a difficult AVM. And this is the post-operative smile of the patient and of the doctor and the post-operative angiogram. You see, it is very important to know for yourself before operation, you cannot create hemiplegia in this patient. You cannot create death in this patient. If the patient is giving consent, that means nothing. If the relatives are saying, operate, doctor, operate, don't worry, that means nothing. What means is whether it is possible to do it properly or not. This is another huge AVM. This boy came to me with only symptom of headache, a farmer by profession. I said, go and do your farming, little bit bamboo on your head, you can keep on pumping. But this fellow came to me after some time and the entire family said, doctor, operate, operate, operate. We give consent. We don't worry this and that. But as I've told you, that doesn't matter. But I gave him a beautiful new life. And this farmer has produced 4 children now and all our farmings are good for the country. But on the other hand, you see, this can be a dangerous situation. This is another ball of fire. Now, ball of fire patient comes with like he's not paying attention in the school, little bit irritable, continuous headache. You cannot say, I will operate pseudo confident. Yeah, I can operate. That nonsense will not work here because your trouser will be firm or tight that you will know during operation. And you cannot come out half-hearted. You have to remove it completely and you have to remove it beautifully. And you cannot say, I've done partial resection. Tumors, okay. Meningiomas, okay. Acoustic, okay. But here you have to do everything. And I have got some beautiful knack of AVM surgery. And my feeling is that knack nobody in the world has. This is my feeling. Others may have the other feeling. But that how to control feeding vessel, how to get the mother feeder. This is not an ordinary art. You just go coagulating, you'll never be able to get that feeder. But if you are able to do, you see, this is an AVM and this is the beautiful post-operative and this is the wonderful smile on the patient. And doctor started, I didn't show the doctor jumping, but he was jumping on the other side. This is another AVM which I did long time ago. These are my trophies which I'm showing you over several years. And these trophies make me proud, but there is a big story behind those trophies. This is in the vein of Gallon region around the brainstem. This I had done some 25 years ago. This patient came with the bleed, I don't know what was the condition, but this was a formidable AVM, formidable location. But you see this PCA feeder, you come into hemispheric, get over the tentorium PCA vessel. That is the most fantastic thing in AVM. Unless you know that art, Unless you know the art of getting interhemispheric, getting the ACA feeder, PCA feeder, you cannot do AVM surgery because most of these are fed here. So PCA is my friend and I get the PCA, then ACA and this AVM beautifully resected. This is another, you see, I'm showing you rather simple AVM, but this was not simple. It is fed by multiple feeders. This is PCA, this is ACA, MCA, MCA opposite side, very high flow AVM, and this had created some trouble for me. This is another AVM, came with a bleed, came in a reasonable condition, but this is the AVM. You cannot say, yeah, I operate. What you will operate? You have to know the intricacies of you have to understand the architecture of AVM. You have to understand the beauty of AVM. You have to plan. You have to execute that plan. I cannot, I want to show this AVM. This I cannot show you. This arrow does not, this bar does not come here. See, AVM, I cannot say I will show AVM surgery and show you. I have to show you bleeding. I have to show you where everything was shaken up in the operation theater. You tend to, when bleeding occurs, there are two things that can happen. One is you start shouting and howling. Second thing is you blame the nurses, you blame the assistant, you blame the anesthetist. Those nonsense will not work here. Okay, now it is coming. First and foremost is wide, big exposure, huge exposure. You have to, as we have heard, like you have to embrace the AVM and AVM from all the sides. This is from anterior communicating artery territory, get the feeders, get into various zones of the AVM and then handle the bleeding. One mistake you make, one normal vessel you take, you have killed the person. You take one normal perforator, gone. So identifying normal from abnormal, continuing to dissect, you cannot get stuck at one point and say, yes, it will go 20 hours and 30 hours. You have to progress. You have to go on. And ultimately you have to come out successful. You cannot come half-hearted in these cases. These are dangerous cases. These are life-threatening conditions. You can create a disaster for the patient. Imagine patient comes with headache and you have created hemiplegia. Imagine many patients come with convulsions. You have killed him. Imagine a patient comes with giddiness. Many patients come with giddiness, and large Sylvian Fisher AVMs is a different cup of tea. You have to identify from the Sylvian vessels which is normal, which is not normal. If you take one normal vessel, you have killed the person. That makes you not very strong. It makes you weak, but you have to go on dissecting and beautifully dissecting and ultimately resecting. And ultimately you must remember, if you have done a beautiful job, if you have done a complete resection, the patient post-operatively be so wonderful that we operate on tumors, we operate on things, and that kind of post-operative results you will not get. This is another huge AVM, but many good points in this. If you sit down with the AVM, understand from where the feeders are coming, spend time, hours and hours on understanding the AVM, and then take the decision. You cannot just take an emotional decision. Most important thing is don't take a hyper, confident, egoistic decisions will be the disaster for the patient. Embolization, I worked in very heavy, high flow interventional department. Embolization was done in some patients, but I do not do preoperative embolization if any patient comes. And when it is embolized, my feeling is it makes the operation difficult. But if it comes, and then you have to remove it, and then you have to remove it fantastically and beautifully. And this is post-operative. This is one AVM. You see, some of these AVMs I have done over last 30 years. Problem is, if it comes to me now, today, I will be probably hesitant to do this AVM. This is in quite a dangerous area and quite a high flow. You see the jugular. Flow AVM, which I remember in my memories, all these dangerous situations which I have faced. And this is another AVM sent to me by Health Minister of India. And this is health minister, I did this for motor strip AVM, and they said, Dr. Goel, only you can do, only you're the best. And that made me hyper, and I said, yeah, come. And this motor strip AVM I did, and post-operatively he developed hemiplegia. He recovered in the hemiplegia to some extent, but I still regret whether that health minister made me do this, whether I would be able to do it now, whether I should have not done this. But I have done several motor strip AVMs like this one with bleed. Earlier, I used to wait for sometimes AVM bleeding and hemiplegia will recover, but now I don't wait. This is another motor strip AVM which is removed and dissected beautifully. Another one which is beautifully removed. This is another one beautifully removed, but some hand weakness you can see here. This is another I did in recently, which was quite a high profile person in the motor area, in the speech area. I did it quite, there was no problem. This one I did for the first time in the literature, contralateral, which I described in 1996 or 1997, contralateral approach. And this approach I have published in 1997 and further referred here. And I did this, if you see, this patient also had some weakness in the hand. This is another quite an AVM in the velum interpositum vein of Galen area. I am still wondering if it comes to me today, whether I will do it or not. Maybe I may, or maybe I not, but I did it at that time and I did it beautifully. This is another huge AVM. I do not know what kind of AVM you can call this, but I did it. Here I had speech disturbance. This fellow was a Russian dealer. He used to make mistake in the Russian calculation, but the son said, don't worry, doctor, he's always making some profit for the family. When he calculates on this side, not on the other side. I said, oh, enjoy the profit. This is another, you see, quite a dangerous speech area, quite an area, convulsion only issue. You see, you cannot say you operate and you stop the convulsions. You cannot say you will operate and you will stop the headache. You cannot say you will operate and you will stop the giddiness. But, this is a cure and they live happily ever after. But the problem is they should live. And they should live with all their legs and hands intact. You cannot create a disaster in this situation. This patient I created several years, 30 years ago, I did this operation. And I removed this patient, developed hemiplegia after operation, but he recovered quite nicely and he still comes with his entire family. At least 10 people come when he comes to me and he brings some beautiful thing from my hometown of my wife. And I enjoy those pickles and all those things. This is another AVM. Like this patient came a clot. Somebody did this craniectomy. I never will do craniectomy. I will always say nonsense. Don't do this nonsense. Come and remove the AVM. And I removed it and I replaced the bone flap. I never do decompressive cranial. This patient came with the bleed. It was difficult situation, but you see, young as I was and young as I am, I said, okay, this patient is unconscious. Let me attack it. And I indeed attacked and removed it, but this patient never survived. This posterior fossa AVM is a different cup of tea, relatively straightforward. This is not posterior fossa. This is basal occipital. This is posterior fossa with multiple aneurysm. What to do with these aneurysms? Whether you have to come first here, come first. You remove the AVM, these aneurysms will disappear on their own. This is another AVM, very dangerous retrograde flow in the venous circulation. I cannot go much here. This is another AVM, a very high profile film actor coming with trigeminal neuralgia. I removed this. The actor is very happy and he sends me some tickets for his film sometimes. This is another intraventricular AVM I did with suboccipitals from the orbital cortex. I reported that approach. Beautiful case, intraventricular AVMs, relatively straightforward. Temporal AVM, you see large choroidal artery feeder. This is postoperative. This is velum interpositum AVM, difficult AVM, but difficult means difficult, but you have to know, yes, possible, no possible. Intraventricular AVMs and these kind of things, can be done and can be done quite effectively. This is not an AVM, this is pial AV fistula. I was not knowing at that time this is pial AV fistula, but when I saw a large artery and draining vein, I said, let me remove it. But this is indeed a pial AV fistula. Subsequently, we had many patients like this, and this patient may not even need operation. You need to just coagulate here and clip this, and that is the end of the story. But at that time, I had removed it completely. This is not necessary. So several pial AV fistulas are there. Surgery is different. This is, I had reported this pial arteriovenous malformation. Diffuse AVM, take a decision. You cannot do it. Say no to the patient. Let him enjoy whatever. Let him enjoy the headache. Let him enjoy the convulsions or giddiness. You also enjoy whilst he's enjoying. Don't enter into controversial issues. Thalamic AVMs, better be away from that. In this kind of nidus, I will say no. Brainstem, anything bleeding in the brainstem or around the brainstem here, I'm not sure today I would have removed this, but at that time I have said no to this patient. Embolization has only questionable role. I don't think it helps in surgery. I don't think it makes the difficult AVM easy. Partial embolization has hardly any role and has potential complication. This AVM was embolized by one of the leaders of embolization in the world, not in India. And after surgery, he created hemiplegia. And then I was called late in the night and I did this beautiful resection. Hemiplegia has reduced, but can be present. So thank you very much, my dear friends. Enjoy AVMs. Understand AVMs. Understand your own self. Understand that your hyper confidence and ego will not work. Your realistic understanding of your personal skills of hemostasis, your personal micro dissection skills, your needs of your patient. Patient is God. Remember, you create hemiplegia in your God, you will not ever be happy. But in our profession, we create complication. You cannot say if there is can be, you do any tumor, that can be complication. You cannot say I will stop doing tumors. You cannot say I will stop doing acoustic because there is a facial nerve palsy. Understand the patient. AVM is indeed the last chapter of neurosurgery. Thank you very much.
Thank you, sir. We'll move on to the next session on bypass surgery. I'd like to invite Professor Ashish Suri to deliver a talk on low-flow bypass surgery.
Yeah, good afternoon. I'll be talking about the low flow. This is the bypass session. I'm talking about the low flow bypass techniques and technique of microvascular anastomosis. The hallmark, the most important is the STMCA bypass of the Moyamoya disease. Moyamoya, as we all know, is a chronic progressive occlusive disease. Bilateral ICA and proximal ACAs and MCAs get diseased. The gold standard treatment is the direct revascularization STMCA bypass. Along with that, indirect methods like encephaloduro, arteriomyo, or encephalomyo can be supplemented or can be in isolation. These are the steps. Mark the superficial temporal artery, palpate it on your above your zygoma, and this is the parietal branch. Dissect the parietal branch, dissect the frontal branch, then make a type of a temporal craniotomy, and then open a durotomy. I take the lower leaf of the stitch with the middle meningeal artery and stitch it to the muscle. There's some people who actually take a strip of the middle meningeal artery, but I feel that there's already endothelium there. It won't have any revascularization there. And then open the Sylvian fissure wide. And then I do a double barrel if it is possible. And a double barrel means infrasylvian branch is anastomose to the frontal and the back wall first, and then the front wall. And the main idea is that the ostomy, the size of the ostomy should be at least 3 times the diameter of the recipient. That is important. And then the parietal branch goes to the suprasylvian. So there is an infrasylvian and a suprasylvian coverage, and we check in on the Doppler and on the ICG. And then we put the muscle over the opened arachnoids to create an EMS. The muscle is already stitched with the. So this is a 10-year girl with multiple infarcts and grade 6, grade 5 Suzuki myeloma disease. So the steps, dissect the superficial temporal artery, take a good amount of adventitia and some connective tissue along so that you don't make into a spasm. And then always a papaverine soaked elevation. That's the frontal branch. We elevate parallel to the zygoma. And that is the frontal branch. And once the frontal branch is intact, and then we open the dura and we stitch the lower leaf of the dura with the middle branchial artery to the dural, to the lower part of the muscle. That helps there won't be any blood oozing into the field later. Then do a wide durotomy because you're stitching the dura to the muscles. Open the Silvan fissure wide, and then M3, M4, like I told, so simple glove piece. I use a lot of papaverine irrigation. These vessels are usually 0.8 to 1 millimeter in diameter. And the recipients, and that is a donor from the STA, double barrel. It's important to bear the last 1 millimeter, 10 millimeters. Make a fish mouth of that. Keep the sutures ready. Put temporary clips. Do an ostomy at least 3 times the size of your recipient diameter. That is very important. That is where me and Tanikawa and my teacher, Dr. Suzuki, we are slightly different from Dr. Bing because he feels that the ostomy should be the same diameter. Then a heel toe stitch. Two interrupted stitches. Oops, sorry. What did I do? Heel toe, then at least 6 or 7 sutures we put interrupted across the lumen on the back wall first and then the front wall. I'll just scroll it a bit. So here we're putting around about 6 sutures. The total bypass time, which is not so important. My clock is around about 14 to 16 minutes. Used to be 18 to 20, now it's around 14 to 16. And then the front wall, another 560 sutures. These are diseased vessels. Anything M2, M1 is already diseased, better to have interrupted. Continuous makes you can have stenosis later. We switch the aspirin off only 48 hours before, and we start the aspirin the next day. And patients are, oops, I think there's something wrong. Then we have the other suprasylvian branch. Sorry. In a heel toe and by 5 to 6 to 7 stitches interrupted. Back in the front walls. Only two forceps, fine forceps. No needle holders, only fine forceps. Then we do the ICG and the Doppler. We start measuring with Doppler as well now. And this is the postoperative angiogram, a single barrel. This is of the collateral circulation. You can even see that perfusion is started. And this is double barrel, the infrasylvian with the frontal branch, suprasylvian with the parietal branch. and the subsidence of the mesomoema collaterals. Well, this was the main workhorse for the low flow. We use this for the complex MC aneurysms. I have a difference of opinion as from the last session. I feel that giant ones of this caliber, we must have an STA ready. It is something known as the insurance bypass. We may not use it, but we must have it. Keep it ready. Then this had two aneurysms, so we went for the ACOM first. This was posteriorly directed. This hadn't bled. But, so I dissect all the four 2A2s and 2A1s. Water bath coagulation. Best clip is a single clip. And then we open the cylinder fissure widely. That is the aneurysm. And why I'm preparing for the bypass, I'll just show you. We see that one of the M2s coming out from the aneurysm is, there's a long segment of aneurysm between the house planes. So we have to sacrifice that. So we decided to do a double barrel STMCA. So this was on the temporal or the inferior division. And that was on the frontal of the, sorry, that was the inferior, that's the superior division. We check on the Doppler as well as the ICG, and then we go for the aneurysm. And that is what we found, that this branch from the MCA was, we had to knock it off because there was no, we could not reconstruct it with any clip. So we dissect this branch. Now we have a bypass. Put a temporary clip there, open the aneurysm, and this branch we could deconstruct. So any calcified aneurysm was always better to open it, take out the thrombus. Water bath coagulation is my favorite. And then try for the best clip to reconstruct the lower, that is the superior division, superior branch of MCA. We had to use a straight and a fenestrated for the calcium there. And this branch goes because already fed by the, so the STA has insurance here and on the lower one, and it has salvage on the upper side, flow alteration. ICG flow well. There's another giant aneurysm. We could only have one branch here. And it was also short. The problem with low flow bypass is if you don't have a posterior wall, it becomes a bit difficult. So we did a bit of cheating there. We did the anterior wall first, and then we put a Liga clip over the adventitia to our temporary clip and did the back wall. Bit of cheating. And then we had a salvage bypass, insurance bypass, which was functioning. And then we attacked the aneurysm, took out the thrombus, did an atherectomy. Here, my temporary clipping time was nearly 30 minutes. But I was safe because had I could have sacrificed one of the MCA branches, but yes, I could do an atherectomy, completely occlude this aneurysm with, I think, one or two clips. Finally, I think 2 clips, 2 or 3. Yeah, 3 clips because that is a thick wall. And so well functioning, and this bypass would have blocked in due time. I skipped this video. Well, for the occipital pica, this was a case in which there was a broad neck aneurysm, and we thought that will be difficult. Our endovascular people said we couldn't do it, so it came on to us. Did a far lateral approach. First, we harvested the occipital artery. Did a far lateral approach. And you see this loop of pica, and we did an occipital artery to pica anastomosis. Here we always do a continuous anastomosis. Diameter is good. The heel toe and then continuous stitches, back wall first, and then the front wall. Now we don't. Our main plan was that we'll trap this aneurysm. So we thought that we'll just play around and see before we trap, because the bypass is in place. And when we punctured the aneurysm, we put the temporary clips. And we saw that there's a perforator there. You see the perforator there, right from the neck. So we could not have sacrificed this segment. There's an important perforator going to the brainstem. We thought that now we have to. So with prolonged clipping time, we actually reconstructed and put a clip, preserve the perforator. So again, this would have been a salvage or a float alteration bypass, became an insurance bypass later. Yeah, this is two interesting cases which I showed yesterday. I'll show the video today properly. This was a PCOM P2 junction by aneurysm. And this was, we used the parietal and the frontal branches of the STA. Harvested them, did a temporal craniotomy with a zygomatic osteotomy, an extended temporal approach. Here I would like to show the steps of the anastomosis. So it's a heel toe, continuous. Here you need long instruments. It's not the. I have Dr. Tanikawa's long by forceps, which I use. So no needle holders, only the forceps. One is angled needle holder, that's what they call it. You see the document. And once we check the flow on Doppler and ICG, we trap this aneurysm. And that was another case. Intraoperative tools, small forceps, long forceps, ICG and Doppler. Microvascular anastomosis training requires a laboratory and simulation training. I love training. So this has been closest to my heart. We have a lab at Thames, and microsuturing training is performed. We have come down to the conclusion that 2-hour sessions are not worth it. You need a 2-week or a 4-week continuous training with continuous iterations. We've trained more than nearly 2,800 neurosurgeons, ENT surgeons, general surgeons, EI surgeons in all these vascular and from all over the country and abroad as well. And now it is good that because the IIT people have come out along with us, they've developed some good softwares. I don't have to be there. The computer tells them how good or bad or ugly they are. So this, they got some big award on that, so, the Galian Award. And this is the AI-based CNN software tells them that this is your score out of 10. You're still 4 out of 10. You're to become better. That is good. So I think, and we've been impaneled as the National Board of Examination Skills Training Lab for the MCH and DNB Neurosurgery. I request the World Dandy India chapter to make use of it. Thank you, sir. Thank you very much.
Thank you, sir. Next in line, we have Professor Dwarakanath Srinivas connected with us to deliver a talk on high-flow bypass surgery. Are we audible, sir?
Can you see my screen, madam?
Yes, sir, we can see your screen.
Again, I apologize for not being in person because of, again, leave denial during vacations. So I'll be speaking on high flow bypass and aneurysm surgery, and Dr. Suri sir has already taken a lot of it by doing the low flow bypasses. So I'll just skip this quickly and just go back to see when bypasses are necessary. So before we decide on a bypass, so we basically have to see whether it's actually necessary. Can the patient withstand occlusion? What is the type of bypass we need? And what are the donor vessel and recipient vessel? So this needs a lot of pre-planning before you actually do the surgery. And these are generally done for a variety of complex aneurysms, which could be either due to its size, location, or the anatomy itself, or those which have failed endovascular treatment. So the first thing, of course, all of us do is to see whether it can be clipped. So multiple varieties of clipping. So for example, even though this appears scary, it can be clipped easily with 2 or 3 clips. Again, clip reconstruction of complex MC aneurysms, so, or flow diverters, of course, which have come into vogue over the last few years. So when we plan for bypass, I generally do a CT, MR, and a DSA with a 3D recon. Look for good collaterals, especially from the PCOM, which is often missed. Do the balloon occlusion test and look for either whether there is a acute or delayed deterioration, then give a high hypotensive challenge. So the principle which I use is if you fail the BTO immediately with balloon inflation, I do a high flow bypass. But if it fails only with the additional hypotensive challenge, then I go in for a low flow bypass, which should be an STA as the donor. Of course, if they aged people who pass the BTO, then we just do an ICA ligation and come out, which is very less morbid for many of these patients, even though it carries a 2 to 5% risk of infarcts. But for very old patients above 70, we generally go in for this if they. So the type of bypasses, of course, have been described by Shekhar. I will not go into it again. Local bypass and EC-IC bypasses. And these are the various types of grafts, bypasses which have been described. And today I'll just stick to the high flow bypass, which is generally a saphenous vein or radial artery used as a donor to connect the cervical carotids to the intracranial M2. So what is the difference between the radial artery and the saphenous vein? The radial artery has a flow rate of around 130 ml per minute, while the saphenous vein has the highest flow. But the disadvantage of the radial artery is that, of course, the length might not be suitable. You need to do a Allen's test to see the patency. And because of the inherent quality of the artery, it can go into vasospasm, which can be again treated by using the pressure distension technique described by Shekhar et al. The saphenous vein, on the other hand, you have an unlimited supply of the vessel. You have a very long graft. But because of the valves, there is a potential for turbulence and thrombosis, and there is shorter patency rates compared to the radial artery. But of course, the long term are usually equal. The other thing which you have to remain careful about the saphenous vein is that the valves, since the valves are unidirectional, you should not reverse the graft, and size mismatch can also occur in, especially in pediatric patients. So this is a Lawton's classification of bypass. I'll just skip that and go through the neuroanesthesia. We use SSCP, MEP in all cases. We do burst suppression during the bypass itself and give intraoperative heparin. We use a recipient vessel opening of around 1.5 to 2 times recipient vessel diameter, orient the graft at around 45 degrees, and we have a dedicated set of instruments only for the bypass, which again cannot be overemphasized. The sutures for the high flow bypass, I generally use a 80 M2 for the M2 segment and a 60 for the ECA or the ICA at the neck. So low flow bypass, I'll just skip the low flow bypass. Just show you a few examples. This patient who has aneurysm of one of the MCAs, we could just do a low flow bypass. So what we did was we trapped this aneurysm and did a low flow bypass. So that vessel supply was coming from the ECA, while the parent vessel continued to supply the other trunk of the MCA. Again, low flow bypasses, these are some of the cases for which we have done a low flow bypass, a double barrel bypass for this aneurysm. And this is a rescue bypass. Like what Dr. Suri mentioned, it's always important to keep the STA ready in case you need to do a rescue bypass. So now coming to the high flow bypass, I generally use a subcutaneous tunnel. The graft is free of perivascular tissue for around 2 to 3 centimeters. Important not to skeletonize this for too long. Then you use the fish mouthing of the donor vessel. Generally, we use a carotid punch for the ECA. Anastomotic time generally varies around 30 to 45 minutes. And we always backbleed it before we complete the anastomosis. I give heparin for around 7 days post-operatively. And then after that, the patients are maintained on aspirin for a few months. So I'll just discuss this case and just show how I do the bypass. This was a patient with a WFNS grade 1 fissure grade 3 aneurysm. And this is what the angio showed. It showed a very MCA trunk, dysplastic MCA with a giant aneurysm of the MCA trunk. So you can see that both the MCA trunks are viable, but the MCA trunk itself is M1 segment is completely the aneurysm. This This has the ideal management for this would be a bypass. So we decided to go with the high flow bypass for this patient. You can see the dysplastic MCA with trunks with ending just proximal to the origin of the M2. So this is a surgical video showing, this is the Sylvian fissure opening. This is the MCA bifurcation being exposed. So it's important to expose it to the entire length so that we select the optimal vessel. You compare the size of the two divisions and generally take the one which has a size matching with the donor vessel. So for example, here you will see that both the vessels are almost the same size. So we selected the inferior trunk because we had a favorable anatomy. This is the graft preparation. I generally do the cranial anastomosis first because it gives more room for manipulation. You generally make the opening around 1.5 times of the diameter of the vessel. Then the principles of the graft remain the same, whether you're doing a low flow bypass or a high flow bypass. You do the heel stitch first. Also, the needle is very important. Here we are using an 80 atraumatic 3/8 needle. The longer the needle, the more difficult it's for you to do the aneurysm. So generally, we use a 3/8 needle here. So this is the 80 nylon. So this is the heel stitch. And this is the toe stitch. So the advantage of doing the anastomosis in the cranial end first is that you can move the graft on either side and mobilize it, so the visualization becomes easy. So the distal and the differences between the distal and the proximal side for the side anastomosis gets negated by the movement of the graft itself. Here, first, initially, I used to use multiple single sutures, but on the advice of Dr. Shekhar, I shifted over to the figure of 8 sutures. So this is the anastomosis which is complete and checking the patency of the graft. So once the cranial anastomosis is complete, we move to the neck. Here you can see the CCA, the ICA, and the ECA has been exposed. Generally, the anatomy of the neck varies. So you could use either the ICA or the ECA or the CCA itself. Preferably the ICA because you do not add, preferably the ECA because you do not add to the ischemic time of the brain. So having said that, we have done both on the ICA, the CCA as well as the ECA, depending on the anatomy and the relative ease of mobilizing the exposing the vessels. So again, the principle remains the same. You do the heel stitch first. This is followed by the toe stitch. So this is a 60 proline. Here again, I used to use the continuous sutures initially, but now again I have shifted over to the figure of 8 for the cervical anastomosis also. So here, because the anastomosis is already done cranially, we need to do the opposite side first because that's the more difficult side because of the visualization issues. So you need a good assistant to make sure that the sutures do not get stuck in the multiple temporary clips we have applied. So once the contralateral side anastomosis is done, we shift our attention to the ipsilateral side. And here again, the anastomosis is done. Here again, I've shifted over to the figure of 8 suturings. So now the anastomosis is almost complete. This is the final sutures being taken. You have to be very careful with the heel and toe stitch because usually the leak occurs there. Here the completion of the anastomosis has been done. So now we again come back to the cranial end and start dissecting the aneurysm. So as you have seen that, before dissecting the aneurysm, we just check the patency of the anastomosis with the proximal MCA clip, and as you can see that the this is the graft, and this is the MCA, the M2 segment onward, which is filled. So now we turn our attention to the aneurysm itself, and as you can see, this is the ICA and the ICA bifurcation. So this is the ICA bifurcating the ACA and the MCA. So we have blocked the flow of blood into the aneurysm by a proximal clip. And now we come to the distal end. We have already put it, since we have already put a temporary clip there, all we have to do is to just replace the temporary clip with a permanent clip. You have to be very careful about actually occluding the aneurysm, because otherwise what happens is if there is flow into the aneurysm can actually swell up and rupture. So now we have completed the anastomosis, and this is the post-op angio, which is showing the patent high flow bypass with good distal filling. You can see the anastomosis coming into the view here. And the flow distal to the trapped aneurysm. This is the so these are some of the cases which we have done. This is a giant ICA cavernous which has failed balloon occlusion test. So we did a high flow bypass. This is another complex ICA aneurysm. You can see the dysplastic vessels. Here again we did a high flow bypass here. Interesting case, almost done 6-7 years back, a bilateral cavernous calcified aneurysm with bilateral vision loss. He was PL negative in one and finger counting at in one eye. So we did a high flow bypass and trapped the aneurysm, and the patient continues to maintain vision almost after 5 to 6 years. So this is the patent bypass here. So this is an unruptured giant ICA with blindness. It's easy to put a flow diverter, but sometimes the aneurysm has a tendency to swell up and the vision can actually worsen. So here we did a high flow bypass and trapped the aneurysm. Again, another high flow bypass for a ICA aneurysm. These are very unusual aneurysms, the MCA serpentine, giant serpentine aneurysms, where the only surgery is, only treatment is high flow bypass. So this is what we did in this case, a high flow bypass with trapping. So some interesting cases, this is in the COVID era where we tried doing I mean, we were not prepared for a bypass, but we found that we could not clip the aneurysm at all. And so what we did was we cut one MCA trunk and re-implanted to the other MCA trunk. So it almost acted like an intermediate flow bypass for this patient. A bypass, of course, needs a lot of help. We call the cardiothoracic surgeon to harvest the graft. Some of the problems which we have had is kinking and the kinking of the vessel. Like I mentioned before, the great saphenous vein has a univalve valves which open only in one direction. So you have to be very careful not to reverse the valve. Complications include vasospasm in radial artery, which can be overcome by the pressure distension technique, and incomplete trapping, which may lead to aneurysm rupture. We have to be very careful for the prolonged ischemia time for bypass, especially when you're using an interposition graft. If you're using the ICA, the ischemia time is higher. So after doing the cranial end, for the cervical end, it's better to wait for some time and then start the cranial bypass. And also, since we use burst suppression, that is not much of an issue. The others include an EDH due to, of course, because we heparinize the patient, and sometimes reperfusion can occur. We haven't had any delayed blockages in infections, but these are known complications. So for example, this is a patient who underwent a bypass, but unfortunately developed a graft failure. There's another patient who developed a graft failure, and we had to do a decompressive cranectomy. Sometimes what happens is, this was a very interesting case. We did a high flow bypass, and immediately post-op CT angio, we found that the graft had thrombosed. So we again re-explored the patient immediately and rescued the bypass. We used a Fogarty's catheter to remove the thrombus. And this was the patient. After some time, we can see that the graft is functioning well. So these are some cases in which prompt attention can actually reverse the blockages. So, so this is the decision-making algorithm which I use. Do a BTO, then stratify depending upon the response to the BTO. And depending upon the response to the BTO, either treat it with a high flow bypass, a low flow bypass, or a clip occlusion, or a Hunterian ligation in the neck. So to end here, bypasses are an important art, though fading because of flow diverters. But there are many cases in which flow diverters, you are unable to place them. So it's very essential that neurosurgeons learn the art of bypasses. You need dedicated instruments, dedicated teams, and you need to do the detailed pre-planning necessary and be aware of the potential pitfalls. So it's always good to remain one step ahead of planned failures. So I'll end here and thank you, and again apologize for not being able to come in person.
Thank you, sir. We'll now have a panel discussion on bypass surgery and AVM, which will be moderated by Professor Matthew Abraham. I request the participants, Professor Dwarakanath Srinivas, Professor Ashish Suri, Professor Atul Goyal, and Professor Batuk Diora to take part in the discussion.
And philosophical talks. I think everybody got an idea about the real what a surgeon feels when he's doing these cases. Any questions to the speakers from the audience? Let me start from Ravi sir. Sir, you were talking about doing AVMs with the help of the with interventionist. Do you think the interventionist's hands has to be held? The surgeon has to be in the cath lab to restrict him from overdoing what he's doing.
Good point, Matthew. Fortunately, I have a interventional radiologist who is in complete sync with the neurosurgeons. And we sit together and have a preoperative plan as to what is the extent to which embolization needs to be done. You are very correct. Over-enthusiastic embolization can sometimes lead to draining vein blockage, hemorrhages, and that kind of a thing. The only problem I have noticed is they are not able to embolize the deeper feeders, the smaller feeders, the perforator feeders. And they embolize the easily surgically accessible feeders first. The greatest advantage I see it is elimination of intranoidal aneurysms and weak spots, which helps the neurosurgeon during the dissection. To me, that is the greatest help that they can do.
This question to Batuk. Suppose there are two set of feeders, two groups of feeders, maybe from the MCA and another from the PCA for a posteriorly located AVM like the one you showed. If you want an intervention, which feeders would you like to embolize and why?
I have not embolized a single this thing case.
Hypothetical.
But I when I'm planning for a AVM surgery, I see those feeders who are exactly opposite to my vision. Those feeder I may consider for embolization and should be considered for embolization. As Dr. Ravi's case, he has mentioned about the superficial feeders were mainly targeted. Actually, we require a deep feeders to be targeted,
first.
rather than the superficial
Deep means on the side of the PCA.
side of the PCA. Yeah.
PCA. And what embolic material do you think would be ideal? You having a feel of both sides.
So, if you are treating with a high flow fistula inside the AVM, then the glue is the best. If you are mainly targeting the AVM nidus, then the Onyx is the best.
Okay, suppose you're having somebody has attempted to embolize an AVM and not immediately sent for surgery, and there's a long gap. What problems do you expect?
So right now I am facing that problem and I am solving that problem. I shifted to KM. Almost all in the neurosurgical department, almost all the AVMs were being embolized. Maybe one session, 2 session, 3 session. Now I am operating on those patients. Sometimes it is easy when because it forms a mass and you can mobilize the mass and AVM this thing is deep. In case of the small AVMs, like small mass. But when there is a big masses and the mobilization, because they are not supple, it's hard mass. So when you want to have a control over the deeper feeders while you are dissecting deeper area, then it's a very troublesome. So you cannot retract. It's from a solid mind. Second thing, it sparks. When you try to coagulate, it sparks. And many a times when the endovascular planning for endovascular planning of AVM embolization is not proper. So many a times it happens like in between this embolized portion, you will have feeders, and that is extremely difficult to control.
Okay, I have one question to you. Suppose you're having a small D procedure. You want some form of a guidance to approach it operatively. Will you use a DSA guidance during surgery in the form of a hybrid, in a hybrid theater?
So
you have a hybrid situation.
In all AVMs, I plan my AVM excision on the basis of DSA only, and always a 3D rotational angiogram correlate the anatomy as well as the angio pictures, DSA pictures. On that basis, along with the anatomy and the angio basis, I plan my surgical excision.
Okay, thank you. To Atul Goel, sir, the general trend among neurologists, neurosurgeons, young as well as senior, is as soon as they see an AVM, get away from it, send it for embolization. This is seen even in institutes in our country. So how do we solve it? How can you solve this issue? We all know, so as you also have emphasized, that the natural history of an AVM is adversely affected by a partial treatment without a strategy for final eradication. So how is it possible to tackle this issue? This is widely there throughout the country. Even that is seen in the Aruba trial. Even the Aruba trial brings out this very clearly, that more than nearly 60 of the 92 AVMs were managed wrongly, clearly, which does not fall into. So how can we tackle this?
The embolization for AVM, is not convincing still. Even for the interventionalist, they are not themselves convinced. Like for dural AV fistula, they are convinced. For aneurysm, they are hyper convinced. But for AVM, they are not convinced themselves. There are newer modalities of AVM embolization like venous embolization. Jack Morey is talking about, and he's showing some good results. Some AVMs, I will say small AVMs, can be entirely embolized. Means you can completely finish off the AVM. This is what the embolization people say. But those AVMs are relatively or quite simple AVMs to operate.
10% of it.
My feeling is, as I have mentioned, I don't like preoperative embolization at all. But sometimes they are already embolized one or more times, and then you have to operate, and that doesn't make your surgery remarkably easier. So if the patient comes to you first time, if it comes to me first time, first thing is you should have confidence in your own self. And second thing is you should instill the confidence in the patient and the family. So it is a difficult job. It is not a simple situation. You can, you cannot, you have to be absolutely sure as to what you are doing.
A question for Ravi, sir. That is, what would be our upper age limit for choosing an unblood AVM for surgery, grade 3? Grade 3A. Non-eloquent, large.
I've done up to 60 years.
Why, sir? Any basis for the 60?
No, that's not a hard and fast rule.
I mean grade 3A, where you may not get a deficit.
Correct. I've done it. My oldest patient where I've done is 60 years old patient. That is coincidental. I'm not sure what is the appropriate age limit for elderly. Of course, very advanced age, you wouldn't definitely do any kind of intervention for a unbled asymptomatic AVM. I'm not sure if there is an upper age limit for doing intervention for elderly.
This becomes a strong question if you're working in the private sector, where you can really take up a elderly patient for an AVM surgery. Now, for our anastomosis, to Dr. Suri, do you think there must be a specialized anastomosis surgeon who does not do anything else? There is such people exist in some regions of the world, particularly in Europe. There are a few plastic surgeons who do that. They are available in theaters to do liver transplant. The next day they will go for a pancreas transplant. And they sometimes even help a cardiac surgeon with a difficult one. Do you think there's a role for such a surgeon in India?
Yeah, for the neck anastomosis, yes, but for the brain anastomosis, no, because I deal with my cardiac surgeons, then and the high flow bypasses, and they're very good till the neck. They're still 7.0, 6.0, 7.0, they're very good because they work on the loop. The moment microscope comes, they cannot work on the microscope. It's impossible for them to come from the loop to the microscope.
Yeah.
And we can work remarkably on the microscope.
It is possible for them to train. There are the 12O surgeons, the 12O surgeons who do digital.
Yeah.
Digital for kids who do with a microscope. That is the MM70, I think. That's the Mitaka.
Yeah.
Which is...
My plastic surgeons do it, but
yeah,
the diameter of the vessels are still, it's 1.5 mm. I work with Dr. Khajanchi.
With digital vessel is less than 1 millimeter.
Yeah. But the muscle is good. Our M2, M3 muscles are not good. They're just flimsy.
Okay, you feel...
You take a 10-0 stitch and it's a bit of pressure. Initially, I used to use the needle holder. Now I use a simple forceps. It just tears through.
Okay, you feel that within the brain, sir?
Then, this is a question directed to Dwarka. A very nice demonstration about a high flow bypass. I have a question for you. You have said that you have changed from a continuous suture to interrupted suture for your high flow bypass. The problem which I faced during a high flow bypass was that the entire, the stream of from the ICA comes directly to the intracranial blood vessel. And if there is even a small rent, then, the entire thing gets flooded. So unless it is totally watertight, the anastomosis is totally watertight, it doesn't work. Because, in a low flow bypass, if you put some Surgicel, gel foam, pressure, it will work after some time. The bleeding will stop. But it doesn't happen with a high flow bypass.
Sir, point well taken, but we are not doing the single interrupted suture, sir. We are doing the figure of 8 sutures. So what happens is for the anastomosis, between the heel stitch and the toe stitch, we needed around 6 stitches, which used to take a longer time. And somehow the continuous sutures actually is good, but it had a tendency to get caught in the clips and all that. So what we're doing is we're doing a figure of 8 stitch, which I need to just take 3 knots. 3 times I have to knot. So it brought down the anastomosis time significantly and took away a lot of issues with the sutures getting stuck in the clips and all that. So, I mean, you can still do a continuous suture. We used to do it, but now I find this is more time saving and convenient, especially since our surgical assistants, they keep on getting changed and they might not have that much exposure to the high flow bypasses. So
Again, I
just
can put a state add a comment to that. I think Dr. Dwarka is absolutely right. That's the problem with microscope and loops. Because the neck anastomosis is actually done under 6O. It's simpler for you to be on the loop and play around with your stitches and your nurses squirting some hep saline on your hands and all that stuff. It never, but when you're under microscopes, it becomes difficult. But if you're training with them, then it's good.
Can I make a comment?
So I just
because I don't do that low flow bypass because I'm not trained for that. I have one plastic surgeons who actually been doing, because they do this free transfer, free muscle transfer, no free graft. And they do it, actually he does my MCA anastomosis with 11O. And they always work with microscope. They don't work with
plastic surgeons do. The rest of them don't do.
There are plastic surgeons, as you said. They are very good in anastomosis. And I'm sure with the people who don't do it, they need a bypass for patients, we can definitely take their help.
Some of them can be adapted into.
So for children below 5 years, 4 years, we have shifted also to 11-0 sutures. It's more flimsier. It takes a lot of breakages and it's more expensive, but it's a much a nicer material to handle. So below 5 years, we're also using a 11-0 bypass, 11-0 sutures.
The problem with 11-0 Dwarka, I've used 11-0. 11-0 breaks very fast. And even if you put the suit, if you need at least 4 or 5 knots. 10-0, 3 knots is good enough. If you put less than 3 knots in 11-0, it just become loose. And suddenly you realize that it's leaking from there. So 10-0 is.
Yes, sir.
And it
So we
breaks
had a
very fast.
discussion with Johnson & Johnson. Apparently, they give a different suture material to the plastic surgeons. So
Now, Nimhan's names are not allowed Johnson & Johnson. You have to work with Healthy and Make in India, MII.
Johnson says they have a suture.
No, Johnson
12O, which needs only 2 knots.
No J&J for government institutes. MII.
A question for Dwaraka. Do you think that sometimes you see a high flow bypass getting occluded on day 3? Suddenly you have a big catastrophe. Now, do you think multiple low flow bypass will substitute for a high flow? Do you think it will supply the perforated territory also?
Sir, I think that's what Dr. Suri said, double barrel bypass for MCA. If it works, I think it should work, but I prefer a high flow bypass because it is more physiological. But Dr. Suri showed excellent results with the double barrel MCA anastomosis. I don't see any reason
I think
why
algorithm is very simple. If you want to replace the complete circulation of internal carotid ICA or the MCA, complete circulation, and there is no cross circulation, then you have to, the only reliance is a high flow bypass. But the problem is, I learned from the Japanese that going only for the high flow bypass, you actually exclude that area for at least 25-30 minutes for that type anastomosis time. Low flow is faster. So a better one low flow on that M3 stem and an M2 high flow, which actually takes care of the anastomosis time and all that. And then starting your aspirin faster. Maybe on the next day you start your aspirin. I always give, how much heparin you give, Dwarka? I give 5,000 units at the anastomosis time.
So we have come down to 3,000 units, 2,500, 3,000 units. We have come down to
Yeah,
that.
and 5,000, it starts oozing a bit.
5,000 units starts oozing. The muscles especially ooze a lot.
Yeah.
Then we have had to use a lot of fibrin glue on the muscle surface to stop the ooze. The problem is the EDH and the hematoma it creates. We haven't, sir, coming back to Dr. Abraham's question, Matthew's question, we haven't had any blockages after 48 hours. All the blockages we've had have been immediate post-op, I mean, within the first 2 to 6 hours.
Yeah.
So that's
One question. Suppose you have done a high flow bypass.
Ravi wants to ask something.
Yeah. Sir, Ravi sir.
This question is to Dwarka. There is a publication from your institute, Dwarka, saying reef knot, only 2 throws are required and they shortens the bypass time. So is that what you people use? You showed figure of 8.
No, that is for the low flow bypass.
Nupur.
Even I use only two stitches are more than enough actually. For the heel and the toe stitch, I use 3 knots. For the others, I use 2 knots.
Dwarga, suppose you have done a high flow bypass. You have given heparin. You see two venous infarcts, two contusion-like things evolving on your frontal, and maybe in the hyperhiatal region. Will you go and do a decompressive craniotomy immediately, or you will do a DSA and follow up or watch? Do you think that the mass effect producing lesion will alter the functioning of your bypass?
That's a good question. I mean, we haven't had the problem, Matthew, so I haven't handled that post-op venous infarct. I mean, until the patient has symptoms of raised ICP or progressive midline shift, we don't jump in to operate these patients. Patients on heparin, it's a big mess. So it's better to be, we use a lot of, clinical correlation is necessary before we just operate on a radiological diagnosis.
Yeah, I think that's a very good question. If you have brain swelling starting at the beginning of the anastomosis and it keeps on increasing, and heparin is already in, you must suspect the presence of a small venous infarct. And I do not keep the bone flap in that surgery. I keep it in the bone bank. It comes after a month. I put it back.
Okay. Thank you. Are there any more questions from the audience? Okay. If there are no more questions, we'll conclude this session. Thank you, everybody.
Thank you, sir.
With this, we come to the end of our session. Before we leave,
We'll have a group photograph. So give me 5 minutes because we do not have time. They have to arrange the stage also. So I'll get the chairs put and then we'll announce those people and then rest of us will stand behind. Okay. So just have 15 chairs put rapidly. Come on. Get 15 chairs put. Come on. Wait, photo here. Chairs. Come. Yeah, डाल दो यार. Somebody take this off. So easy if we have election. Yeah, that is Dr. Sari's idea.